This will be the GI system of Pance Prep Pearls. We'll start off with ingestion of toxic substances. First, acetaminophen. So acetaminophen toxicity overwhelms the enzyme capability of the liver, which decreases glutathione and leads to hepatic necrosis. They'll have anorexia, nausea, vomiting, diaphoresis, right upper quadrant pain, jaundice, and coagulation abnormalities, as it has to do with the liver. So as such, you should get a PT, PTT, INR, urinalysis, EKG, LFTs, and importantly for acetaminophen, follow the nomogram, and that's with the APAP levels. And importantly, you can do activated charcoal, but only within the first 1 hour of ingestion, and this is not stomach pump, just the activated charcoal. And also NAC, N-acetylcysteine, is the antidote for acetaminophen overdose, and this is a glutathione substitute. Next, for salicylates like aspirin, Pepto-Bismol, and oil of wintergreen, this leads to a respiratory alkalosis due to the respiratory stimulation, which leads to a high anion gap metabolic acidosis, which occurs later. So alkalosis to a metabolic acidosis. For CNS, you could also have seizures, coma, encephalopathy, and also renal problems. For the workup, you want to get salicylate levels, work up the metabolic acidosis, know that that's a common cause of salicylate overdose, and hypokalemia from increased urinary K+ loss. So the management of a salicylate overdose, you want to do resuscitation, of course, with your ABCs, then GI decontamination with activated charcoal, gastric lavage, importantly with sodium bicarb, alkalinization of the urine, also glucose to help with the CNS symptoms, IV fluids, and hemodialysis last line if severe. So again, sodium bicarb important for the alkalinization, and GI decontamination with activated charcoal or lavage for salicylates. For bases, the examples are oven cleaner, drain cleaner, and bleach. You want to worry about esophageal perforation or gastric perforation, respiratory distress as well. An EGD can be done. And remember, damage occurs in seconds with bases. So it's just supportive care and emesis prevention. So if they start to vomit after they've ingested a base, this is actually a worse prognosis for them. You could dilute it with milk or small amounts of H2O, and it's a gastric lavage or acids are contraindicated. They will worsen the symptoms in a base overdose. Hydrocarbons like gasoline, benzene, petroleum, etc. You want to worry about aspiration pneumonitis, and you want to do supportive treatment, antibiotics if pneumonia develops, and you also want to avoid emetics or lavage. For anticholinergics like antihistamines or atropine and TCAs as well. Anticholinergics have antimuscarinic effects. For here, this sympathetic stimulation, such as hyperthermia, no sweating, tachycardia, hypertension, hot, flushed, dry skin and mucous membranes, mydriasis and visual changes, urinary retention and ileus, so all the anti-sludge effects, salivation, lacrimation, urination, defecation, and emesis. So all the opposite of those effects are going to happen with that anticholinergic overdose. For EKG, with TCAs especially, you'll have a wide QRS and a prolonged QT. You could also have heart block, asystole, and other dysrhythmias. This is due to the sodium channel blocking effects of the TCAs. So prolongs that time to repolarization. Activated charcoal can be done for anticholinergics as well as whole bowel irrigation. Physostigmine can also be used. It's an acetylcholinesterase inhibitor, so it prolongs whatever choline's still in the synapse, as this is an anticholinergic overdose. For TCA toxicity, supportive and sodium bicarb as well as the antidote. And remember, like we said, bicarb can be used in a salicylate overdose as well. And diazepam for seizures, as TCAs have a CNS toxicity as well. For cholinergics, such as organophosphates, insecticides, and pesticides, this is the opposite. So this is your sludge, salivation, lacrimation, urination, defecation, and emesis. Again, increased salivation, lacrimation, diarrhea, emesis, meiosis as well. Cardiovascular, you may see bradycardia or hypotension. And for respiratory, bronchospasm, rhinorrhea. And those are the muscarinic effects. There's also nicotinic effects, such as mydriasis, tachycardia, weakness, hypertension, and fasciculations. Children usually present with nicotinic side effects as well. garlic breath can also be seen with arsenic. So you want to get a blood glucose level and a cholinesterase level. And the treatment and management or antidote is atropine plus pralidoxime. Atropine is an anticholinergic, and pralidoxime reactivates the cholinesterase enzymes. So that basically will start to clear out all the extra choline in the synapse. Okay, and for iron, an iron overdose will cause GI, nausea, vomiting, abdominal pain, shock, coagulopathy, as well as a red urine. For management, emesis with gastric lavage is important. Whole bowel irrigation, hemodialysis last line, but the most important step for iron overdose is deferoxamine. Deferoxamine for iron overdose. So now we'll just go into some poisons, their treatment, and some notes about them. So TCAs, again, tricyclic antidepressants. The treatment is bicarb, which may be helpful in that cardiotoxicity. And for note, cardiotoxicity is the prolonged QT interval for those TCAs. For amphetamines, the treatment is ammonium chloride. So when I think amphetamine, I think ammonium chloride. For opioids, naloxone or naltrexone are the treatment, and they may be needed if severe respiratory depression. For benzos, flumazenil is the antidote, but it's only used in severe cases. So benzos, flumazenil. For beta blockers, glucagon is the treatment. It's only given as an IM injection. For theophylline, beta blockers are the antidote, and an overdose symptoms usually lead to increased sympathetic activity. So remember, theophylline is kind of like caffeine. So it would make sense that you'd have that increased sympathetic activity, and that beta blockers would be a treatment for it. Digitalis toxicity, digibind is the treatment. You also might need IV magnesium. Methemoglobin, methylene blue is the treatment, or vitamin C. TPA and streptokinase, aminocaproic acid is the treatment. For warfarin, vitamin K and FFP, cryoprecipitate if continued bleeding as well, and especially if an INR is over 10. So ROSH asks a ton of questions about warfarin overdose and what you need to do with that. And the INR of 10 is an important marker to know whether you need to transfuse, or you can just omit the next dose, or you should give vitamin K. So for heparin, protamine sulfate is the treatment, and for ethylene glycol, which is antifreeze, an IV ethanol infusion is the treatment. So next is some more common GI issues, such as acute cholecystitis. So acute cholecystitis, this is inflammation and infection of the gallbladder due to obstruction of the cystic duct by the gallstones itself. The most common bugs are E. coli, and Klebsiella is the second most common. Also other gram-negative enteric organisms, so E. coli and Klebsiella. Clinical manifestations of acute cholecystitis, continuous right upper quadrant or epigastric pain. It also may be precipitated by a fatty food or a large meal. It's associated with nausea, vomiting, as well as guarding. On physical exam, they'll have fever, it's often low grade, and an enlarged palpable gallbladder. Also no Murphy's and Boas sign. Murphy's sign is that positive right upper quadrant pain or inspiratory arrest with palpation under the gallbladder. So you're irritating that phrenic nerve under there. And that's a similar nerve with Boas sign as well. Phrenic nerve irritation, but Boas sign is referred pain to the right shoulder or that subscapular area. For diagnosis, CBC and ultrasound to start. So ultrasound is that best test of choice in the beginning. Thickened or distended gallbladder you'll see with pericholecystic fluid classically. And you may also have a sonographic Murphy sign, which is pushing with the ultrasound probe, where you would push under that right costal margin, where you would see Murphy sign anyways. CT scan is alternative to ultrasound, and it can also detect complications. And for labs, again, increased white blood cells, leukocytosis with a left shift, you'll see. Increased bilirubin, increased alk-phos, and increased LFTs as well. A HIDA scan is the most accurate test as well. Cholecystitis is present if there is no visualization of the gallbladder. So that HIDA scan is the most accurate test. And for management of acute cholecystitis, you'll do MPO, IV fluids, antibiotics. You want some gram-negative and some anaerobic coverage, so ceftriaxone for gram-negative and metronidazole for those anaerobes. So ceftriaxone, metronidazole, IV fluids, MPO, and then cholecystectomy, usually within 3 days. You can do a laparoscopic cholecystectomy, which is preferred whenever possible. Cholecystostomy, which is a percutaneous drainage of the gallbladder if the patient is non-operative. So in acute cholecystitis, also of note, there's probably not going to be jaundice because there's no obstruction of the hepatic duct or common bile duct. This is still within the gallbladder itself. So it's not backing up. So none of the bilirubin is backing up to the liver when we'd see jaundice. Next will be acute acalculous cholecystitis. Acute acalculous cholecystitis is an acute necroinflammatory disease of the gallbladder not due to gallstones. It accounts for 10% of acute cholecystitis. So very sick patients with gallbladder inflammation, but no stone and no calcium. So gallbladder stasis is the pathophysiology and ischemia, leading to local inflammation, inflammatory reaction in the gallbladder wall itself. It leads to a concentration of bile salts, gallbladder distension, secondary infection, perforation, or necrosis of the gallbladder tissue. And again, those risk factors are current hospitalization in critically ill patients. Manifestations: fever, leukocytosis, jaundice, sepsis, and vague abdominal discomfort. For diagnosis of acute acalculous, based on the clinical symptoms in the setting of supporting imaging and the exclusion of an alternative diagnosis. Ultrasound is the initial test of choice, in which you'll see a distended gallbladder with thickened walls and again pericholecystic fluid without calcifications, however, hence the name acalculous cholecystitis. Contrast-enhanced abdominal CT if diagnosis remains uncertain after ultrasound, and a HIDA scan can be performed if the diagnosis remains uncertain after a CT. Management is supportive care, IV fluids, bowel rest, pain control, correct electrolytes, and also broad-spectrum antibiotics. Next, for chronic cholecystitis, this will be fibrosis and thickening of the gallbladder due to chronic inflammation of this chronic inflammatory cell infiltration of the gallbladder and evidence of histopathology. The presence of chronic cholecystitis does not correlate with symptoms, and it's almost always associated with gallstones. Acute ascending cholangitis, and also there'll be images of the biliary tract as it connects to the liver, pancreas, and duodenum, so you can see exactly where these pathologies are occurring. Acute ascending cholangitis. Acute ascending cholangitis is a biliary tract infection secondary to an obstruction of the common bile duct, such as due to gallstones or malignancy. Again, the etiology is most commonly gram-negative enteric organisms that ascend from the duodenum, such as E. coli most commonly, also Klebsiella, which is the second most common, and other gram-negatives and anaerobes as well. Clinical manifestations is the classic Charcot's triad, which is fever and chills, plus right upper quadrant pain, plus jaundice. So right upper quadrant pain, fever and chills, and jaundice. And then you can also add on Raynaud's pentad, which is an additional hypotension or shock, and altered mental status. For diagnosis, you'll see leukocytosis again on labs, may have a left shift, and a cholecystatic pattern, increased alk-phos and GGT, increased bilirubin that's greater than the increase in ALT and AST. So a very high increase in that alk-phos and GGT. Ultrasound is the initial test of choice, and MRCP is the most accurate imaging test. Although an MRCP is not as good as an ERCP because an MRCP is only diagnostic and not therapeutic. Cholangiography is the gold standard via ERCP, so basically is an ERCP, in endoscopic retrograde cholangiopancreatography, or PTC, percutaneous transhepatic cholangiography. These are usually performed once a patient has been afebrile or stable for 48 hours after IV antibiotics. So an ERCP goes in to break up the stone or pass it through the rest of the GI tract. It can also do a sphincterotomy so that you can clear out that area. So initial management of acute ascending cholangitis are IV antibiotics followed by common bile duct decompression and stone extraction once they are stable, and again that's by ERCP. For antibiotics you can do Unicin, which is ampicillin sulbactam, which is broad spectrum, Zosyn, piperacillin tazobactam, again broad spectrum, ceftriaxone, a gram-negative coverage, and metronidazole for anaerobic coverage. You can also substitute a fluoroquinolone plus metronidazole, and ampicillin plus gentamicin, ampicillin gram-positives and gentamicin gram-negatives. For common bile duct decompression and stone extraction, again, the ERCP with a sphincterotomy, that's the sphincter that opens from the pancreas and common bile duct into the duodenum, the sphincter of Oddi, usually performed once the patient has been afebrile or stable for 48 hours after IV antibiotics. And open surgical decompression plus a T-tube insertion can also be done. And eventually, the patient should, of course, undergo an elective cholecystectomy. So moving to cholelithiasis, this is simply gallstones in the biliary tract, usually in the gallbladder itself, without any inflammation. So this is usually a complication including choledocholithiasis, acute cholangitis, and acute cholecystitis. Cholelithiasis can lead to all these three things. Types of gallstones. Cholesterol is the most common type of gallstone itself, mixed and pure, 90%. Pigmented are 10%. Black stones are associated with hemolysis or alcohol-related cirrhosis, as black is the color of hemolyzed red blood cells like we see in melena. And brown stones increase in Asian population, parasitic or bacterial infections, which are brown stones. Risk factors for cholelithiasis are the 5 F's, fat, fair, female, 40, and fertile, as well as OCP use due to the increased estrogen, Native Americans, bile stasis, chronic hemolysis, which would probably lead to those black stones, cirrhosis, infection, rapid weight loss. And the rapid weight loss is not due to the weight loss itself, but the change in the normal foods. So if the patient is constantly used to creating so much bile in order to digest a lot of fats, if less fats are being formed, the body still thinks there's a lot of bile that needs to be put out. So all that bile is just going to be sitting in the gallbladder and outweighing the ratio. So inflammatory bowel disease can also be a risk factor. Total parenteral nutrition, TPN, fibrates, remembering that gallstones are a side effect of fibrates, and increased triglycerides as well. Clinical manifestation, most are asymptomatic, may be an incidental finding. Biliary colic, which is episodic, abrupt, right upper quadrant, or epigastric pain, resolves slowly and lasting typically 30 minutes to hours. It may be associated with nausea and a precipitating fatty food ingestion or a large meal. For diagnosis, ultrasound is the initial test of choice. You can also do a CT or MRI. And for management, you can observe if they're asymptomatic, or ursodeoxycholic acid may be used to dissolve the gallstones, but it takes 6 to 9 months for this, and an elective cholecystectomy should be done. For choledocholithiasis, this is gallstones in the common bile duct itself, which can lead to cholestasis due to the blockage. Clinical manifestations are a prolonged biliary colic, which leads to right upper quadrant pain or epigastric pain, again, nausea and vomiting, and the pain is usually more prolonged due to the presence of the stone blocking the bile duct. So it's not like cholelithiasis where the stone kind of bobs its head out of the gallbladder and comes back in during the meal and after the meal. This is the gallbladder is stuck in the common bile duct, so it has no chance to really move from there. So it's causing that more constant pain. And on physical exam for choledocholithiasis, they'll have that right upper quadrant or epigastric tenderness, as well as jaundice. For diagnosis and labs, an elevated AST and ALT due to the blockage and backing up, increased alk-phos and GGT in a cholestatic pattern, especially. Ultrasound is the initial imaging of choice, and an ERCP is the diagnostic test of choice. An ERCP can be a diagnostic as well as therapeutic, which allows for stone extraction, often obtained after an ultrasound. MRCP, magnetic resonance cholangiopancreatography, and endoscopic ultrasound may be used in some patients with intermediate risk, determined by labs and transabdominal ultrasound. For management, ERCP stone extraction preferred over a laparoscopic choledocholithotomy. Next, we'll move to neonatal jaundice. So this is a yellowish discoloration of the sclera, skin, and the conjunctiva due to elevated plasma bilirubin in a newborn. It's usually a transient and mild condition, but in severe cases may lead to kernicterus, which is cerebral dysfunction and encephalopathy in the newborn. Physiologic jaundice presents on days 3 to 5 of life, and bilirubin levels fall in about 50% of the neonates during the first week of life. So in the first 5 days of life, the liver is still learning how to process this bilirubin. For etiologies of neonatal jaundice, physiologic jaundice is a transient decrease in the first 3 to 5 days in UGT enzyme. UGT enzyme is the enzyme that conjugates bilirubin. It could also be breastfeeding failure, caused by insufficient breast milk consumption, which leads to inadequate amounts of bowel movements to excrete the bilirubin from the body. In breast milk jaundice, the infant liver is not mature enough to process the lipids yet, so it occurs around the 4th to 7th day of life. Mothers should continue to breastfeed, however. In pathologic jaundice, you could have Crigler-Najjar syndrome, which is prehepatic, Gilbert syndrome, which is prehepatic, cretinism, hemolytic anemia, Dubin-Johnson syndrome, which is posthepatic. Pathologic causes may occur in the first 24 hours of life and persist over 10 days to 2 weeks. Bilirubin increases over 5 milligrams per deciliter per day is associated with a bilirubin greater than 12 milligrams per deciliter in a term infant. Conjugated bilirubin over 2 or over 20% of the total bilirubin would be pathologic jaundice. For clinical manifestations of neonatal jaundice, well, there will be, of course, jaundice, yellowing of the skin, sclera, and conjunctiva. And in neonates, jaundice usually progresses from head to toe with increasing bilirubin levels. Typically, it's a bilirubin of over 5. Kernicterus, again, is that cerebral dysfunction and encephalopathy due to the bilirubin deposition in brain tissue. It can manifest as seizures, lethargy, irritability, hearing loss, mental developmental delays, and it's associated with bilirubin levels greater than 20. For workup, you want to do bilirubin Coombs test as well, which distinguishes between immune-mediated, such as ABO incompatibility, from non-immune-mediated hemolytic disorders. You could do a blood smear, LFTs, and an ALK phos. For management, no management is needed in physiologic jaundice, but phototherapy is the initial management of choice for all types. So that's phototherapy. So for term infants, 38 weeks gestational age or longer, without risk factors, phototherapy is initiated based on total bilirubin. 24 hours of age, greater than 12, 48 hours of age, greater than 15, 72 hours of age, greater than 18. So the values can be used in preterm or at-risk infants. So again, the rates change with age at 12 milligrams at 24 hours, 15 milligrams at 48 hours, and 18 milligrams at 72 hours. Exchange transfusion can be done in severe cases like hemolysis, ABO incompatibility, or RH isoimmunization. IVIG may be needed with isoimmune hemolysis as well. So we'll go further into some of those liver syndromes. Next will be Dubin-Johnson syndrome. Dubin-Johnson syndrome is a hereditary conjugated direct hyperbilirubinemia due to direct or decreased hepatocyte excretion of the conjugated bilirubin due to a gene mutation in MRP2. So think direct Dubin and dark liver, because this has a characteristic dark liver. So Dubin-Johnson is posthepatic, or also known direct and conjugated hyperbilirubinemia, and Gilbert and Crigler-Najjar are prehepatic. So Gilbert and Crigler-Najjar are prehepatic, Dubin-Johnson posthepatic. Clinical manifestations usually asymptomatic. They may have some mild icterus. And for diagnosis of Dubin-Johnson, it's mild, isolated, conjugated, direct hyperbilirubinemia, often between 2 to 5 milligrams, but can increase with concurrent illnesses, pregnancy, and OCPs as well. And classically on biopsy, you'll have the grossly black liver with dark granular pigments in the hepatocytes. So Dubin, direct, and dark liver. That grossly black liver on biopsy. Typically no management is needed. And also note Roeder's syndrome, which is similar to Dubin-Johnson but milder in nature, is associated with conjugated and unconjugated hyperbilirubinemia and not associated with a grossly black liver on biopsy. Crigler-Najjar syndrome is a hereditary, unconjugated, indirect hyperbilirubinemia. The pathophys of this one, Crigler-Najjar, is decreased activity of the glucouronyl transferase, UGT, enzyme needed to convert indirect bilirubin to direct bilirubin. So again, Gilbert and Crigler-Najjar are prehepatic, and posthepatic is Dubin-Johnson. So for Crigler-Najjar, there's two types, type 1 and type 2. Type 1, there's no UGT activity at all, and type 2 is Arias syndrome, which is very little UGT activity, 10% or less of the normal. So this is kind of analogous to type 1 diabetes and type 2, or type 1 in its honeymoon period, where type 2 is still having a little bit of that insulin left, and type 1 is having no activity at all. So again, for Crigler-Najjar, type 1, no activity at all. Type 2, still a little bit left, 10% of less of normal. For clinical manifestations, there's type 1, which you'll have neonatal jaundice with severe progression in the second week, leading to kernicterus, which is bilirubin-induced encephalopathy, which will give hypotonia, deafness, lethargy, ocular motor palsy, and it could be potentially fatal. And type 2, because there's still a little bit of enzyme activity left, it's usually asymptomatic, and it may be often an incidental finding on routine lab testing. For a diagnosis, isolated, indirect, unconjugated hyperbilirubinemia, and otherwise normal LFTs. Type 1 will be an indirect bilirubin from 20 to 50. Remember, no UGT activity at all, and a type 2 will have an indirect bilirubin just between 7 to 10 because there's still a little bit of UGT left. But again, it may increase during illness and fasting as it puts stress on the body. So management of type 1 is phototherapy, plasmapheresis, and liver transplant for definitive. And management of type 2 is phenobarbital, actually. Treatment usually isn't required, however, for a type 2, but phenobarbital is important to know. It's been shown to increase UGT activity, and type 1 is not responsive to phenobarbital because there's no UGT activity at all. So phenobarbital increases in neonates the UGT activity. So pheno, E-N-O, switch it around for neo. So pheno kind of reminds you of neonates. So phenobarbital is for neonates to increase the UGT activity only in type 2 Crigler-Najjar syndrome. And for Gilbert syndrome next, this is a hereditary, unconjugated, indirect hyperbilirubinemia. It's relatively common at 5 to 10% of the U.S. total population as well. Pathophys is a reduced UGT activity, similar to a type 2 Crigler-Najjar, at 10 to 30% of normal, and decreased bilirubin uptake, leading to increased indirect bilirubin. UGT enzyme is responsible for the conjugation again. Manifestations of Gilbert's is transient episodes of jaundice during periods of stress, like fasting, alcohol, and illness. And for diagnosis, it's usually an incidental finding with slight increase in isolated indirect bilirubin levels, otherwise normal LFTs again. And no treatment is typically needed, and hereditary unconjugated indirect hyperbilirubinemia is relatively common at, again, 5 to 10% of the US population. So now we'll go over some patterns of liver injury. We'll go through hepatocellular damage, cholestasis, and liver synthetic function. So hepatocellular damage is increased ALT and AST primarily. ALT is more sensitive for the liver than AST. So ALT, liver, is more sensitive. Cholestasis, increased levels of alkaline phosphatase with increased levels of GGT. Increased bilirubin, greater than levels of increase in ALT and AST. So GGT, alk-phos, and increased bilirubin is more of a cholestatic pattern. For the liver synthetic functions, this is the prothrombin time and the albumin. The prothrombin time depends on the synthesis of coagulation factors, also vitamin K dependent coagulation factors, 2, 7, 9, and 10. And remember, warfarin works on this pathway. This is the PT pathway. PT, prothrombin time, is an early indicator of severe liver injury and prognosis, better than albumin. Prolonged PT is seen in 80%, of the liver's protein synthesizing ability is lost. So you still need to get down the first 80% until you see a marked decrease in the PT, which prolongs the ability to clot. So albumin is a useful marker for overall liver protein synthesis, and its levels also decrease with liver function decrease. So that's albumin, PTT, as the liver synthetic functions. So we'll go through some disorders and the laboratory patterns of liver injury. Alcoholic hepatitis, you'll have an AST over ALT over 2 times. So the AST to ALT ratio is greater than 2 in alcoholic hepatitis. So the AST levels are usually under 500, however. And AST is found primarily in the mitochondria, so alcohol causes direct mitochondrial injury, leading to an increased ALT. As in its opposition, viral, toxic, or inflammatory processes, the ALT is going to be greater than the AST. Think ALT for liver, and the ALT and AST are usually over 1,000, however, for a viral or toxic cause. Usually an acute viral hepatitis like AB, but rarely C due to its chronic nature. And of course, also chronic viral hepatitis like B, C, D, and also a mild increase in ALT and AST, but this is usually under 400. So in those chronic viral conditions, the LFTs will be more ALT elevated than AST, but it will still be under 400. But the acute conditions, ALT and AST over 1,000. And again, alcoholic hepatitis, AST more than ALT. Biliary obstruction or intrahepatic cholestasis, increased alk phos, like we said, increased ALP with increased GGT, suggest hepatic source or biliary obstruction. GGT is the most sensitive indicator for biliary injury, and if increased ALP without increased GGT, look for other sources other than liver injury, like the bone or the gut. Remember Paget's disease of the bone or rickets. For autoimmune hepatitis, you'll see an increased ALT over 1,000, positive ANA, positive smooth muscle antibodies, and an increased IgG. It also responds to corticosteroids or azathioprine. That's autoimmune hepatitis. Now we'll move to constipation. Constipation is, of course, infrequent bowel movements under 2 times a week, straining, hard stools, feeling of incomplete evacuation. The etiologies of constipation could be disordered movement of the stool through the colon or the rectum, usually the proximal GI tract is intact, or slow colonic transit overall, which could be idiopathic, motor disorders like colorectal cancer, diabetes, or hypothyroidism, or adverse effects of many drugs like verapamil, which, calcium channel blockers block the calcium from contracting the smooth muscle in the first place, as well as opioids, of course, or in neonates an outlet delay like Hirschsprung's disease. So we'll go through some of the different drugs you can use in constipation and some of the mechanisms. So fiber, the mechanism of action is retaining water and improves GI transit. There's also bulk-forming laxatives like psyllium, methylcellulose, polycarbophil, and wheat dextran. And the mechanism of these bulk-forming laxatives are to absorb water and increase the fecal mass itself. And dietary fiber and bulk-forming laxatives are the most physiologic and effective approach to constipation. There's also osmotic laxatives like polyethylene glycol, PEG, lactulose, and sorbitol, as well as some saline laxatives like milk of magnesia and magnesium citrate. So for osmotic laxatives, the mechanism is to retain H2O in the stool. The osmotic effect pulls the H2O into the gut. It could lead to flatulence and bloating as well. That's for PEG, polyethylene glycol. For lactulose, it's a synthetic disaccharide sugar that's not absorbed, and sugar has a high osmotic gradient, so it pulls water into the gut. And this type of sugar, lactulose, is not absorbed. And also note that it can be used in hepatic encephalopathy as well. Sorbitol is a synthetic sugar as well, which is good and cheap to be used. And saline laxatives like milk of magnesia and magnesium citrate have the adverse effect of hypermagnesemia, especially in chronic renal disease. And lastly, there's also stimulant laxatives like bisacodyl or senna. So senna is docusate sodium. The mechanism of action of the stimulant laxatives are to increase acetylcholine, regulated GI motility, peristalsis, and alter electrolyte transport in the mucosa. So increasing acetylcholine activity leads to increasing of the gut motility. And a way to remember this is PMPW for psyllium methylcellulose polycarbophylline wheat dextran, and also PEGLs for polyethylene glycol, lactulose, sorbitol, and saline. Saline laxatives, which are again the milk of magnesia and magnesium citrate. And for fecal impaction, which will be next. This is of course copious amounts of immovable solid bulk of stool in the rectum. This is due to decreased mobility and inability to sense and respond to the presence of stool in the rectum. For diagnosis of impaction, DRE, and abdominal radiographs. For management, disimpaction and colon evacuation, followed by a routine bowel regimen to reduce recurrence. Digital disimpaction followed by a warm water enema with mineral oil is helpful. You could also use polyethylene glycol, which can be employed after disimpaction of the distal colon, either orally or NG tube. And other options for disimpaction, if both these are unsuccessful, include a water-soluble contrast enema under fluoroscopy, as well as anesthesia to relax the anal canal and pelvic floors, and abdominal massage. You can identify and reduce and eliminate the causes of constipation in the first place as the best management. And remember, that's the digital disimpaction followed by a warm water enema with mineral oil. So next will be the anorectal abscess and fistulas. The abscess often results from bacterial infection of anal ducts or glands. Staph aureus is the most common. Of course would be E. coli as well, Bacteroides, Proteus, and Strep. So it makes sense, Staph aureus, the most common bug on the skin, as this is an anorectal abscess around the skin, and E. coli, which is the most common in the GI tract. So it's most commonly one of those two. And the posterior rectal wall is the most common site. So this is the same thing as a fissure as well, the posterior rectal wall. For a fistula, this is an open tract between the two epithelium-lined layers. It's especially seen with deeper abscesses. And for a fistula, it may cause anal discharge and pain. So if they say discharge in the question stem, it's more likely a fistula as opposed to an abscess. Whereas an abscess will present with anorectal swelling, rectal pain that is worse with sitting, coughing, and defecation. Maybe febrile as well. For an abscess, they'll have that induration and the fluctuance on examination. For management of these either abscess or fistulas, you want to do incision and drainage, which is the mainstay of treatment, followed by WASH, W-A-S-H, warm water, analgesics, sitz baths, and high fiber diet. Antibiotics are not usually required in simple cases, however. Next, for anal fissures, this is a painful linear tear or crack in the distal anal canal. Etiologies are low fiber diets, passage of large, hard stools, constipation, or other anal trauma. Clinical manifestations are severe, painful rectal pain and bowel movements, causing a patient to refrain from defecating, and also bright red blood per rectum will be seen. So they want to refrain from defecating. On physical exam, it'll be a longitudinal tear in the anoderm that usually extends no more proximally than the dentate line, most common in the posterior midline, as in 99% of men and 90% of women. And also skin tags can be seen in chronic. So also a question is, do we see skin tags more common in ulcerative colitis or Crohn's? And it's Crohn's. So Crohn's and anal fissures are where we see skin tags around the anal area. Management, over 80% resolve spontaneously. Supportive measures can be done, which are the first line management, warm sitz baths, analgesics, high fiber diet, increased water intake, some stool softeners, laxatives, and mineral oil. Second line treatment would be topical vasodilators like nitroglycerin, although again with the headaches and dizziness as an adverse effect, also nifedipine ointment. Third line would be Botox injections at the internal sphincter. And surgery is last line, which is a lateral internal sphincterotomy, which is used in reserve refractory cases. Hemorrhoids will be next. Hemorrhoids are engorgement of the venous plexuses. There's internal, external. For internal hemorrhoids, they're graded on a scale of 1 to 4, and they originate from the superior hemorrhoidal vein and are proximal or above the dentate line. Internal hemorrhoids tend to bleed, but they are usually painless. so they bleed, but they are painless. Based on the degree of prolapse from the anal canal is how they're graded. Grade 1 does not prolapse, it's confined to the anal canal. It also, of course, will bleed with defecation. Grade 2 prolapses with defecation or straining, but spontaneously reduces back into place. Grade 3 prolapses with defecation or straining and requires manual reduction. And grade 4 is irreducible and may strangulate. So 1, no prolapse. 2, spontaneously reduces. 3, you have to manually reduce it. And 4, irreducible. There's also external hemorrhoids, which originate from inferior hemorrhoidal vein and are distal or below the dentate line. And external hemorrhoids tend to be painful, but they don't usually bleed. Painful and don't usually bleed for external. Risk factors overall are increased venous pressure, straining during defecation, constipation, pregnancy, obesity, prolonged sitting, cirrhosis with portal hypertension as well. So some clinical manifestations of hemorrhoids. For internal, you have that intermittent rectal bleeding again, which is most common. Painless, bright red blood per rectum, which is hematochezia, seen on the toilet paper, coating of the stools, or dispersed into the toilet water. They may have some itching, fullness, and mucus discharge. Uncomplicated internal, usually not tender and not palpable, unless they are thrombosed. And rectal pain may suggest a complication. For external, perianal pain aggravated with defecation. They may have a tender mass or skin tags as well. So again, remember, internal tend to bleed, but they're painless, and external are painful, but they don't bleed. For diagnosis, visual inspection, DRE, or fecal occult blood testing can be done. Anoscopy is the best for internal, and it allows for direct visualization and diagnosis of the internal hemorrhoids. You can also do a proctosigmoidoscopy or colonoscopy, which may be indicated for patients with hematochezia to rule out proximal sigmoid disease. And for management of these hemorrhoids, conservative treatment is first line. Again, high fiber diet, increased fluids, sitz baths, and topical rectal corticosteroids. Analgesics like lidocaine may be used for itching and discomfort or thrombosis. For procedures, if they have failed conservative management, debilitating pain, or strangulation, this is second line. Options include rubber band ligation, which is the most commonly used, sclerotherapy, or infrared coagulation. Excision of externally thrombosed hemorrhoids may be performed. So in ROSH, they always ask, what's the second line treatment for hemorrhoids? And they give you rubber band versus sclerotherapy, and the answer is rubber band ligation. So rubber band ligation is preferred over sclerotherapy for procedures for hemorrhoids. And for last, you can also do a hemorrhoidectomy for stage 4, or those not responsive to the aforementioned therapies. Surgical management is used for external hemorrhoids. Next will be diverticulosis. Diverticulosis, so first, diverticula are outpouchings due to herniation of the mucosa into the wall of the colon along the natural openings at the vasa recta of the colon. The left colon more commonly in incidence presents, and the right colon is more common location for bleeding itself. So the left colon, it's under much higher pressure as it narrows as it approaches the sigmoid. So risk factors are a low fiber diet, constipation, and obesity, importantly. Clinical manifestations of diverticulosis are usually asymptomatic, incidental finding, and lower GI bleeding in diverticulosis. Diverticulosis is the most common cause of acute lower GI bleeding. This is painless hematochezia in adults. For diagnosis, colonoscopy is the test of choice. So once the upper GI bleed has been ruled out, you need to do colonoscopy. So occasionally they'll ask, what should you do first, colonoscopy or rule out the upper GI bleed with an EGD? And it could be EGD to rule out the upper GI bleed prior to colonoscopy. And of course, this colonoscopy is diagnostic and therapeutic. Radionuclide imaging, such as the technetium-99 tagged red blood cell scan, can be used, and followed by arteriography is the next step if the bleeding is not visualized in colonoscopy. And also, you don't want to do a colonoscopy in diverticulitis, but you can do it in diverticulosis. In most cases, the bleeding stops spontaneously, And you may need to do resuscitation with large bore IVs, fluids, blood products, correction of the coagulopathies as well. Endoscopic therapy to control the bleeding if it is active, like epinephrine injections or tamponade. And asymptomatic diverticulosis can be followed on a high fiber diet with the use of bran or psyllium. And now we'll move to diverticulitis. And diverticulitis is different as it's microscopic perforations in the diverticulum, which leads to inflammation and a focal necrosis. This is considered complicated if it leads to bowel perforation, abscess, fistula, or bowel obstruction. The sigmoid colon is the most common area due to the high intraluminal pressure, and the onset of age is over 40 years. The clinical manifestations are left lower quadrant abdominal pain, most commonly, left lower quadrant tenderness, low-grade fever, may have nausea, vomiting, constipation, diarrhea, flatulence, bloating, changes in bowel habits as well. The physical exam is often normal, and a tender mass may be present due to inflammation or abscess. Diagnosis: a CT scan is the initial test of choice. Colonoscopy and barium enema are not really used, as it's a perforation risk, especially in diverticulitis. That's why you just do the CT scan in diverticulitis. And on labs, you'll see the leukocytosis due to the infection. So for management in uncomplicated diverticulitis, treat as an outpatient with oral antibiotics, metronidazole for the anaerobes, and you could do Cipro or levofloxacin for the gram-negatives for 7 to 10 days, and a clear liquid diet as well. Bactrim plus metronidazole is an alternative that can be used. Surgery is only done if refractory to the medical therapy, or if they're having frequent recurrences, perforations, or strictures of the diverticulitis. And also for criteria of admission for diverticulitis, they should have complicated diverticulitis if you admit them, which is perforation, abscess, obstruction, or a fistula formation. CT-guided percutaneous drainage may be done in acute diverticulitis with an abscess, or if it's uncomplicated, with a high risk like a fever over 102, sepsis, immunocompromised, increased age, or unable to tolerate oral intake, you should admit them. Toxic megacolon is next. So you can remember this by TOX6 megacolon. It's over 6 centimeters, plus signs of systemic toxicity. So this is also a non-obstructive condition, and it's extreme dilation over 6 centimeters. Some of the etiologies of toxic megacolon are complications of IBD, inflammatory bowel disease, especially ulcerative colitis, as it involves mostly the sigmoid as well as the rectum and up through the descending colon and transverse. Also infectious colitis like C. diff or cytomegalovirus, CMV. Ischemic colitis as well. Volvulus, diverticulitis, radiation, as well as obstructive colorectal cancer can be causes of toxic megacolon. For clinical manifestations, you'll have that profound bloody diarrhea, abdominal pain, distension, nausea, vomiting, tenesmus, lower abdominal pain, and especially distension, and extreme signs of toxicity, altered mental status, fever, tachycardia, hypotension, dehydration, signs of peritonitis with rigidity, guarding, and rebound tenderness. For diagnosis of megacolon, radiologic evidence is needed of a colon over 6 centimeters. So abdominal radiographs are usually the first initial test of choice, but a CT scan is better to assess complications. 3 or more of the following to officially diagnose toxic megacolon must be had: a fever over 38, a pulse over 120, and a neutrophilic leukocytosis over 10,500. And you need hypotension, dehydration, electrolyte abnormalities, or altered mental status. So these patients are very sick, obviously, with toxic megacolon. For management is the supportive treatment as mainstay, such as bowel rest, bowel decompression, broad-spectrum antibiotics like, again, ceftriaxone and metronidazole, fluid and electrolyte replacement. And you want to also manage the underlying cause, like corticosteroids being used in ulcerative colitis, for instance. Next will be Ogilvie syndrome. Ogilvie syndrome is a colonic pseudo-obstruction. So there's acute dilation of the colon in the absence of any mechanical obstruction. It usually involves the cecum and the right colon. Etiologies are similar to an adynamic ileus, which occurs in a post-op state. Also medications like opioids, anticholinergics, also metabolic, like hypokalemia. the gut can't contract, or hypercalcemia, such as when we see tetany, so increase of the repolarization threshold and it can't contract. Severe medical illness and metabolic, also hypothyroidism and diabetes. So those are some important risk factors for, or etiologies rather, for Ogilvie syndrome. Post-op state, meds like anticholinergics and opiates, hypo-K and hypercalcemia. Metabolic, also hypothyroidism and diabetes. Clinical manifestations, abdominal distension is the main feature. You'll have tympanic abdomen and also distension again, nausea, vomiting, abdominal pain, constipation, and a paradoxical diarrhea, interestingly. For diagnosis, abdominal radiographs you want to do first and see a cutoff at the splenic flexure with a dilated right colon from the cecum on. But the abdominal CT scan and contrast enema are better. So that's a proximal right colonic dilation, and again, CT most accurate. So for Ogilvie syndrome, you want to do IV fluid and electrolyte repletion, so correct the electrolytes as they may be a cause. Again, hypo-K, hypercalcemia. And if the colonic dilation is less than 12 centimeters in absence of severe symptoms, you can just stick with the conservative management. For a second line is medical decompression with neostigmine, which is used in patients at risk for perforation or a cecal diameter over 12 centimeters, or if they failed the conservative management for 1 to 2 days. So that's neostigmine. So that stimulates the gut to contract. So that's the opposite of anticholinergics. Colonoscopic decompression for failure of conservative treatment and neostigmine, or surgical decompression with cecostomy or colectomy, used in refractory cases when everything else fails. So first conservative, then neostigmine, then decompression, and then surgical decompression for Ogilvie syndrome. Next will be inflammatory bowel disease. This includes ulcerative colitis and Crohn's disease. There's a lot of notable risk factors. First is race and ethnicity, more common in Jewish population, especially Ashkenazi Jews, increased in Caucasian compared to Black and Hispanics as well. Age and gender, classically onset between 15 to 35. Ulcerative colitis is slightly more common in males, and Crohn's more common in females. Genetics, 10 to 30% have a first-degree relative with it. And smoking is associated with increased incidence of Crohn's, but interestingly protective in ulcerative colitis. So smokers who stop smoking who have a history of ulcerative colitis also have an increased incidence of flares. Diet. Western style diet is associated with increased risk of IBD. And also infections. Alterations in the bowel microbes during viral or bacterial infections may trigger inflammatory processes that go unchecked. For meds, NSAIDs, oral contraceptives, or hormone replacement therapy may be associated with an increased risk. So extraintestinal manifestations, very common. These manifestations can be seen in Crohn's or ulcerative colitis. Rheumatologic, like musculoskeletal pain, arthritis, ankylosing spondylitis, and osteoporosis. So ankylosing spondylitis is part of the HLA-B27 seronegative spondyloarthropathies, which is PAIR, the psoriatic, the ankylosing spondylitis, IBD, like ulcerative and Crohn's, and R, reactive arthritis. So that's PAIR, pair, are the HLA-B27. There's also dermatologic manifestations in IBD, especially erythema nodosum, which is typically on the shins, or pyoderma gangrenosum on the extensor surfaces. There's classically ocular manifestations, conjunctivitis, anterior uveitis or iritis, also episcleritis, which leads to mild ocular burning. Hepatobiliary, fatty liver, and PSC, primary sclerosing cholangitis with a positive P-ANCA. So you can remember PSC has a P-ANCA positive, and so does ulcerative colitis. Hematologic, B12 and iron deficiency, especially with Crohn's. And remember, intrinsic factor helps absorb B12 in the terminal ileum. So if we have damage to the terminal ileum, which is the most common place Crohn's disease affects, it's going to be B12 and iron deficiency. So B12 iron deficiency anemia, and also increased risk of thromboembolism, as the liver upregulates production of von Willebrand's factor, so this leads to arterial and venous thrombosis. So we'll put them side by side, ulcerative colitis and Crohn's disease, to compare the area, the depth, the manifestations, complications, etc. So for ulcerative colitis, the area is limited to the colon. It begins in the rectum with contiguous spread proximally, and the rectum is always involved in ulcerative colitis. As opposed to Crohn's is any segment of the GI tract from mouth to anus, but the most common is the terminal ileum, which leads to that right lower quadrant pain in Crohn's. The depth of ulcerative colitis is mucosa and submucosal only, so more superficial, where Crohn's disease is transmural or all the way through, which leads to the more common fistulization as well as granulomas. Clinical manifestations of ulcerative colitis: you have that left lower quadrant, which is most common, tenesmus and urgency, also bloody diarrhea, which is hallmark, stools with mucus and pus, and hematochezia. For Crohn's, on the other hand, you'll have a right lower quadrant pain, which is most common. That's where the cecum is. And you'll have weight loss and diarrhea, but no visible blood usually with Crohn's. Complications: PSC, primary sclerosing cholangitis for ulcerative colitis. Colon cancer is more common with ulcerative colitis, importantly, and toxic megacolon is more common with ulcerative colitis. So PSC, colon cancer, and toxic megacolon. Also, smoking decreases, like we said, the risk for ulcerative colitis. But for Crohn's, more commonly is perianal diseases, also like we said, with fistulas, strictures and abscesses, and skin tags. Also granulomas. Malabsorption, more common in Crohn's disease, with iron and B12 deficiency as well. On colonoscopy, for ulcerative colitis, you have a uniform inflammation, plus or minus ulceration in the rectum or colon, and also pseudopolyps. Whereas Crohn's, you'll have those skip lesions, which are normal areas interspersed between inflamed areas, and the classic cobblestone appearance in Crohn's. For barium studies, a stovepipe sign, which is the loss of haustral markings, which is pathognomonic for ulcerative colitis. And for Crohn's, you have the string sign, which is barium flow through a narrowed or inflamed scarred area due to transmural strictures. So the string sign can be seen in colon cancer, kind of, where it's like an apple core sign, which is similar to the string sign, but a string sign can be seen in Crohn's disease. So for labs, P-ANCA is ulcerative colitis, and ASCA, A-S-C-A, antibodies versus Saccharomyces cerevisiae, is Crohn's. Crohn's is non-curative, and ulcerative colitis is curative if you do a total colectomy. So next, we'll go more into Crohn's disease specifically. It will have some repeats, but Crohn's is an idiopathic autoimmune inflammatory bowel disease. It has transmural inflammation that affects any part of the GI tract, anywhere from the mouth to the anus. This transmural inflammation may lead to fistulas, bowel strictures, perianal disease, like we said, skin tags, etc., abscesses, fissures, fibrosis, and bowel obstruction. The terminal ileum is the most commonly involved segment. 55% are in the ileocolitis, 40% affect the small bowel only, and 20% of is colitis only. And importantly, the rectum is often spared in Crohn's disease. Clinical manifestations: ileocolitis will have crampy abdominal pain, especially in that right lower quadrant, diarrhea, but not usually bloody, and weight loss and fever. If you have jejuno-ileitis, we'll have malabsorption, steatorrhea due to the decrease in fat absorption, nutritional deficiencies, and electrolyte abnormalities. Colitis and perianal disease, you'll have diarrhea, perirectal abscesses, anorectal fistula, and fissure formation, also bowel obstruction. For diagnosis, upper GI series is the initial test of choice. We'll see that string sign, like we mentioned, barium flowing through a narrowed or inflamed scarred area, and fistula formation. On endoscopy, segmental skip areas of normal area between damaged area, and that cobblestoning of the mucosa, aphthous ulcerations in the mouth even, and strictures. Biopsy will have transluminal inflammation, or rather transmural inflammation, microscopic skip areas, non-caseating granulomas, which are giant cells, T cells, and macrophages, and fibroblasts that form connective tissue and lesions. Also, classically, creeping fat on gross dissection is pathognomonic. Creeping fat sign, which is mesenteric fat stranding, which is best seen on MRE. mechanical resonance enterography. For labs, anti-Saccharomyces cerevisiae antibodies and decreased B12 if severe increased ESR and CRP. Management limited to ileocolonic, ASA, 5-ASA, mesalamine, or oral glucocorticoids. If it's progressed, you can do glucocorticoids like budesonide, prednisone. Severe and refractory, azathioprine, 6-mercaptopurine, methotrexate, and anti-TNF agents like adalimumab or infliximab are options. So moving to ulcerative colitis. Ulcerative colitis is diarrhea, most common manifestation, often bloody, crampy abdominal pain, especially the left lower quadrant, and tenesmus. Mild, moderate, and severe. So mild will have 4 or less bowel movements per day, may be bloody. No signs of systemic toxicity, however. Episodes of constipation may also be seen, and they may have mild abdominal pain. For moderate ulcerative colitis, frequent loose bowel movements over 4 a day, pain and anemia. Severe 6 or more loose bowel movements a day, severe abdominal pain, signs of systemic toxicity, fever, anemia, elevated ESR and CRP, may also have weight loss. For diagnosis, flexible SIG, which is nonspecific, pseudopolyps, uniform erythema and ulceration, a friable mucosa, also a continuous circumferential pattern, importantly, diffuse and contiguous rectal involvement. Biopsy is nonspecific. Also, they'll have crypt abscesses and atrophy. So don't get the crypt abscesses confused with the fistula of Crohn's disease, whereas crypt abscesses are ulcerative colitis and fistula are Crohn's. Inflammation as well, and basal plasmacytosis. On barium enema, stovepipe or lead pipe sign, loss of postural markings, and for labs, a positive P-ANCA, ESR, CRP, leukocytosis, anemia, fecal lactoferrin, as well as calprotectin, are sensitive for acute inflammation. For management, mild to moderate, are topical 5-aminosalicylic acid is first line. Topical corticosteroids can be added. Combo therapy with 5-ASA, topical ASA and steroids as well. Severe oral glucocorticoids, 5-ASA, topical 5-ASA and steroids. Or fulminant colitis, IV glucocorticoids, fluids, and broad-spectrum antibiotics. And so now we'll go over to some of the maintenance therapy for Crohn's and ulcerative colitis. So first, 6-mercaptopurine and azathioprine. So these are basically the same thing. Mechanism is purine analogs that inhibit immune response. Azathioprine is converted into 6-mercaptopurine. Indications are a steroid-sparing agent. They also may be used as maintenance therapy. Adverse effects are rash, pancreatitis, fever, bone marrow suppression, lymphoma, increased risk of. Methotrexate can also be used as an anti-inflammatory that reduces interleukin production. And remember, this is a folic acid antagonist. Indications used to induce remission and to reduce the use of corticosteroids long term. Adverse effects are many: leukopenia, pneumonitis, hepatic fibrosis, especially with periodic LFTs and CBC. Cyclosporin, mechanism is immunomodulator that reduces interleukin production. Tacrolimus, which is a macrolide antibiotic with immunomodulatory properties. It's more effective than azathioprine, but used refractively. Anti-TNF agents inhibit pro-inflammatory cytokines like adalimumab, infliximab, and anti-integrins like natalizumab also. Okay, so next is chronic mesenteric ischemia. Chronic mesenteric ischemia is ischemic bowel disease due to mesenteric atherosclerosis, which leads to a decreased supply during increased demand, such as during eating, when we need more blood in the stomach. Most patients have atherosclerotic disease, like a history of an MI or coronary artery disease. The pathophys is episodic intestinal hypoperfusion related to eating. So the increased demand during eating plus a decreased blood supply leads to this mesenteric ischemia. Manifestations are abdominal pain, worse with meals. This is also called intestinal angina. It's the same mechanism. Anorexia, and adverse aversion to eating, and weight loss. So typically in the question stem, it'll be an older person with an aversion to eating leading to weight loss, makes you think of the colorectal cancer. However, they have this abdominal pain that's worse right after eating and is very intense. For diagnosis of chronic mesenteric ischemia, angiography is the best test. You'll see that atherosclerotic lesion. And you want to revascularize for management, which is the definitive treatment, angioplasty versus stenting or bypass. On the other hand, acute mesenteric ischemia is different. This is an abrupt onset of small intestinal hypoperfusion. Etiologies most commonly are an acute arterial occlusion due to an embolism from AFib. Thrombotic as well, due to atherosclerosis, could occur acutely, and superior mesenteric artery occlusion is the most common, so SMA. And that's most commonly an emboli from AFib, like we said. Non-occlusive arterial ischemia, which would be hypoperfusion due to shock, also vasopressors and cocaine. Also think if you're using some migraine medications like ergotamines, could lead to vasoconstriction in the gut. Venous thrombosis, obstruction of intestinal venous outflow. Clinical manifestations, abdominal pain, severe abdominal pain out of proportion to the physical findings. That's classic for acute mesenteric ischemia. Severe abdominal pain out of proportion to the physical findings. So that's similar to the compartment syndrome findings as well. No peritoneal signs, pain is usually poorly localized. Nausea, vomiting, diarrhea, advanced signs are peritonitis, guarding rigidity, rebound tenderness, heme-positive stool, or shock. Diagnosis, CT angiography is the initial test to assess ischemia if they are stable. Done without oral contrast, as there could be a risk of perforation. Conventional arteriography is the definitive diagnosis. They'll have a leukocytosis, a lactic acidosis due to the tissue breakdown, increased hematocrit due to the bleeding, hemoconcentration, also due to the lack of fluids, increased amylase and LDH. Management is depending on the cause, but surgical revascularization is often needed, such as an embolectomy due to the embolism, or angioplasty with stenting or bypass to treat arterial thrombosis. You may have to do surgical resection if it's not salvageable, or anticoagulation or thrombolysis in venous thrombosis, anticoagulation in patients with AFib. Next will be ischemic colitis. So ischemic colitis is a bit different. This is a decreased colonic perfusion leading to inflammation. So this is most commonly due to a transient systemic hypotension or atherosclerosis involving the superior and inferior mesenteric arteries. So this is similar to the mechanism of a pre-renal AKI, where there's just not enough flow getting there. Most commonly a watershed area, which there's two watershed areas. So one is the SMA to the inferior mesenteric artery junction, as well as around the turning of the corner of the sigmoid, both where there's no collaterals or main arterial supply. So again, these are most commonly at the watershed area between two arteries with decreased collaterals, such as the splenic flexure and the rectosigmoid junction. So that splenic flexure is between where the SMA and the inferior mesenteric artery kind of have the collaterals. Risk factors for ischemic colitis is elderly, diabetes, of course, aortoiliac surgery or instrumentation, cardiac cath, myocardial infarction, constipation-inducing medications. Manifestations will have the left lower quadrant crampy abdominal pain with tenderness, bloody diarrhea, or hematochezia due to colonic sloughing from the ischemia. Pain is usually not as severe and is more lateral as compared to acute mesenteric ischemia. So they may have like a splenic flexure pain, which kind of is a left upper quadrant pain as well. They also may develop bowel gangrene associated with a lactic acidosis and a leukocytosis. So for diagnosis of ischemic colitis, you want to get the CT of the abdomen. It's the first test to test for acute colonic ischemia with wall edema and thumb printing, segmental bowel wall thickening, which is nonspecific however, and colonoscopy. Segmental ischemic changes are seen in areas of low perfusion, again the splenic flexure, and friable mucosa. It's not performed, however, if there's signs of peritonitis or risk of bowel perforation is suspected. Management is supportive. You have to restore the perfusion just like a pre-renal AKI. Bowel rest, IV fluids, and observe for signs of perforation is the management in most patients. Usually resolves without specific therapy. They may need empiric, broad-spectrum antibiotics as well, especially if there's a risk for perforation. Next, we'll move to colon polyps. Colon polyps. So there's pseudopolyps and inflammatory polyps, as well as hyperplastic. So first, the pseudopolyps and inflammatory polyps. These are due to inflammatory bowel disease like ulcerative colitis or Crohn's, and they're not considered cancerous. Hyperplastic, on the other hand, do carry a risk for malignancy, although it's low, and they're most commonly non-neoplastic, and they're a type of serrated polyps. So this will be the sawtooth appearing polyps. There's also hamartomatous polyps, like juvenile polyps, as well as juvenile polyposis syndrome, JPS, which is an autosomal dominant condition associated with multiple hamartomatous polyps. It's associated with an increased risk of colorectal cancer and gastric cancer. We also have Peutz-Jeghers syndrome, or Peutz-Jeghers polyps, often associated with Peutz-Jeghers syndrome, which is the STK11 mutation. Usually benign, but may undergo submalignant transformation, so they're usually resected. So remember, they have the oral changes as well, with those blue and black dots in the oral mucosa in Peutz-Jeghers. Adenomatous polyps, most common neoplastic polyps are the adenomatous polyps. There's 3 types of these as well. So adenomatous polyps are the most common neoplastic, and they also comprise 2/3 of all colonic polyps, unfortunately. Average is 10 to 20 years before becoming cancerous, especially over 1 centimeter are considered cancerous. So we have tubular, tubulovillous, and villous. So easy to remember: villous, villain, these are the worst kind. Tubular adenoma, the best kind if you had to have one. Non-pedunculated, most common type of adenomatous polyp. It's associated with the least risk of all three subtypes of adenomatous polyps. There's tubulovillous, which is a mixture, and this has intermediate risk. And of course, villous adenoma, the highest risk of becoming cancerous. But these tend to be sessile as well, so a little bit harder to see. Next, colorectal cancer. Colorectal cancer most commonly arises from adenomatous polyps. The risk factors are over age 50, especially over age 65, African Americans, as well as family history of colorectal cancer. IBD, ulcerative colitis over Crohn's, and the increased risk of colon cancer begins about 8 to 10 years after the initial diagnosis of pancolitis, and also at about 15 to 20 years from colitis limited to the left colon itself. And remember again, ulcerative colitis, more common risk for colorectal cancer than Crohn's. Diet and lifestyle is very important as a risk factor. A diet low in fiber and high in red and processed meat, as well as animal fat, is really bad. Obesity, smoking, and alcohol. Genetic, there's many important things to remember in the genetic causes of colorectal cancer. For instance, familial adenomatous polyposis, which is a genetic mutation of the APC gene. These adenomas in FAP begin in childhood. So almost all will develop colon cancer by age 45 years old. A prophylactic colectomy is the best chance for survival for patients with familial adenomatous polyposis. There's also Turcotte syndrome, which is similar to FAP, but there's also having CNS tumors like a medulloblastoma and a glial tumor. So that's Turcotte syndrome, which is the FAP tumors plus a CNS tumor as well. Lynch syndrome, which is hereditary non-polyposis colorectal cancer, which is an autosomal dominant due to loss of function of the DNA mismatch repair genes, has a 40% risk of colon cancer, especially type 1 seen on the right side. Type 2 is a risk of extracolonic cancers as well, like endometrial. So I had that question in the EOR. The patient had endometrial cancer as well as colorectal cancer, and it was what was the syndrome, and it was Lynch syndrome. So that's the hereditary non-polyposis colorectal cancer. It's the inabilities of the body to repair the mismatched DNA. And again, they have those extracolonic cancers like endometrial, ovarian, small intestine, brain, and skin, and the mean age is 40s. Peutz-Jeghers syndrome, again, autosomal dominant, associated with hamartomatous polyps, mucocutaneous hyperpigmentation, especially in the lips, oral mucosa, hands, and also increased risk of pancreatic cancer. Some protective factors are physical activity, use of aspirin, interestingly, and NSAIDs are associated with a decreased risk. Manifestations, iron deficiency anemia is very classic with its fatigue and weakness, also rectal bleeding, pain, and change in bowel habits. And importantly to know, colorectal cancer is the most common cause of large bowel obstruction in adults. And with advanced disease, you can get ascites, abdominal masses, and hepatomegaly due to the backup or compression. So right-sided versus left-sided are different in colorectal cancer. For the right-sided, which are also called proximal, the lesions tend to cause chronic occult bleeding due to iron deficiency anemia and positive guaiac stools, as well as diarrhea. So the right-sided is more chronic bleeding. The left-sided tend to cause bowel obstructions, and they tend to present later and cause changes in stool diameter. They also may develop with strep bovis endocarditis. So remember that strep bovis is the GI-associated endocarditis. And also another reason why we might see the bowel obstruction in the left side as opposed to the right side is the diameter, remember, is smaller in the left side as it narrows down the sigmoid. So a bowel obstruction there or a cancer growing could easily obstruct that as opposed to the larger diameter right side. Diagnosis is colonoscopy, of course, with biopsy. Barium enema will show apple core lesions, which are classic on the left side. And laboratory iron deficiency anemia, especially right side. Tumor markers, classically CEA, carcinoembryonic antigen, is the most commonly monitored tumor marker, but it's not specific. And for management of colorectal cancer, surgical resection, radical versus endoscopic, also post-op chemo to destroy residual cells or micrometastases. Metastatic palliative chemotherapy. Colon cancer screening guidelines will be next. So for average risk, first degree relative over 60 or first degree relative under 60, the screening lines are different. So fecal occult blood test, if they're average risk, just do annually at 50 years old. And for colonoscopy, average risk every 10 years or flex sig every 5 years, up to age 75. First degree relative over 60, you start the fecal occult at 40, and a colonoscopy every 10 years. First degree relative under 60, annually at 40 for the fecal occult, or remember 10 years before the relative was diagnosed, and a colonoscopy every 5 years if that relative was first degree and under 60 years old. So patients are screened until they're 75, and the USPSTF guidelines recommend any of the three approaches: high sensitivity fecal occult blood testing annually, colonoscopy every 10 years from age 50 to 75, flex sig every 5 years, along with fecal occult every 3 years. And again, so different also for Lynch syndrome and familial adenomatous polyposis. Familial adenomatous polyposis is initiate screening at age 10 to 12 years of age with a flex sig every year. So, and also that differs from Lynch syndrome, the hereditary non-polyposis colorectal cancer, in which screening begins at 20 to 25 years with a colonoscopy every 1 to 2 years. So a little bit different for each of those. Next will be esophagitis. Etiologies of esophagitis are GERD as the most common cause, of course, but there's also infectious, which could be due to Candida, cytomegalovirus, and HSV. It's most commonly associated with immunocompromised states as well for the infectious. Eosinophilic due to allergic reaction, so you want to look for a history of asthma as well as eosinophilic esophagitis. In pill-induced esophagitis, bisphosphonates are a common culprit, as well as beta blockers, calcium channel blockers, tetracyclines, NSAIDs. Also, potassium chloride, I got a question on. Caustic, corrosive due to acidic or basic substances. Remember, basic substances are worst with the liquefactive necrosis, where acidic is the coagulative necrosis. Clinical manifestations of esophagitis: odynophagia, which is the pain upon swallowing, dysphagia, which is trouble swallowing, and retrosternal chest pain. Upper endoscopy allows for direct visualization in double contrast esophagram as well. Management: treat the underlying cause. Next, for irritable bowel syndrome. Irritable bowel syndrome is a chronic functional idiopathic pain disorder with no organic cause of its own. The onset is more common in the late teens as well as early 20s and more common in women. So there's three main theories proposed for the pathophys of IBS. So there's abnormal motility, where chemical imbalances of serotonin and acetylcholine in the intestine cause abnormal motility and spasm, causing abdominal pain, as well as altering the gut microbiota. So that's the abnormal motility. There's also visceral hypersensitivity. So patients may have a lowered pain threshold to intestinal distension. Also psychosocial interactions with altered central nervous system processing. And for clinical manifestations, for hallmark, it's typically abdominal pain associated with alterations in defecation and bowel habits, like alternating between diarrhea, constipation, or between the two. And the pain is often relieved with defecation, with no tenesmus. So that's important. The pain is often relieved with defecation. Alarm symptoms in IBS, evidence of GI bleeding, such as occult blood, rectal bleeding, anemia. Also anorexia or weight loss, fever or nocturnal symptoms especially, family history of GI cancers or IBD or celiac, persistent diarrhea causing dehydration as well is a alarm symptom, severe constipation or fecal impaction, or having an onset of over 45 years old as well is a risk factor. For diagnosis of IBS, it is a diagnosis of exclusion after you work them up with a colonoscopy, abdominal CT to rule out other etiologies. The Rome 4 criteria is important to know for IBS diagnosis. This is recurrent abdominal pain on an average of at least 1 day per week in the last 3 months, associated with at least 2 of 3 of the following. So they have to have either a relation of this IBS to defecation, so defecation helps relieve it, so relation to defecation, or an onset associated with a change in stool frequency or a change in stool form, the appearance. So it has to have 2 of the 3, related to defecation, change in stool frequency, and change in stool appearance. For management of IBS, lifestyle and dietary changes are first line. This includes low fat, high fiber, and unprocessed foods. Avoid fake sugars and avoid gas-producing foods. And smoking cessation and sleep and exercise are helpful. For the constipation symptoms, as opposed to the diarrhea symptoms, we have different treatments. For the constipation symptoms, you want to use fiber as well as psyllium, which help with the prokinetic movement, as well as bulking, and polyethylene glycol, which is an osmotic, and you can use anything from the Pegels thing too. Maybe added to the fiber. Bulk forming and saline laxatives as well. Lubiprostone and linaclotide are usually reserved for people with no response to the above. So lubiprostone and linaclotide, gotten questions on those, and those are for the constipation symptoms. For diarrheal symptoms, loperamide, which is an opioid, so that slows things down. Also rifaximin and bile acid sequestrants. Also anticholinergics and antispasmodics like dicyclamine or hyoscyamine. These are antispasmodics for the gut. So that's a common one used, dicyclamine or hyoscyamine and loperamide. And again, for constipation, use your bulkers, or second line would be lubiprostone or linaclotide. And moving to infectious esophagitis. So infectious esophagitis, some of the risk factors are immunocompromised states, like HIV, post-transplant, malignancy, chemotherapy, but they can also occur in healthy patients as well, although less common. Candida is the most common cause overall of infectious esophagitis, and in patients with classic symptoms, impaired treatment with fluconazole can be initiated with upper endoscopy, reserved if no response to initial therapy. So with a high suspicion, just treat with fluconazole before the EGD. Clinical manifestations, triad of symptoms, odynophagia, the pain, dysphagia, the difficulty, and retrosternal chest pain again. So Candida, CMV, and HSV all have similar but different presentations and treatments. So for Candida, you see on endoscopy. These are all on endoscopy. For Candida, you see linear yellow-white plaques, and you want to treat with PO, fluconazole. Second line is voriconazole or caspofungin. For CMV, cytomegalovirus. These are large, superficial, shallow ulcers. So megalovirus, large, superficial, shallow ulcers. And ganciclovir is first-line treatment. HSV, small, deep ulcers, and acyclovir is treatment. Eosinophilic esophagitis is next. Eosinophilic esophagitis is an allergic inflammatory eosinophilic infiltration of the esophageal epithelium, most commonly seen in children and associated with atopic disease. Again, asthma, eczema, allergic rhinosinusitis. Atopic triad you must look for with this one. Clinical manifestations: dysphagia, especially solids, odynophagia, reflux, or feeding difficulties in children. Diagnosis on endoscopy: you'll see multiple corrugated rings with white exudates. Not white exudates like Candida, though. So, multiple corrugated rings are pretty pathognomonic for the eosinophilic, and in biopsy you see an abundance of eosinophils. For management, remove the foods that incite the allergic response, and some may need PPIs as well. Inhaled topical corticosteroids without using a spacer to allow for penetration, with spacer for asthma, and without the spacer allows it to get stuck in the esophagus, which is what we want. So we want those corticosteroids to get into the esophagus. So that's with eosinophilic, however. So pill-induced esophagitis. Esophagitis due to prolonged pill contact with the esophagus itself. And most common are NSAIDs and bisphosphonates. And also I got a question in potassium chloride was the cause of pill-induced esophagitis. Also beta blockers, calcium channel blockers, iron pills, vitamin C, tetracyclines. But NSAIDs and bisphosphonates are the biggest ones. Odynophagia and dysphagia. Endoscopy will show a small, well-defined ulcer of varying depths. Management is to take with at least 4 ounces of water, avoid recumbency at least 30 to 60 minutes after the pill ingestion. You can also have a caustic or corrosive esophagitis. This is ingestion of a corrosive substance like alkali in drain cleaner, lye, and bleach, or acids like batteries. Odynophagia, dysphagia, hematemesis, dyspnea. For diagnosis of caustic or corrosive, endoscopy is used to determine the extent of damage and look for complications like perforation, stricture, or fistula. Supportive pain meds and IV fluids are the management. Next is the all-important hiatal hernia. This is herniation of structures of the abdominal cavity through the esophageal hiatus of the diaphragm. So there's sliding and there's paraesophageal. Sliding is a type 1. This is when the gastroesophageal junction slides into the mediastinum. It increases reflux, and it's the most common type at 95%. That's sliding type 1 hiatal hernia. Paraesophageal is a type 2 or rolling hernia, where the fundus of the stomach protrudes through the diaphragm with the GE junction remaining in its anatomical location. There's also a type 3 where everything goes up into the through the GE junction as well. Manifestations are usually asymptomatic, usually an incidental finding, but they can develop epigastric or substernal pain or postprandial fullness or retching or nausea. And management for sliding is GERD, PPIs, and weight loss, if indicated. And paraesophageal is surgical repair reserved for complications like volvulus, obstruction, strangulation, etc. Next will be esophageal atresia. Esophageal atresia is a complete absence or closure of a portion of the esophagus. Most commonly it's associated with a tracheoesophageal fistula as well as polyhydramnios. The clinical manifestations typically present immediately after birth with excessive oral secretions that lead to choking, drooling, inability to feed, respiratory distress, and coughing, especially when they're attempting to feed. And gastric distension, of course, as well as aspiration pneumonia is common, as it's a connection between the trachea and the esophagus after all. Diagnosis is the inability to pass an NG tube further than 10 to 15 centimeters in which you have coiling in the esophagus. So that's the inability to pass the NG tube for esophageal atresia. On fluoroscopy for diagnosis, a small amount of water-soluble contrast may reveal it, but it must be removed promptly to prevent aspiration, and barium should not be used. For management of esophageal atresia, surgical ligation of the fistula with primary anastomosis of the esophageal segments can be done in stages of the distance between the two segments if it is large. Next for GERD, gastroesophageal reflux disease. GERD is reflux of the gastric contents into the esophagus due to an incompetent lower esophageal sphincter. It's due to the transient relaxation of the LES, also called incompetency, which leads to gastric reflux and esophageal mucosal injury over time. The manifestations are typically, well, we need to go over typical and atypical or alarm symptoms. For typical presentation of GERD, you typically have heartburn, pyrosis, which is hallmark. It's often retrosternal and postprandial, increasing with supine position, and also may be relieved with antacids. For regurgitation continuously, you may have water brash, a sour taste in the mouth, cough, and sore throat. So water brash is the increased saliva in response to the acid, so you may sense just an increase in saliva overall. Some atypical symptoms and some alarm symptoms are dysphagia, odynophagia, pain when swallowing, weight loss as well as bleeding. Hoarseness, aspiration pneumonia, wheezing, and chest pain can also occur. So there's 4 main complications that can present with these alarm symptoms. Esophagitis, which is inflammation from the acid refluxing. Strictures over time, narrowing from the acidic damage. Barrett's esophagus, of course, which is esophageal squamous epithelium replaced by precancerous metaplastic columnar cells from the cardia, which is the top portion of the stomach. Esophageal adenocarcinoma as a result of Barrett's esophagus. So the body tries to build a stronger esophagus to handle the constant acidic environment, so it starts switching the squamous epithelium, which is the typical esophageal cells, to more columnar cells, which are a bit bulkier and stronger. So the diagnosis of typical GERD, you can just do a clinical diagnosis based on the history if they are presenting with a classic simple symptom, or a 24-hour pH ambulatory monitoring, and this is the gold standard if a confirmation is needed. So usually clinical, but the 24-hour pH ambulatory monitoring is the gold standard. And also esophageal manometry may be able to detect a decreased LES pressure. For diagnosis, if persistent symptoms or alarm symptoms, you want to do endoscopy. This is the first line diagnostic test if persistent symptoms or a complication of GERD is suspected, such as, again, alarm symptoms, malignancy, symptoms for over 5 to 10 years as well. For management of GERD, lifestyle modifications are first line. You want to elevate the head of the bed 6 to 8 inches, avoid recumbency for 3 hours after eating, avoid foods that delay gastric emptying like fatty or spicy foods, chocolate, peppermint, and caffeinated products, smoking cessation as nicotine decreases the strength of the lower esophageal sphincter, also decrease your alcohol intake and weight loss. For stage 2 management, intermittent or mild, under 2 episodes per week, you can do as needed pharmacologic therapy, antacids and H2, and stage 3 is a PPI, proton pump inhibitors for moderate to severe disease, which is classified as greater than 2 episodes per week, and Nissen fundoplication in medication refractory patients. So again, for the management of GERD, lifestyle first, then you can do an antacid, and then H2 receptor antagonist, and then stage 3 is the PPIs, and refractory is the Nissen fundoplication. So we'll go into Barrett's esophagus a bit more here. This is again esophageal squamous epithelium being replaced by precancerous metaplastic columnar cells from the cardia of the stomach, and again it's a precursor to esophageal adenocarcinoma. It's a complication of long-standing GERD. So for the diagnosis of Barrett's, you want to do an upper endoscopy with a biopsy. So Barrett's of the esophagus only, which is metaplasia, just do PPIs and rescope every 3 to 5 years. If they have low-grade dysplasia, PPIs and rescope every 6 to 12 months. And if they have a high-grade dysplasia, do ablation with endoscopy, photodynamic therapy, endoscopic mucosal resection, or radiofrequency ablation as well. So moving to esophageal neoplasms, you have a few different types. So there's adenocarcinoma and squamous cell carcinoma. So first for adenocarcinoma, this is the most common cause in the US of esophageal cancer. 50 to 80% are adenocarcinoma. It's also more common in younger patients as well as Caucasian males. It's most common in the distal esophagus, so distal equals down, so the bottom of the esophagus near the LES, and also the esophagogastric junction. For squamous cell, on the other hand, it's the most common worldwide at 90 to 95%, and it peaks at 50 to 70 years of age, so a little bit older for squamous cell. In the US, it is associated with an increased incidence in African Americans. So most are in the mid to upper third of the esophagus as well. So some differences with both of those. And risk factors for adenocarcinoma. Major risk factor is in the United States is Barrett's esophagus, which again is a complication of GERD, smoking, and high BMI. Unlike squamous cell, however, alcohol is not a risk factor for adenocarcinoma. Risk factors for squamous cell. Major risk factor is smoking and alcohol. So worldwide includes poor nutritional status, low fruit and veggie intake, beverages at high temperatures due to thermal injury, HPV, also atrophic gastritis, achalasia, etc. For protective factors, aspirin or NSAIDs may be protective actually for esophageal cancer, particularly in the setting of Barrett's esophagus. Clinical manifestations, patients often have extensive disease by the time they do become symptomatic. Progressive dysphagia is hallmark in esophageal neoplasms, especially solid food dysphagia, progressing to include liquids and odynophagia. So in the beginning, some fluid can still leak through, but as it progresses, not even fluid can get through. And painful swallowing, which is odynophagia. Weight loss is important to note, anorexia, and iron deficiency anemia from chronic blood loss. Chest pain, anorexia, cough, hematemesis, reflux, hoarseness due to recurrent laryngeal nerve irritation, Horner syndrome, if you have damage to the vagus nerve, that ptosis, anhidrosis, and meiosis for Horner's, and tracheal esophageal fistula could be possible. Hypercalcemia with squamous cell carcinoma. For diagnosis, upper endoscopy with biopsy is the diagnostic test of choice. In appearance, you'll see early lesions that may appear as superficial plaques, nodules, or ulcerations. Advanced lesions on upper endoscopy may appear as strictures or also ulcerated masses, circumferential masses, or large ulcerations. You could also do a double contrast barium enema, but pre-treatment staging is important to do. That's after with the biopsy, and you can do endoscopic ultrasound is the preferred method for loco-regional staging. So if you need to stage the cancer, you should do an endoscopic ultrasound for loco-regional staging. Preoperative bronchoscopy with biopsy and brush cytology are indicated for locally advanced lesions. CT of the neck, chest, and abdomen, or PET scan or CT scan as well can be done. For management, resection of the esophagus, you can do radiation therapy, chemo, palliative stenting to improve dysphagia may be needed in some advanced cases. Next will be achalasia. So achalasia is a loss of peristalsis and a failure of relaxation of the lower esophageal sphincter. The pathophys is idiopathic proximal degeneration of Auerbach's plexus, leading to increased LES pressure and impaired LES relaxation. It's most common in patients under 50 years old. Manifestations are dysphagia to both solids and liquids at the same time, regurgitation of undigested foods, chest pain, and cough. They may develop malnutrition, weight loss, and dehydration. For diagnosis of achalasia, you'll see the classic bird's beak appearance on barium esophagram, which is the LES narrowing with proximal esophageal dilation and loss of peristalsis distally as well. On manometry, this is the most accurate test, which will show increased LES pressure and lack of peristalsis. So you have the classic sign, which is the bird beaks on barium esophagram, but manometry is the most accurate. Endoscopy can also be done. It's usually performed in achalasia prior to initiating treatment to rule out esophageal squamous cell carcinoma. Achalasia is a risk factor. Management, decreased LES pressure. Botulinum toxin injection requires a retreatment in 6 to 12 months, however. Nitrates can be done to try to relax it, but surgery is more effective, and this is the Heller myotomy. Pneumatic dilation can also be done, and esophagomyomectomy is the definitive treatment. Next, for Zenker's diverticulum. Zenker's diverticulum is a pharyngoesophageal pouch, or also called a false diverticulum, which only involves the mucosa and possibly the submucosa. It's most common in males, and it usually presents over 60 years of age, often in the 70s. Pathophys is an outpouching, which occurs due to weakness at the junction of Killian's triangle, between the fibers of the cricopharyngeal muscles and lower inferior pharyngeal constrictor muscle. Dysphagia, regurgitation of undigested foods, coughing, feeling as if there's a lump in the neck, a neck mass, a choking cessation, and importantly, halitosis, which is odorous breath due to food retention in the pouch. So for diagnosis of Zenker's, we can do a barium esophagram with video fluoroscopy as the initial test of choice. This will show a collection of dye behind the esophagus at the pharyngoesophageal junction. And it's mostly posterior as well. Upper endoscopy will be performed before surgical evaluation, and for management, observation if it's small and asymptomatic, but you can also do a diverticulectomy or cricopharyngeal myotomy as well. Next will be distal diffuse esophageal spasm. This is esophageal dysmotility disorder characterized by severe non-peristaltic esophageal contractions. These are uncoordinated contractions. The pathophys is impaired inhibitory innervation, so it just doesn't stop, leading to premature and rapidly propagating contractions. So it can't inhibit appropriately, and then the contraction just continues. So you'll have stabbing, chest pain, worse with hot or cold liquids or food, pain similar to angina but not exertional. You could have dysphagia to both solids and liquids simultaneously, and a sensation of an object stuck in the throat. Diagnosis is by esophagram. Will show severe non-peristaltic contractions and a corkscrew esophagus, classically. Corkscrew esophagus. For mnemonics, which is the best test and the definitive for diagnosis, you'll see increased simultaneous or premature contractions in the distal esophagus with preservation of some peristaltic activity. Mnemonics is often combined with esophagram and endoscopy to rule out malignancy as well. The management of diffuse distal esophageal spasm is an antispasmodic as first line, which is calcium channel blockers, nitrates, and TCAs. Second line, you could do a botulinum toxin injection or pneumatic dilation, and pre-oral or endoscopic myotomy is an alternative if refractory to medical management. So this is the contraction of the esophagus. It just does not relax and it's not coordinated. So it's just one contraction at a time. For hypercontractile jackhammer esophagus, on the other hand, this is esophageal motility disorder characterized by increased pressure during peristalsis, normally sequential contractions in the smooth muscle of the esophagus, classically known as nutcracker esophagus, as opposed to corkscrew esophagus. So the clinical manifestation is dysphagia to both liquids and solids, also chest pain similar to distal diffuse esophageal spasm. Manometry is the definitive diagnosis, showing increased pressure during peristalsis. In upper endoscopy and esophagram are usually normal. For management, lower esophageal pressure is our goal, also with calcium channel blockers, nitrates, botulinum toxin injection, and TCAs. So in differentiating between hypercontractile jackhammer esophagus and distal diffuse corkscrew esophagus, esophageal spasm, they're a little bit different. So diffuse esophageal spasm has a decrease in inhibition and no peristalsis, as opposed to a hypercontractile jackhammer esophagus. This has an increase in strength and peristalsis. So again, distal diffuse esophageal spasm and hypercontractile esophagus have a similar presentation, but manometry will show a different peristaltic pattern to be able to distinguish between the two. And next will be Boerhaave syndrome. Boerhaave syndrome is a thick, full rupture, most commonly affecting the left posterior lateral wall of the lower esophagus, and this is a high mortality rate at 40%. Boerhaave syndrome is associated with an iatrogenic perforation of the esophagus during endoscopy, which is most common, but also repeated forceful vomiting or retching, such as in bulimia or alcoholism. Clinically, you'll have retrosternal chest pain, worse with deep breathing and swallowing, also vomiting and hematemesis. On physical, crepitus on chest auscultation, subcutaneous emphysema, importantly, and also classically Hammond's sign for Boerhaave syndrome. Hammond's sign is mediastinal crackling, which is accompanied by every heartbeat in the left lateral decubitus position. For diagnosis, contrast esophagram is the diagnostic test of choice, which will show leakage, and you don't want to use barium here, you want to use gastrographin. So a gastrographin swallow is preferred due to its water solubility, and barium is caustic if it does leak through due to the perforation. A CT chest and chest x-ray will show a left-sided hydropneumothorax, which is most common, and also pneumomediastinum, which is basically why we're hearing that Hammond sign, the crackling with every heartbeat, and esophageal thickening. Management, small and stable, you can use IV fluids, NPO, broad-spectrum antibiotics, of course, and H2 receptor blockers. If it's large and severe, you can do surgical repair. For Mallory-Weiss syndrome, or Mallory-Weiss tear, on the other hand, this is a longitudinal superficial mucosal laceration at the gastroesophageal junction or the gastric cardia. The pathophys of a Mallory-Weiss tear is sudden rise in intra-abdominal pressure or gastric prolapse into the esophagus, such as persistent retching or vomiting after an alcohol binge most commonly. It may be associated as well with hiatal hernias. Clinical manifestations, you'll have an upper GI bleed preceded by retching or vomiting, hematemesis, melena, hematochezia, syncope. 5 to 10% of all upper GI bleeds are Mallory-Weiss tears. May develop upper abdominal pain, back pain, or hydrophobia. Upper endoscopy is the test of choice with superficial longitudinal mucosal erosion. So remember, for Mallory-Weiss tear, as opposed to Boerhaave's, Mallory-Weiss tear is more superficial and longitudinal in line with the esophagus, as opposed to Boerhaave's, which is just a tear through the whole entire esophagus. So for management of Mallory-Weiss tear, again, upper endoscopy, and if they're not actively bleeding, supportive is the mainstay of treatment with acid suppression, with PPIs, which promote healing, but most cases stop bleeding without intervention. If they do have severe bleeding, options include thermal coagulation, hemoclips, endoscopic band ligation, with or without epi, and you can also do balloon tamponade with a Stangerston Blakemore tube or a Minnesota tube. Next is esophageal web. This is non-circumferential thin membrane in the mid-upper esophagus, proximally. It may be congenital or acquired, and it's associated with Zenker's diverticulum. Manifestations are dysphagia, especially to solids like meat and bread, but they can be asymptomatic as well. For diagnosis of a web, it's barium esophagram or swallow, which is a diagnostic test of choice. It's more sensitive for webs actually than in endoscopy, importantly. For management, endoscopic dilation, if they're severe symptoms, and also PPI therapy after dilation may decrease the risk of recurrence. So I think of it as the body's natural protective mechanism for increased acid reflux. So if PPIs help, then preventing recurrence, and it could be due to that increased acid. So Plummer-Vinson syndrome, it's a triad of dysphagia, cervical esophageal webs, and iron deficiency anemia. So dysphagia, esophageal webs, and iron deficiency anemia. It can also be associated with atrophic glossitis, angular cheilitis, koilonychia, and splenomegaly, all of which are complications of iron deficiency anemia as well. It's most common in Caucasian women 30 to 60 years old, and patients with Plummer-Vinson syndrome are at an increased risk of esophageal squamous cell carcinoma. Next will be esophageal Schatzki ring, circumferential diaphragm of tissue that protrudes into the esophageal lumen. It's most common in the lower esophagus at the squamo-columnar junction distally. The risk factors for a Schatzki ring are hiatal hernia, most commonly, and the hiatal hernia is present in most patients, corrosive esophageal injury as well, such as with acid reflux and eosinophilic esophagitis. Clinical manifestations of the Schatzki ring are mostly asymptomatic. They may have some episodic dysphagia, especially to solids like meat and bread, and classically a bolus of food may get stuck in the lower esophagus, which is called steakhouse syndrome. For diagnosis, barium esophagram or swallow is more sensitive than endoscopy again, just as it was for web. And for this Schatzki ring, you'll see circumferential ridge with a few centimeters above the hiatus of the diaphragm. Upper endoscopy, often performed in patients with esophageal rings, to biopsy the esophagus for associated eosinophilic esophagitis. And for management, symptomatic can get dilation, which could be pneumatic dilation, or obliteration with biopsy forceps. Anti-reflux surgery if reflux is present, like a Nissen fundoplication. For esophageal varices, this is dilation of the gastroesophageal collateral submucosal veins as a complication of portal vein hypertension, including the left gastric vein. So the left gastric vein is prior to the ascending veins up the esophagus that form the varices. The biggest risk factor for esophageal varices is cirrhosis as the most common cause. Also, portal venous thrombosis, which is Budd-Chiari syndrome, which is most common in children. For clinical manifestations in upper GI bleed, with hematemesis, melena, and hematochezia, if it is severe, they may develop signs and symptoms of hypovolemia. For diagnosis of varices, upper endoscopy is the test of choice. It's both diagnostic and therapeutic for this one, so you can use it to treat at the same time. The management for acute variceal bleeds is LOL, liquids, octreotide, and ligation. So first, of course, stabilize the patient with 2 large bore IV lines, IV fluids. May need packed red blood cells if they have low hematocrit. If they have a coagulopathy, such as an increased INR or PT, they may need FFP, which could be likely, especially if this is from cirrhosis from liver. Endoscopic intervention will be endoscopic variceal ligation is the initial treatment of choice. Endoscopic sclerotherapy is an option as well, but it has a higher complication rate and rebleed potential. So you want to do ligation over sclerotherapy as the first line for that. You can also do pharmacologic vasoconstrictors such as octreotide, which is the first line medical management. It can be used alone or as an adjunct to endoscopic treatment. Octreotide is a somatostatin analog that causes vasoconstriction of the portal venous flow, decreasing portal pressure and reducing bleeding. For second line for pharmacologic vasoconstrictors, you can use vasopressin. Vasopressin decreases portal venous pressure as well, but it has adverse effects like vessel constriction in other areas like coronary artery vasospasm, MI, and bowel ischemia, so it's more non-selective. Balloon tamponade can also be used. This could be used to stabilize bleeding, but it's not controlled if it's not controlled by endoscopic or pharmacologic interventions, or if they're just rapidly bleeding. The balloon helps inflate and physically stop the flow. And surgical decompression. The TIPS procedure, transjugular intrahepatic portosystemic shunt, can be done. This is indicated if bleeding despite endoscopic or pharmacologic treatments, and also in some advanced cases. For antibiotic prophylaxis is important in esophageal varices, with fluoroquinolones like norfloxacin or ceftriaxone, importantly, to prevent infectious complications like SBP, spontaneous bacterial peritonitis. So I've seen ceftriaxone as the answer to that on some questions for antibiotic prophylaxis. Also important to note prevention of rebleed with non-selective beta blockers like nadolol or propranolol to prevent the rebleeding once the patient has been stabilized. So you don't do this for acute management. 90% of the patients with cirrhosis will develop esophageal varices. 30% of those patients will bleed, and the mortality rate of them is 30 to 50% with the first bleed, and also 70% rebleed within the first year of the initial bleed, and 1/3 of those rebleeds are fatal. So it has a high mortality and a high recurrence overall. Next will be celiac disease or celiac sprue. This is an autoimmune mediated inflammation of the small bowel due to reduction in alpha-gliadin in gluten-containing foods like wheat, rye, and barley. The pathophys is an autoimmune damage that leads to loss of the villi with subsequent malabsorption. Increased incidence in females, European descent as well. And clinical manifestations will be malabsorptive, such as with diarrhea, abdominal pain and distension, bloating, and also steatorrhea, which is fat in the stool due to decreased absorption. Also growth delays if this happens in children. They can't absorb the nutrients. Classically, dermatitis herpetiformis, which is a pruritic papulovesicular rash most commonly on the extensor surfaces, neck, trunk, and scalp, which is very commonly associated, especially with celiac disease. Dermatitis herpetiformis. For diagnosis, it's a clinical diagnosis. Symptoms usually improve with a trial of gluten-free diet, but for screening, you can also do a transglutaminase IgA antibody test as the initial test of choice. You can also do endomysial IgA antibodies. But for definitive and confirmatory, you do a small bowel biopsy. This is the most definitive. And you'll see that atrophy of the villi. So for management, gluten-free diet, avoid the wheat, rye, and barley. Limit your oats. Rice, corn, and wine are actually safe. Also vitamin supplementation. So how I remember this is it's all involving A. So atrophic villi, IgA, tissue transglutaminase, alpha-gliadin, autoimmune condition, and endomysial A antibodies. So next for lactose intolerance. Lactose intolerance is the inability to digest lactose due to low levels of lactase enzyme. Lactase enzyme production normally declines in adulthood, normally, but this is especially common in African Americans, Asians, and South Americans. Clinical manifestations of lactose intolerance are loose stools, abdominal pain, flatulence, borborygmi after ingestion of milk or milk-containing products. For diagnosis, it's a clinical diagnosis, as symptoms usually improve after a trial of lactose-free diet, but you can also do the hydrogen breath test, which is the test of choice for lactose. Hydrogen produced when the colonic bacteria ferment the undigested lactose. This is usually performed after a trial of lactose-free diet if the diagnosis is uncertain. For management, of course, lactose-free diet or the use of enzymes like lactase enzymes. Lactaid, which is pre-hydrolyzed milk, you can also use as a supplement or as a substitute for regular milk. Next will be peanut allergies and tree nut allergies. Peanut and tree allergy will be next. Most are IgE mediated, but they may be non-IgE mediated or mixed. The risk factors most commonly is genetics, as well as, importantly, timing of exposure. So delayed introduction of nuts until over 3 years of age leads to increased risk. They'll have typical manifestations of allergies such as skin pruritus, flushing, diaphoresis, urticaria, and angioedema, contact urticaria. For oropharyngeal, sneezing, congestion, itchiness, respiratory wheezing, dyspnea, cough, cardiac arrhythmias, eyes, conjunctival injection, lacrimation, itchiness, GI, nausea, vomiting, abdominal pain, diarrhea. For neuro, some dizziness and syncope or a sense of doom is possible. For management, patient education about avoiding these things. Also, complete avoidance and epinephrine auto-injectors should be prescribed in the case of accidental exposure or reaction. If you want to manage the acute attack, antihistamines if mild, or epinephrine if severe. Next will be dumping syndrome. Dumping syndrome are symptoms of rapid gastric emptying and rapid fluid shifts when large amounts of carbohydrates, simple sugars, are ingested. This is often a complication of bariatric surgery. So food leaves quickly since the small stomach and thus the fluid shift, the osmolarity of the ingested contents is greater, so it pulls all the fluid in, causing bloating, etc. So these early symptoms it causes are bloating, flatus, diarrhea, abdominal pain, nausea and vasomotor symptoms like diaphoresis, dizziness, tachypnea, hypotension, and flushing, often within 15 minutes of ingestion. Some of the late symptoms are hypoglycemia as well as syncope. Diagnosis is clinical. You can also do a modified oral glucose tolerance test. Barium fluoroscopy and radionuclide scintigraphy can be used to confirm rapid gastric emptying. The management for this is to decrease the carbohydrate intake, especially the simple sugars, and eat more frequently with smaller meals, such as protein-rich foods, and separating solids from liquid intake by 30 minutes. Next will be peptic ulcer disease. These are gastric erosions of over 0.5 centimeters on imaging. Duodenal ulcers are 4 times more common, but they're usually benign, and gastric ulcers are 4% associated with gastric adenocarcinoma. For pathophysiology, it's an imbalance between increased aggressive factors in the duodenal and gastric area, like hydrochloric acid and H. pylori, between balancing decreased protective mechanisms with the gastric ulcers, and this is BMP, bicarb, mucus, and prostaglandins, which are inhibited by NSAIDs. So it's the balance between these two things. Etiologies, Helicobacter pylori is the most common cause of gastritis, and NSAIDs and aspirin are the second most common cause. These lead to more commonly gastric ulcers, especially due to the prostaglandin inhibition. Zollinger-Ellison syndrome, which is a gastrin-secreting tumor, it's 1% of all cases of peptic ulcer disease. Also importantly, alcohol, smoking, and stress, physiologic stress due to burns, trauma, surgery, or severe medical illness, as well as males, elderly, steroids, and gastric cancer, are all risk factors. For clinical manifestations of peptic ulcer disease, dyspepsia, burning, nausea, epigastric pain is hallmark. For duodenal ulcers, dyspepsia classically relieved by food, such as the mnemonic, "Do give me food," Also, antacids or acid suppressants. It's worse before meals or 2 to 5 hours after meals, as well as increasing nocturnal symptoms with duodenal. For gastric ulcer, symptoms classically worse with food, especially 1 to 2 hours after meals, and they could also have weight loss. For a bleeding ulcer, hematemesis, melena, hematochezia are common. Peptic ulcer disease is the most common cause of upper GI bleeding as well. And remember, diverticulosis, the most common cause of lower GI bleeds. In a perforated ulcer, you may see sudden onset of severe abdominal pain. It may radiate to the shoulder. Also peritonitis, rebound tenderness, guarding, and rigidity if it is perforated. For diagnosis, upper endoscopy with biopsy is the diagnostic test of choice. And remember, all gastric ulcers need repeat upper endoscopy to document healing even if they're asymptomatic. And that's all gastric ulcers, not duodenal. H. pylori testing, there's 4 different things you can do. So 1 would be endoscopy with biopsy. This is the gold standard in diagnosing the H. pylori infection. A rapid urease test and direct staining can be performed on the biopsy specimen itself. For 2, the urea breath test. This is non-invasive, and H. pylori converts labeled urea into labeled carbon dioxide, so breathing out the labeled urea shows us the presence of H. pylori. For 3, H. pylori stool antigen, that's the HPSA. It's over 90% specific. It's useful for diagnosing H. pylori and confirming eradication after therapy, after it goes away, which is important. And lastly, serological antibodies. Only useful in confirming H. pylori infection, not eradication, as of course the antibodies can stay elevated long after the eradication of H. pylori because it was the body's response to it in the first place. For management of H. pylori positive, we can do the triple therapy, which is clarithromycin plus amoxicillin plus PPI for 10 to 14 days, and remember, metronidazole if penicillin allergic. And you could also do the quadruple therapy, which is the bismuth quadruple therapy, which is bismuth salicylate, tetracycline, metronidazole plus a PPI for 14 days. And if it's refractory, you could also do a parietal cell vagotomy. So the vagus nerve is parasympathetic, which would increase acid secretion. So if we cut the vagus nerve there, then we're going to have decreased overall acid secretion. And if it's H. pylori negative, we want to continue using PPIs, H2 blockers, misoprostol, antacids, bismuth compounds, and sucralfate as well to coat the GI tract. So again, we'll go through the differences between duodenal and gastric ulcers. First, the causative factors. Duodenal ulcers are an increase in damaging factors, especially H. pylori, as well as acid and pepsin. For gastric ulcers, a decrease in mucosal protective factors is more common. That's again your BMP, bicarb, mucus, and prostaglandins. So we have decreased mucus production, decreased bicarb production, or decreased prostaglandins as they're inhibited by NSAIDs. So for gastric, it's more so a decrease in the protective, whereas duodenal, it's an increase in the damaging. The incidence of duodenal is most commonly in the duodenal bulb. It's almost always benign, and it's 4 times more common. However, for gastric ulcers, it's more common in the antrum of the stomach, near the pylorus, and also 4% are malignant as well. So again, all gastric ulcers need repeat endoscopy to document the healing. For pain, duodenal ulcers are better with meals, as opposed to gastric ulcers which are worse with meals. And for age, it's more common in younger patients to have a duodenal ulcer, 30 to 55, and a gastric ulcer, think about its association with cancer, it's more common in older patients over 55. So we'll go through the medical management of peptic ulcer disease. So first for the medications, proton pump inhibitors like omeprazole, lansoprazole, pantoprazole, etc. The mechanism is blocking a hydrogen potassium ATPase proton pump of the parietal cell, therefore reducing acid secretion. It's more effective than an H2 receptor antagonist, but of little clinical difference after 4 weeks in uncomplicated cases. PPIs are associated with faster symptom relief and healing, and it usually takes 30 minutes to start working, so you want to take 30 minutes before the meals in the AM, and it's a low risk in pregnancy. For indications, this is the most effective drug to treat peptic ulcer disease. You can also use it in gastritis and Zollinger-Ellison. For side effects, B12 deficiency is important to note. Also sometimes diarrhea, headache, hypomagnesemia, hypocalcemia, and no omeprazole is associated with C. diff infections and hip fractures. But importantly, the B12 deficiency. For drug interactions, again, omeprazole causes that CP450 inhibition, increasing levels of theophylline, warfarin, phenytoin, etc. For H2 receptor antagonists, this is your cimetidine, ranitidine, famotidine, nizatidine. The mechanism is an H2 receptor blocker, directly inhibits the proton pump itself, reduces acid and pepsin secretion, especially nocturnally. Ranitidine is 6 times more common, or rather more potent than cimetidine. So ranitidine is much more potent than cimetidine, and it's usually taken at night. So again, side effects are those B12 deficiency and also CP450 inhibition, which increases many different drug levels. Also, there's note anti-androgen effects of cimetidine, like gynecomastia, as well as impotence. For misoprostol, this is a prostaglandin analog, prostaglandin E1 analog, that increases bicarb and mucus secretion and reduces acid production overall. Misoprostol is good for preventing NSAID-induced gastric ulcers, but not for healing the already existing NSAID-induced ulcers. It's also used to keep the patent ductus arteriosus, and it has some side effects and contraindications, especially in premenopausal women, because it's an abortifacient and causes cervical ripening. So remember, this is the opposite of what NSAIDs do in the GI tract, so you can see why it'd be helpful. For antacids, the mechanism is to neutralize the acid, prevent conversion of pepsinogen to pepsin, its active form. These are calcium carbonate, which is TUMS, and some side effects are acid rebound, importantly, as well as milk alkali syndrome. Some non-systemic antacids you can use are milk of magnesia, but it can cause diarrhea, such as it is actually a treatment for constipation. It's a saline laxative. We can also use amphogel, which is an antacid. It also can cause constipation and hypophosphatemia due to the increased calcium, magnesium, and simethicone as well. Bismuth compounds like pepto-bismol or kaopectate. The mechanism of bismuth compounds are an antibacterial and a cytoprotective that inhibits peptic activity. It has a limited role, but it's used in quadruple therapy, like we mentioned. And importantly, the side effects of bismuth are a darkening of the tongue and stool, also constipation and neurotoxicity in high doses, also salicylate toxicity in overdose. Sucralfate is next. Sucralfate is a cytoprotective. It forms a viscous adhesive ulcer coating that promotes healing and protects the stomach mucosa. So it's usually used as ulcer prophylaxis, better than a treatment. Some side effects are metallic taste, and also antacids may interfere with its action. It also can reduce the bioavailability of H2RAs and PPIs, which makes sense as it coats the GI tract, so nothing can really touch the real mucous membranes of the GI tract. And you also want to take this on an empty stomach. Next will be gastritis, acute gastritis. Gastritis is a superficial inflammation or irritation of the stomach mucosa with mucosal injury. Gastropathy, on the other hand, is a mucosal injury without evidence of any inflammation. For pathophysiology of acute gastritis, this is again an imbalance between aggressive, like H. pylori and acid, as well as protective, BMP, bicarb, mucus, and prostaglandins, mechanisms of the gastric mucosa. Some of the etiologies of acute gastritis are H. pylori as the most common cause, and number 2 most common cause are NSAIDs and aspirin. Acute stress in critically ill patients, such as physiologic stress, can also cause this. And other things like heavy alcohol consumption, bile salt reflux, medications, radiation, trauma, corrosives, ischemia, pernicious anemia, and portal hypertension can also cause some acute gastritis. Manifestations are mostly asymptomatic. If they are symptomatic, they're similar to peptic ulcer disease with the dyspepsia, also the nausea and vomiting. For diagnosis of gastritis, upper endoscopy with biopsy is the most important diagnostic test of choice, in which you'll see a thick edematous erosion that's under 0.5. Remember, an ulcer is over 0.5 centimeters. Also, it's important for diagnosis to do H. pylori testing. So again, that's the urea breath, the fecal antigen, the serum antibodies. For management of acute gastritis, similar to peptic ulcer disease, eradicate the H. pylori if that's the cause. Also, you can do acid suppression with the H2 or PPIs, or stop the offending agent and treat the underlying cause of the gastritis. Pharmacologic prophylaxis for patients at high risk of developing stress-related gastritis with IV PPIs or H2 blockers. Next, we'll go to autoimmune metaplastic atrophic gastritis. This is a form of chronic gastritis associated with chronic inflammation, gland atrophy, and epithelial metaplasia. Usually occurs in the gastric fundus and body, and usually spares the antrum. Patients are at an increased risk for developing gastric adenocarcinoma. Pathophysiology: T-cell mediated destruction of the onyctic mucosa in autoantibodies against intrinsic factor and parietal cells. So the lack of intrinsic factor here and the autoantibodies that have destroyed the parietal cells that secrete the intrinsic factor can lead to that B12 deficiency, which is of course called pernicious anemia. So the lack of parietal cells can lead to a hypochlorhydria and hypergastrinemia. Iron deficiency can occur because gastric acid normally enhances iron absorption. So remember, orange juice we take with our oral iron in iron deficiency anemia. So normally iron absorption is increased with acid. Next will be Zollinger-Ellison syndrome, which is a gastrinoma. So a gastrinoma is a gastrin-secreting neuroendocrine tumor. This leads to peptic ulcer disease and diarrhea, importantly. Most commonly seen in the duodenal wall, 45%, also the pancreas in 25%, and lymph tissue in 5 to 15%, and also other sites as well. So for clinical manifestations of Zollinger-Ellison, we want to suspect this gastrinoma in patients with severe, recurrent, multiple, or refractory ulcers and diarrhea. So diarrhea is an important component of Zollinger-Ellison syndrome. Severe peptic ulcer disease, multiple peptic ulcers, refractory ulcers, and abdominal pain. For diarrhea, the increased acidity inactivates the pancreatic enzymes, leading to malabsorption. So we have that steatorrhea, and we have diarrhea in general because the decrease in lipase and amylase. So it's really due to the pancreas in Zollinger-Ellison syndrome why we have that diarrhea as well. For diagnosis of the gastrinoma, it's established by demonstrating elevated basal or stimulated gastrin levels once endoscopy confirms the presence of an ulcer. For screening, elevated fasting gastrin level is the best initial test, over 1,000 picograms per milliliter, plus a gastric pH of under 2. So that means basically normal gastric pH. Confirmatory is a secretin test. Persistent gastrin elevations in gastrinomas. Normally gastrin release is inhibited by secretin. So other causes of hypergastrinemia are usually inhibited by secretin. You'll have a basal acid output test that you can do, which will show increase, and a chromogranin A, which will show increase in neuroendocrine tumors. So also the somatostatin receptor scintigraphy is the most sensitive test for tumor localization and to detect primary or secondary lesions, which may be combined with endoscopic ultrasound. Also, a gastrinoma is associated with increased somatostatin receptors. The management of Zollinger-Ellison is tumor resection. If it's metastatic or unresectable, you can do lifelong PPIs. If liver and abdominal lymph nodes are the most common sites for MET. For carcinoma tumors, carcinoid tumors are rare, well-differentiated neuroendocrine tumors that arise from the enterochromaffin cells. So the enterochromaffin cells. 50% of carcinoid tumors arise in the GI tract, and 30% are actually in the lungs. Carcinoid tumors are thought to arise from the transformation of the enterochromaffin-like cells, the ECL cells, which are responsible for histamine secretion, due to chronic stimulation by gastrin. Autoimmune atrophic gastritis is associated with hypergastrinemia and hypochlorhydria as well. So clinical manifestations of the carcinoid tumors are mostly asymptomatic, and it's usually an incidental finding on endoscopy, but they could have local symptoms depending on where the tumor is. They could manifest carcinoid syndrome, which is a periodic episode of diarrhea due to serotonin release, flushing, tachycardia, and bronchoconstriction due to the histamine release, and hemodynamic instability, such as hypotension. So it's a serotonin and histamine release that causes this carcinoid syndrome. For diagnosis of a carcinoid tumor, mostly are asymptomatic, again, a incidental finding. However, you can do a 24-hour urine 5-HIAA excretion at the end, which is the end product of serotonin metabolism. So it will show if we're using excess serotonin if you get the elevated 5-HIAA excretion. Also, a radio-labeled somatostatin analog can be used for localization, and a contrast-enhanced triple-phase CT of the abdomen and pelvis, or a contrast-enhanced MRI. So some options for management include surgical resection, but it depends on the site of the tumor. Next will be a gastric carcinoma. Types of gastric carcinoma are adenocarcinoma as the most common cause, which are 90%. 4% are actually lymphoma, and also carcinoid tumors, stromal tumors, and sarcomas. Risk factors for gastric carcinoma are H. pylori as the biggest risk factor, and that's associated with 90% of gastric carcinomas. Most commonly occur in males and over 40 years of age, and for dietary, preserved foods are a big risk factor, such as salt, cured, smoked, pickled foods, or foods containing nitrites. Diets low in raw fruits and veggies, and obesity are all risk factors for gastric carcinoma. Pernicious anemia, chronic atrophic gastritis, achlorhydria, smoking, blood type A, and post-antrectomy. Also non-Hodgkin's lymphoma. So remember, non-Hodgkin's lymphoma is the type that can metastasize around the body, whereas Hodgkin's lymphoma means the presence of the Reed-Sternberg cells. So non-Hodgkin's lymphoma is the area where it can manifest is the GI tract. So the stomach is the most common site for extranodal non-Hodgkin's lymphoma. For decreasing the risk of gastric carcinoma, this will be patients who use aspirin and NSAIDs, as well as an increased intake of fruits and veggies associated with a decreased risk overall of gastric carcinoma. Also, wine consumption is associated with decreased risk. Clinical manifestations, mostly advanced at the time of presentation, and weight loss and persistent abdominal pain, epigastric, vague, or mild. Also early satiety, abdominal fullness, nausea, postprandial vomiting, dysphagia, melena, hematemesis, iron deficiency anemia as well. But most importantly, weight loss and persistent abdominal pain, and early satiety. For gastric carcinoma, there's a few physical examination classic things that are needed to be known. So palpable or abdominal mass or signs of metastasis are supraclavicular lymph nodes, which are called Virchow's nodes, umbilical lymph nodes, which is Sister Mary Joseph's node, ovarian mets, which is the Kruckenberg tumor, and a palpable nodule on rectal exam, which is Bloomer's shelf. Also left axillary lymph node involvement, which is called the Irish sign, and also note these nodes may be seen with other GI tumors as well. For diagnosis, upper endoscopy with biopsy is the initial test of choice for most gastric cancers, but upper GI series is preferred if linitis plastica is suspected. Management, endoscopic resection for early local disease, gastrectomy, chemotherapy, and radiation for lymphoma, but it does have a poor prognosis as the patients usually present late in the disease, kind of like ovarian cancer as well. So that's gastric carcinoma. Next will be pyloric stenosis. Pyloric stenosis is hypertrophy and hyperplasia of the pyloric muscles, causing a functional gastric outlet obstruction, preventing gastric emptying into the duodenum. Most commonly, it is the most common cause of intestinal obstruction in infancy. For risk factors of pyloric stenosis, most common in the first 3 to 12 weeks of life, also with erythromycin use, importantly, within the first 2 weeks of life. So erythromycin is commonly used for that conjunctivitis prophylaxis, and it's also a treatment for gastroparesis, so it increases the contraction and motility, which I guess can lead to pyloric stenosis as well. So erythromycin use, know that. Also Caucasians, more common in males, 4 to 1, and firstborns. Clinical manifestations of pyloric stenosis, you'll have that non-bilious, classically projectile vomiting, especially after feeding, which is hallmark. They may have signs of dehydration, weight loss, and malnutrition, hypochlorhydria. Physical examination, palpable pylorus, again the classic olive-shaped mass, non-tender, mobile, hard mass to the right of the epigastrium. It's especially after emesis noted and hyperperistalsis, also a succussion splash on auscultation. For diagnosis of pyloric stenosis, abdominal ultrasound is typically used initially. You'll see an elongated, thickened pylorus, more sensitive and no radiation risk, is why you use the abdominal ultrasound. If you get an upper GI series, you may see the string sign, which is a thin column of barium squeezing through the narrowed pyloric canal with delayed gastric emptying, and also the railroad track sign, which is excessive mucosa in the pyloric lumen resulting in 2 columns of barium. So those are all diagnostics for pyloric stenosis. Also for labs, we'll see hypokalemia and hypochloremic metabolic alkalosis. So it's an alkalosis because we're getting rid of all that acid in the stomach, therefore weighing it more to an alkalotic pH. And it's hypochloremic because we're getting rid of HCl, so hydrochloric acid. Management is initially rehydration with IV fluids and electrolyte repletion, with potassium especially. And definitive is a pyloromyotomy to take out that stenosed pylorus. Next will be autoimmune hepatitis. Autoimmune hepatitis is an idiopathic chronic inflammation of the liver due to circulating autoantibodies. It's most common in young women, and complications of it include cirrhosis and also pericarditis, myocarditis, proliferative glomerulonephritis, and uveitis. Clinical manifestations of the autoimmune hepatitis are mostly asymptomatic. Physical exam may be normal, splenomegaly, hepatomegaly occasionally, but importantly for diagnosis, you'll have autoantibodies. For type 1, you'll have a positive ANA with smooth muscle antibodies, and type 2 will have anti-liver and kidney microsomal antibodies and an increased IgG. For LFTs, it'll be a hepatocellular pattern with an increased ALT greater than 1,000. It is a hepatitis. And for liver biopsy, that's definitive. You'll see bridging necrosis and multi-acinar necrosis. Management is steroids, corticosteroids plus azathioprine or 6-mercaptopurine. So overall for autoimmune hepatitis, you'll have that ALT over 1,000, hepatic symptoms, young woman, positive ANA, smooth muscle antibodies, and autoimmune drugs should be used like corticosteroids, azathioprine. Next we'll move into all the different hepatitis. So acute viral hepatitis versus fulminant hepatitis we'll start with, and then going into hepatitis A, B, C, D, etc. Acute viral hepatitis, the clinical manifestations are prodromal, icteric, and fulminant phases. So prodromal will be malaise, arthralgia, fatigue, URI symptoms, anorexia, a decreased desire to smoke, nausea, vomiting, abdominal pain, etc. And also hepatitis A is associated with a spiking fever. In the icteric phase, which is second, you'll have jaundice, although most don't develop this. And for fulminant hepatitis, you may see encephalopathy and coagulopathy due to the livers failing to make those coagulatory factors. Hepatomegaly, jaundice, edema, ascites, asterixis, and hyperreflexia due to the uremia. Laboratory values, increased AST and ALT, both usually over 500 if they are acute and under 500 if it's chronic. So it goes back down if it is chronic. And they also may have a hyperbilirubinemia. For outcomes of an acute viral hepatitis, usually clinically recover with taking 3 to 16 weeks. 10% of HBV and 80% of HCV becomes chronic. So in chronic hepatitis, the disease is over 6 months of duration, and only HBV, HCV, and HDV are associated with chronicity. Hepatitis A and E are not. For fulminant hepatitis, this will lead to encephalopathy, coagulopathy, jaundice, edema, ascites, asterixis, the flapping tremor, and hyperreflexia. So edema, it's all due to deficiencies in some of the liver functions. So the edema due to the decreased albumin, the ascites due to the also decreased albumin, the flapping tremor, the encephalopathy, the increased uremia causing the encephalopathy, coagulopathy due to the problem in creating 2, 7, 9, and 10, the jaundice due to the UGT deficiency as well. So for fulminant hepatitis, you have acute hepatic failure in patients with hepatitis. The most common etiologies of some fulminant hepatitis are actually acetaminophen toxicity as the most common cause in the US. It could also be caused by viral hepatitis, autoimmune hepatitis, and also drug reactions like tolcapone. Remember, it postpones dopamine reuptake in Parkinson's, but it's hepatotoxic. Also sepsis. Also Reye's syndrome. Reye's syndrome is fulminant hepatitis in children given aspirin after a viral infection. But remember, the most common cause of fulminant hepatitis overall is acetaminophen toxicity. Clinical manifestations, importantly, encephalopathy, vomiting, coma, altered mental status, seizure, asterixis, flapping tremor of the hand with wrist extension. Also increased intracranial pressure, cerebral edema, and hyperreflexia. Coagulopathy will also be noted in fulminant hepatitis with an increased PT and INR, also and eventually an increased PTT due to decreased hepatic production of those coagulation factors 2, 7, 9, and 10. Hepatomegaly and jaundice. And for Reye's syndrome, they may develop a rash on the hands and feet, intractable vomiting, liver damage, encephalopathy, dilated pupils in Reye's syndrome with minimal response to light, and multi-organ failure. For diagnosis of a fulminant hepatitis, it's a combination of symptoms, hepatic encephalopathy, abnormal LFTs, and an increased INR of 1.5 or greater. Hypoglycemia is common because the liver usually does gluconeogenesis to increase glucose, so hypoglycemia and also increased ammonia due to the encephalopathy, or which leads to encephalopathy rather. Also, you want to do for diagnosis labs to look for a cause, such as acetaminophen levels and viral serologies. For management of fulminant, it's supportive, however. IV fluids and electrolyte repletion. Also mannitol if increased intracranial pressure. PPIs for stress ulcer prophylaxis. And also blood products for platelet or cryoprecipitate used for active bleeding or coagulopathy. And liver transplant is definitive. So now moving to specific hepatitis viruses. Hepatitis A we'll start with. An acute viral infection of the liver due to hepatitis A infection. Transmission is fecal-oral, similar to HEV. Also fecally contaminated water and food, especially international travel, close contact with infected individuals as well. Clinical manifestations mostly asymptomatic, may be associated with spiking fever. Diagnosis are LFTs, you'll see elevated, especially ALT, over 1,000. And for acute, you'll see IgM, anti-HIV. Past exposure will be IgG, HAV, antibodies with a negative IgM. So IgM is acute, IgG is post. Management, no treatment needed. Fulminant hepatitis is very rare. Prevention, hand washing, and improving sanitation are the greatest impact to reduce transmission, as well as food safety and immunization. You could also do a pre-exposure prophylaxis in those that are increased risk for hepatitis A virus infection. 2 doses are given 6 months apart. But it's important to note that post-exposure prophylaxis is given to healthy individuals 1 to 40 years old. HAV vaccine is preferred over the immunoglobulin within 2 weeks of exposure. In healthy individuals over 40 years old, you want to do the HAV vaccine with or without the immunoglobulin, as opposed to the immunoglobulin alone, and again within 2 weeks of exposure. If they're immunocompromised or chronic liver disease over 1 year old, vaccine and immunoglobulin within 2 weeks of exposure. Next will be coagulopathy of liver disease. Coagulopathy of liver disease is decreased production of coagulation factors, proteins associated with advanced liver disease. Bleeding is the classic presentation, such as GI bleeding, especially varices, and may have signs of underlying liver disease. For diagnosis, you want to do your function studies, increased PT and INR, and a low albumin. Liver makes albumin. As these diseases advance, increased PTT will occur. So it's PT INR first with a low albumin, and then as it advances, again, increased PTT will occur. The coagulopathy corrects with mixing studies, and also there'll be a decreased fibrinogen. On CBC, you may also see a thrombocytopenia, and a peripheral smear may show target cells. And remember, thrombocytopenia because the liver also takes part in making thrombocytes, which are platelets. Management, cryoprecipitate if active bleeding or undergoing an invasive procedure. Cryoprecipitate if decreased fibrinogen, as it replaces fibrinogen factor 8 and von Willebrand's factor, and FFP, fresh frozen plasma, may be used in select patients to replace deficient coagulation factors if no response to cryoprecipitate. Correct the underlying cause and avoid alcohol consumption. Vitamin K does not correct the coagulopathy. Hepatitis E virus, HEV, is an acute viral infection from the liver due to hepatitis E infection. Transmission, like hepatitis A, it's fecal-oral, fecally contaminated water and food, blood transfusions, and also mother-to-child transmission. Most patients are asymptomatic. They'll have jaundice, hepatomegaly potentially, and increased risk for fulminant hepatitis in women that are pregnant. So that's very important. Embryo, hepatitis E virus, embryo, so you can remember fulminant hepatitis is possible in pregnant women. Some LFTs will be elevated in a hepatic pattern with ALT over 1,000. No treatments usually needed. IgM, anti-HEV, will be seen in acute infection, and it's not associated with chronic states. And again, high mortality due to fulminant hepatitis during pregnancy, especially during the third trimester. In pregnancy, the rate goes up between 10 to 25%, where normal mortality from HEV is only 1 to 3%. So hepatitis D virus is a defective virus that requires hepatitis B virus, hepatitis B surface antigen, to cause a co- or superimposed infection. The pathophys is HDV, uses the HB surface antigen as an envelope protein. HDV has a direct cytopathic effect, more severe hepatitis, and a faster progression to cirrhosis. Transmission is primarily parenteral, exposure to blood products or transfusions, same as HBV. Manifestations mostly asymptomatic. They may have that right upper quadrant pain, jaundice, dark urine, clay-colored stools due to the bile. For diagnosis, total anti-HDV. This is confirmed by immunochemical staining for liver biopsy and HDV RNA in the serum as well on PCR. Hepatitis B serologies are of course also performed. And prevention is hepatitis B vaccination. Hepatitis C virus, HCV, is an RNA virus. 85% of patients with HC virus develop chronic infection, C for chronic. Most common infectious cause of chronic liver disease, cirrhosis and liver transplantation. So that's typically a trick question. It's not alcohol as the most common cause of chronic liver disease. It's hepatitis C virus. Transmission, parenteral. IV drug use is the most common cause of transmission. Also needle stick injuries and increased risk if getting a blood transfusion before 1992. Also clinical manifestations, mostly asymptomatic. Some acute findings will have the right upper quadrant pain as well, jaundice, dark urine, myalgias, nausea, fatigue, etc. For diagnosis, importantly with HCV, you want to get the HCV antibodies, which usually become positive in the first 6 weeks, but this does not imply recovery, as it may become negative after recovery. Increase LFTs as well on screening. But confirmatory, importantly, is the HCV RNA. HCV RNA is more sensitive than the HCV antibody. So the RNA, of course, will show up as well with a negative antibody test sometimes because the antibody is almost the body's response to the RNA. So that's why we want to get the HCV RNA as the best test for this one. HCV RNA is the best way to determine viral replication activity as well. Genotyping is the most effective to determine effective treatment options. And for management, there are new regimens that have nearly equal efficacy, over a 95% cure rate with 12 weeks of oral therapy, and the response to therapy is determined by the PCR RNA load, viral load, at 12 and 24 weeks after therapy. So there are some options, and they're all antivirals. Older regimen also was ribavirin, but it's associated with increased adverse effects like psychosis, depression, thrombocytopenia, etc., and interferon as well as an older regimen. Some of the newer treatments may possibly reactivate hepatitis B, so perform hepatitis B virus testing prior to initiating treatment. And there is, of course, for prognosis an increased risk of cirrhosis, 20% over a 20 to 30 year period, hepatocellular carcinoma, a 3% risk, and liver failure. And for the all-important hepatitis B virus, HBV. Transmission is percutaneous, sexual, parenteral, or perinatal. And clinical manifestations of acute have again the three phases: the subclinical, icteric, and fulminant. And in the subclinical phase, classically the decreased desire to smoke in smokers. The icteric will have jaundice, and the fulminant will be acute hepatic failure with encephalopathy, coagulopathy, jaundice, edema, and ascites. For clinical manifestations of chronic, if it does go that way, however, only 10% of HBV go to chronic, we'll have the elevated LFTs, increased viral load, and persistent symptoms. For diagnosis, hepatitis B serologies. The hepatitis B surface antigen, surface antibody, and core antibodies are important to get. So we'll go through a variety of different diagnoses, such as what period they're in or where they are in the hepatitis B, and what the results will be. So if they're in the window period, they'll have a negative surface antigen, they'll have a negative antibody, they'll have a negative anti-HBC core antibody, which would be IgM, and for envelope will be negative as well. For acute hepatitis, the surface antigen will be positive, the HBS will be negative, the anti-HBC will be IgM. For resolved, we'll have a negative surface, a positive anti-HBS, and an IgG. For immunized, we'll have a negative surface, a positive anti-HBS, and a negative HBC. For chronic, will be positive surface antigen, negative HBC, positive IgG. LFTs in the acute setting, AST and ALT will be in the thousands. For chronic, ALT and AST in the hundreds range, or normal actually. For hepatitis B DNA, this is the best way to assess viral replication activity, and a liver biopsy can also be done to determine the extent of the damage. For the management of acute hepatitis B virus, supportive is the mainstay. The majority of patients will not progress to chronic infection. Remember, 10% of HBV, 80% of HCV. Management of chronic, antiviral therapy may be indicated if persistent, severe symptoms, also marked jaundice with a bilirubin over 10, inflammation on liver biopsy, an increased ALT, or positive HB envelope antigen persistence. So that means it's still infective and replicative. Options include entecavir, tenofovir, lamivudine, adenofovir, and telbivudine. Treatment can be stopped after confirmation of 2 consecutive tests 4 weeks apart that the patient has cleared the surface antigen. Hepatitis B vaccine. The recombinant hepatitis B vaccine, non-adjuvated, derived from yeast, is most commonly used for vaccination. And the vaccine schedule is 3 doses. If they're an infant, 0, 1, and 6 months, and 6 to 18 months rather. And if they're an adult, 0, 1, and 6 months. And there's contraindication to Baker's yeast. So important for we'll go into a little bit of the hepatitis B serologies and an example as well. So there are 5 variations to the hepatitis B that you must know. The window period, in which there's a positive core IgM, successful vaccination, positive surface antibody, acute hepatitis, positive surface antigen, positive core IgM antibody, so the body's response, chronic hepatitis, positive surface antigen, positive core IgG antibody. A distant resolved infection recovery would be a positive surface antibody, positive core IgG antibody. So antibody interpretation, positive hepatitis B surface antigen is either acute or chronic, and the hepatitis B surface antigen is usually the first positive serologic marker in acute. The core antibody determines if acute or chronic. Core IgM equals acute, core IgG equals chronic. For positive hepatitis B surface antibody, this is either recovery or vaccination, and that's surface. Now, if it's core antibody IgM, this is either window period or acute hepatitis because it's acute. And if it's hepatitis B core antibody IgG, this is resolved infection or chronic hepatitis. So step 1 is to look at the surface antigen. If it's positive, go to step 2. If the surface antigen, step 1, is positive, look at the core antibody. If it's IgM, it's acute. If it's IgG, it's chronic. And step 3 is only needed if the surface antigen was negative in step 1. In step 3, if the surface antigen was negative, look at the surface antibody. If it's positive, it's either vaccination or recovery, a distant infection. If the surface antibody is the only thing positive, then it's vaccinated, because vaccines don't get to the core. But if the core IgG antibody is positive, that means there's been recovery or a distant resolved infection. Okay. So next will be hepatocellular carcinoma. This is a primary neoplasm of the liver. The risk factors are chronic liver disease, HBV, HCV importantly, and cirrhosis. Also alpha-toxin B1 exposure from Aspergillus. Clinical manifestations of hepatocellular carcinoma are mostly asymptomatic. Some will have malaise, weight loss, jaundice, abdominal pain, and hepatosplenomegaly. For diagnosis of hepatocellular carcinoma, contrast-induced CT and MRI tailored for liver lesion evaluation, also liver biopsy. Management: surgical resection, if it's confined to a lobe and not associated with cirrhosis, and surveillance, of course, with ultrasound. Primary modality every 6 months, with or without AFP, alpha-fetoprotein, which is a marker for liver cancer. Performed in high-risk patients such as acute, active hepatitis B with a high AST or high viral load as well. Next will be Budd-Chiari syndrome, which is a hepatic vein obstruction. So Budd-Chiari syndrome is a hepatic vein outflow obstruction leading to decreased liver damage, or rather decreased liver drainage with subsequent portal hypertension and cirrhosis. It's the most common cause of portal hypertension in children. There's two types. There's a primary hepatic vein obstruction, which is hepatic vein thrombosis. Now remember, this isn't hepatic portal vein, this is hepatic vein itself, so on the way out of the liver. Secondary is hepatic vein or IVC occlusion, inferior vena cava, due to the exogenous tumor compression. So some of the risk factors for this are underlying thrombotic disorders like malignancy, polycythemia even, which steroids can cause, pregnancy, as well as clotting disorders. So there's a classic triad for hepatic vein obstruction, which is ascites, hepatomegaly, and right upper quadrant abdominal pain. So you're getting hepatomegaly because the liver is getting engorged because the blood can't flow out of it. It's the hepatic vein obstruction, not the portal vein. Rapid development of acute liver disease like jaundice and hepatosplenomegaly you may see, and also a subacute presentation is possible too. For diagnosis, ultrasound is the initial screening test of choice. You could do CT or MRI or venography. Venography is the gold standard, but it's not commonly performed. And if you do a biopsy, although it's not usually needed, you may see congestive hepatopathy, which is classically described as a nutmeg liver. So nutmeg liver is with Budd-Chiari syndrome with hepatic vein obstruction. Nutmeg liver. Management options include shunt decompression through the TIPS procedure, angiography with stenting, anticoagulation, thrombolysis. Thrombolysis is only done if it's an acute thrombus under 3 to 4 weeks and not involving the IVC as well. For ascites, you can do diuretics to remove the excess fluid, also counsel on a low sodium diet, and you could do a large volume paracentesis as well. For cirrhosis now, cirrhosis is a mostly irreversible liver fibrosis with nodular regeneration secondary to chronic liver disease. The pathophys is nodules cause increased portal pressure. Macronodules are associated with a higher risk of hepatocellular carcinoma. And for etiologies of cirrhosis, chronic hepatitis C is actually the most common cause. Alcohol is the second most common. And chronic HBV and HDV are also causes. Non-alcoholic fatty liver disease, as well as obesity, diabetes, also hypertriglyceridemia, hemochromatosis, autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, which we'll go into, and also drug toxicity like acetaminophen. Clinical manifestations, general symptoms like fatigue, weakness, weight loss, muscle cramps, and anorexia. Also for physical exam of cirrhosis, importantly ascites, hepatosplenomegaly, gynecomastia, spider angiomas, telangiectasias, caput medusa, muscle wasting, bleeding, palmar erythema, jaundice, and Dupuytren's contractures. In hepatic encephalopathy we could also see, with confusion and lethargy due to increased ammonia levels, which are toxic to the brain, and for physical exam, asterixis, which is the flapping tremor with wrist extension, and fetor hepaticus, which is smelly breath due to lack of the detoxification products usually done by the liver. And of course, esophageal varices. For management, avoid alcohol and hepatotoxic meds, weight reduction, vaccinations against the hepatitis, treatment the underlying cause when possible. However, liver transplant is the definitive treatment. And also you want to screen with an ultrasound and AFP for, of course, hepatocellular carcinoma. That's alpha-fetoprotein and ultrasound. If they are having encephalopathy, lactulose or rifaximin can be done. Also neomycin is second line. So you want to use lactulose and rifaximin together. And protein restriction as well. For ascites, sodium restriction. We don't want them to hold on to any more water. Also diuretics, spironolactone, and furosemide. Although weird, they would recommend spironolactone with its side effect of gynecomastia if they're already having gynecomastia in cirrhosis. But anyways, paracentesis can also be done to pull off the fluid in ascites as a complication. Pruritus, cholecystiramine. Cholecystiramine is a bile acid sequestrant that reduces bile salts in the skin, leading to less irritation from the bile salts. So, also hepatocellular carcinoma surveillance, like we mentioned, every 6 months with ultrasound with or without AFP as well. And complications, of course, end-stage liver disease, hepatocellular carcinoma, esophageal varices, and spontaneous bacterial peritonitis, which is treated with ceftriaxone. So cirrhosis staging. So the child Pugue classification. So the child Pugue classification, it can probably be looked up, but just to mention some of the things that are contained within it. So it has a few parameters, and it's scored between 1, 2, and 3 points for each of those. So we want to measure bilirubin, serum albumin, PTR and INR, and remember later PTT gets affected as well, ascites, and hepatic encephalopathy. So those are what's involved in the child Pugue classification. And that's the determining the 1 and 2 year survival. You also have the MELD score, which is the model for end-stage liver disease. This is a slightly more accurate way to measure 3-month mortality. So this is just the 3-month mortality. Okay, so next we'll go over lactulose. Lactulose has a couple indications, one for constipation, as it's an osmotic laxative. It's a synthetic disaccharide sugar that's not absorbed, so it pulls water into the gut. So it's kind of like mannitol as well, except this works just in the gut. Hepatic encephalopathy is also an indication for lactulose. Bacterial flora convert lactulose to lactic acid, which neutralizes ammonia in patients with hepatic encephalopathy. Adverse effects of lactulose are bloating, flatulence, and diarrhea. And don't forget to add rifaximin as well to this. Next, for spontaneous bacterial peritonitis. This is an infection of the acidic fluid without perforation of the bowel. It's a complication of cirrhosis. So it's spontaneous, but it's no rupture. Etiologies are E. coli is the most common organism, also strep pneumoniae and anaerobes, but E. coli by far the most common. Clinical manifestations of SBP. This is fever, chills, abdominal pain, increased abdominal girth, and diarrhea. Physical exam, findings of ascites, shifting dullness, and fluid wave, as well as some abdominal tenderness. For diagnosis, you want to do a paracentesis, which is the test of choice. And it would show a SAAG over 1.1 indicates portal hypertension, and a cell count of over 250 cells or greater determines the need for treatment. So that's an important one. They sometimes show you the acidic fluid and say how many cells it has in it. So it's important to know that a cell count over 250 cells per millimeter cubed or greater determines the need for treatment. So over 250 equals treatment. Gram stain is often negative, and you can also culture the fluid, which is the most accurate test. Management is ceftriaxone or cefotaxime for that gram-negative coverage, and those are 3rd gen. And prophylaxis after the initial occurrence is important. You want to do, for SBP, lifelong prophylaxis with Bactrim or norfloxacin, as SBP frequently recurs. This is a complication of cirrhosis, so these patients aren't just going to get better with one paracentesis. For non-alcoholic fatty liver disease, which will be next, NAFLD, non-alcoholic fatty liver disease, is an extremely common cause of mildly abnormal LFTs. Etiologies are obesity, hyperlipidemia, glucocorticoid use, and diabetes mellitus. So this progresses from NAFLD to NASH, non-alcoholic steatohepatitis. So NAFLD, non-alcoholic fatty liver disease, is relatively benign. It's not associated with fibrosis or malignant potential quite yet. But non-alcoholic steatohepatitis, NASH, is associated with inflammation and fibrosis and the potential to progress to cirrhosis, and it's potentially pre-malignant. So 2 stages, it goes NAFLD to NASH. For diagnosis, you want to do a biopsy is the most accurate. You'll see microvesicular fatty deposits similar to alcoholic fatty liver disease without the history of heavy alcohol consumption. The most pertinent component is to exclude a more serious cause of liver disease like malignancy. And you want to correct the underlying causes for management. So next we'll go into 2 commonly confusing topics of primary biliary cirrhosis or cholangitis, PBC, versus primary sclerosing cholangitis, PSC. So first for PBC, primary biliary cirrhosis or cholangitis, this is an idiopathic autoimmune disorder of the intrahepatic small bile ducts that leads to decreased bile salt excretion, cirrhosis, and end-stage liver. Most common in middle-aged women 30 to 60. Manifestations mostly asymptomatic. They may have a high alk phos due to the small bile ducts in the liver. And fatigue is usually the first symptom, as well as pruritus, of course, and right upper quadrant discomfort. Physical exam, hepatomegaly, jaundice, xanthelasmas, osteoporosis, signs of cirrhosis, and later disease. And for a diagnosis, a cholestatic pattern with increased alk phos and GDT. Importantly, which helps differentiate it, anti-mitochondrial antibodies are hallmark. Also hypercholesterolemia. Ultrasound can be done, and liver biopsy is definitive. Management is ursodeoxycholic acid as first line, which helps break down the bile acids. You can also do UV light for pruritus and cholestyramine, and liver transplant is definitive. So for PBC, primary biliary cirrhosis, middle-aged women, fatigue, hepatomegaly, jaundice, pruritus, but importantly, increased alk phos and GGT, and most importantly, anti-mitochondrial antibodies, and this is in the intrahepatic small bile ducts, as opposed to primary sclerosing cholangitis, which we'll go over now. Primary sclerosing cholangitis is also autoimmune. It's a progressive cholestasis leading to diffuse fibrosis of the intra and extrahepatic biliary ducts. So this extends out of the liver now. So that's why when I think of it has cholangitis in the name, and it's primarily sclerosing, so it goes to the intra and extrahepatic biliary ducts. As opposed to primary biliary cirrhosis or cholangitis, it has cirrhosis in the name, so I think of it mostly involving the liver. And so back to primary sclerosing cholangitis, the second one. This is risk factors, most commonly associated with IBD, ulcerative colitis. So that helps you remember that it's P-ANCA also. So PSC is P-ANCA, involved with ulcerative colitis as well. And this is in men 20 to 40, most common. And again, same complications, cirrhosis, liver failure, cholangiocarcinoma. Clinical manifestations, jaundice, pruritus, fatigue, hepatomegaly, splenomegaly, presents pretty similar. Diagnosis, again, a cholestatic pattern, increased alk phos and GGT. And importantly, which helps differentiate it, positive P-ANCA is hallmark for PSC. Positive P-ANCA for PSC. And you can do an MRCP or an ERCP as the most accurate test. And you'll see the classic beaded appearance of the biliary ducts. And I'll have an image for that, which are narrowing and strictures. Liver biopsy is rarely used, and PSC is the only cause of cirrhosis where a liver biopsy isn't the most accurate test, because it also involves the extrahepatic biliary ducts. So management is stricture dilation for symptomatic relief, and cholestyramine for pruritus. Liver transplant is definitive. So again, just to compare them quickly, PBC, primary biliary cirrhosis, you'll have that anti-mitochondrial antibody, more common in women, middle-aged. And for PSC, primary sclerosing cholangitis, this is intra and extrahepatic biliary ducts. It's more common in men, and it's more common with ulcerative colitis, which helps you think of that P-ANCA. And both are a cholestatic pattern, GGT and alk phos. So next will be Wilson's disease. This is hepatolenticular degeneration. So Wilson's disease is a rare autosomal recessive disorder leading to copper accumulation in the body, especially the liver, the brain, kidneys, joints, and cornea, importantly. Pathophys of Wilson's is a defect in the copper transporting protein of chromosome 13, leads to the decreased biliary copper excretion due to decreased ceruloplasmin. So decreased ceruloplasmin. Decreased ceruloplasmin. Clinical manifestations, you may have hepatitis from the deposition there, cirrhosis, liver failure, and liver is the initial site of copper accumulation. For the CNS, you'll have some dysarthria, which is most common, as well as dystonia or Parkinson's-like syndromes with tremor, rigidity, bradykinesia. Psychiatric, some psychosis and delusions and personality changes, and in joints, arthralgias for copper deposition. On physical exam, for slit lamp examination, the very classic Kaiser-Fleischer rings, which are blue or green and brown pigmented rings due to copper deposition in the cornea. It's hallmark, but it's not specific. For diagnosis, they'll have decreased ceruloplasmin, they'll have increased 24-hour urinary copper excretion, labs will have elevated LFTs and hemolytic anemia, some molecular genetic testing can be done, and a liver biopsy is definitive. So remember, it deposits into the liver first, but classically we see the Kaiser-Fleischer rings in the eyes as well. And the management I remember as TZD6. So T, trientine, Z, zinc supplementation interferes with the intestinal copper absorption, so that helps. And D is D-penicillamine, and you have to give pyridoxine, which is B6, with the penicillamine to prevent B6 deficiency. So that's TZD6, trientine, zinc, D-penicillamine with B6. Next will be inguinal hernias. So first we'll start with indirect hernias. Indirect hernias are a type of inguinal hernia with bowel protrusion at the internal inguinal ring. This is the origin of the sac, which is lateral to the inferior epigastric artery. This is the most common type of hernia in both sexes, although more common in men, younger children, and young adults as well. The pathophys of the indirect hernia is often congenital due to a persistent patent process vaginalis. An increase in abdominal pressure may force the intestines through the internal ring into the inguinal canal and may follow the testicle tract into the scrotum. Clinical manifestations of indirect are mostly asymptomatic, swelling or fullness at the hernia site. It may enlarge as well with increased intra-abdominal pressure or standing as well due to the gravity, and they also may develop scrotal swelling. If it's incarcerated, it's painful, also enlarged. It's an enlargement of an irreducible hernia, so it's unable to return the hernia contents back into the abdominal cavity. Also, nausea and vomiting may be present if they have a bowel obstruction. Strangulated, which is even worse, this is ischemic incarcerated hernias with systemic toxicity. So it's irreducible hernia with compromised blood supply, and it's severely painful, and they may have severely painful bowel movements as well, and they may refrain from defecation. So incarcerated then can progress to a strangulation, which is ischemic. For diagnosis of indirect, this is a clinical diagnosis. You could also do a groin ultrasound, which is often the initial imaging of choice for an occult uncomplicated inguinal hernia. CT or MRI are also alternatives. For management, inguinal hernias are often repaired surgically, and strangulated are also importantly surgical emergencies. So next will be direct inguinal hernias. Direct inguinal hernias are a type of inguinal hernia with bowel protrusion, where the origin of the sac is medial to the inferior epigastric artery within Hasselbalch's triangle. So their mnemonic is when you see a direct message DM, direct is medial. Hasselbalch's triangle, it's said, can be remembered as RIP, the rectus abdominis. It's towards the medial border of the rectus abdominis. Also the inferior epigastric vessels, which is the lateral border, and Poupart's inguinal ligament, which is the inferior border. So it's between this is Hasselbalch's triangle. The pathophys of a direct inguinal hernia is occurring as a result of weakness in the floor of the inguinal canal, and most commonly found on the right side. Manifestations are very similar. mostly asymptomatic, some swelling or fullness at the hernia site. It also, again, enlarges with increased intra-abdominal pressure or standing due to gravity, and it can also progress to incarcerated or strangulated. Incarcerated, again, a painful enlargement of an irreducible hernia, nausea and vomiting if a bowel obstruction is present. And for strangulated, ischemic incarcerated hernias with systemic toxicity, it is an irreversible hernia, or rather an irreducible hernia with compromised blood supply. And they could have severely painful bowel movements as well in strangulated. So again, this is a surgical emergency, and strangulated is worse than incarcerated. It's a progressive step. Diagnosis, clinical, you can do ultrasound and of course CT and MRI. And surgical repair for inguinal hernias is often required, and again, strangulated are surgical emergencies. A few other types of hernias to go through are femoral hernias. So femoral hernias are a protrusion of the contents of the abdominal cavity through the femoral canal below the inguinal ligament. This is most commonly seen in women, so femoral, female, most commonly seen in women. They occur later in life as compared to inguinal hernias as well. So because the femoral ring is smaller in women, they often become incarcerated or strangulated compared to inguinal hernias. There's also umbilical hernias. This is a hernia through the umbilical fibromuscular ring. It's congenital often due to failure of the umbilical ring closure, and it's usually due to loosening of the tissue around the ring in adults, if it is adults. There's also incisional or ventral hernias. This is herniation through weakness in the abdominal wall, and incisional hernias are most commonly occurring with vertical incisions in obese patients. There's also obturator hernias. This is a rare hernia through the pelvic floor in which the abdominal pelvic contents protrude through the obturator foramen. It's most commonly in women, especially multiparous women, and women with significant weight loss as well. So next we'll go to management of diarrhea and the different diarrheal illnesses. So the first step in management of diarrhea is fluid repletion. This is the mainstay of management in gastroenteritis, and oral rehydration is preferred. Sports drinks, broths, IV saline can be used, Pedialyte as well. So, and also diet is step 2. So a bland, low residue diet, the classic brat diet, bananas, rice, applesauce, and toast. Antimotility agents is third. Indications for antimotility agents are patients under 65 with moderate to severe signs of volume depletion. Contraindicated, do not give antimotility agents to patients with invasive diarrhea, as it may cause further toxicity. So some antidiarrheals that we'll go through are, first, bismuth subsalicylate, which we talked about previously. So this can be Pepto-Bismol or kaopectate. The mechanism, again, is antimicrobial properties against bacterial and viral pathogens, and salicylate is an anti-secretory and an anti-inflammatory, of course. Side effect is dark-colored stools and darkening of the tongue, and contraindicated in children with a viral illness, as salicylates are associated with increased risk of Rye syndrome. Also, an antidiarrheal are opioid agonists, such as diphenoxylate or atropine, and loperamide. The mechanism of action of these are binding to the gut wall opioid receptors, inhibiting peristalsis, and side effects are CNS, central opiate effects. So anticholinergic side effects as well, some nausea, vomiting, abdominal pain, but most importantly, the side effect is constipation, as they are an opioid. They're indicated for non-invasive diarrhea as well, and avoid in patients with acute dysentery or colitis. And lastly, for the antidiarrheals, anticholinergics like phenobarbital, hyoscyamine, and scopolamine. Mechanism of action, of course, anticholinergic, especially the hyoscyamine, atropine, and scopolamine. They inhibit acetylcholine-related GI motility. They relax the GI muscles, antispasmodic, decrease gastric secretions, and phenobarbital lowers the GI motility. So remember we used hyoscyamine as well in IBS management too, as an antispasmodic. Next will be antiemetics we can also use. So vomiting is usually due to an imbalance of neurotransmitters such as serotonin, acetylcholine, dopamine, and histamine. So with this imbalance, we can use medications to rebalance it or change it. So ondansetron, grensitron, and dolancitron can be used, most commonly ondansetron, which is Zofran. The mechanism blocks serotonin receptors, so it's an anti-serotonergic. Blocks 5-HT3, both peripherally and centrally, in the chemoreceptor trigger zone. Side effects are some neurologic and cardiac. Neurologic, some headache, fatigue, sedation, GI bloating, diarrhea, constipation. But importantly for cardiac, prolongs the QT and cardiac arrhythmias as well. So it's an anti-serotonergic and it prolongs the QT for ondansetron. For dopamine blockers, we have prochlorperazine, promethazine, and metoclopramide. So dopamine blockers block CNS dopamine receptors, D1 and D2. They also have some mild antihistaminic and muscarinic effects. And also remember, metoclopramide is also a prokinetic agent, so it increases GI motility. Side effects of these drugs are QT prolongation. So it is an antipsychotic basically, since it is a blocker of dopamine. So you'd expect some QT prolongation. Also anticholinergic and antihistamine side effects like drowsiness, hypotension, and hyperprolactinemia, which we also saw with the antipsychotics. Also extrapyramidal symptoms as side effects, so rigidity, bradykinesia, tremor, and akathisia, which is a type of restlessness. You could have dystonic reactions as well, dyskinesia, which is reversible EPS hours to days after the initiation of these meds. It's intermittent, spasmodic, also sustained involuntary contractions like trismus, protrusions of the tongue, forced jaw opening, facial grimacing, speech difficulty, and torticollis. The management for this is diphenhydramine IV or add an anticholinergic agent like benztropine. So we want to balance it out, kind of like when we're treating Parkinson's as well. So management for this, again, we want to give an anticholinergic agent, so diphenhydramine has those properties as well as benztropine. And also Parkinsonism as well is a side effect, so due to decreased dopamine in the nigrostriatal pathway, you'll see more rigidity as well as tremor. So now we'll go over some highlights of invasive diarrhea versus non-invasive diarrhea. So non-invasive diarrhea is due to enterotoxins, which increase GI secretion of electrolytes, leading to a secretory diarrhea, and there's no cell destruction or mucosal invasion, as opposed to invasive diarrheas, which are cytotoxic, and they cause mucosal invasion and cell damage. So the areas affected are also different. For non-invasive, you have the small bowel being affected more, which leads to large voluminous stools, as opposed to invasive diarrheas, which affect mostly the large bowel, which lead to many small volume stools and high fever as well. For non-invasive, you typically have a lot of vomiting, and for invasive, you don't really have vomiting. For non-invasive, fecal blood, white blood cells, and mucus are absent, and some examples of non-invasive are viral gastroenteritis, Staph aureus, Bacillus cereus, Vibrio cholera, and enterotoxigenic E. coli. For invasive diarrheas, you will have fecal blood, white blood cells, and mucus, and it's an enterohemorrhagic E. coli, not toxigenic. Enterohemorrhagic E. coli for invasive, also Shigella, Salmonella, Yersinia, and Campylobacter. So differentiating those is important. Remember, the enterotoxigenic E. coli is non-invasive, and the enterohemorrhagic E. coli is invasive. So next will be the non-invasive enterotoxin infectious diarrheas. So again, non-invasive is more vomiting, watery, voluminous, as it involves the small intestine, and it has no fecal white blood cells or blood. Norovirus gastroenteritis is the most common overall cause of gastroenteritis in adults in North America, and the most common cause of viral gastroenteritis worldwide. The peak incidence is in winter, but it can occur any time of the year. And the transmission is fecal-oral, contaminated food and water, fomite contamination, and it's associated with outbreaks on cruise ships, hospitals, restaurants, etc. So somebody said Noro, think Navy, or Norwegian cruise line. So Noro can be remembered as a very common outbreak in these areas. Clinical manifestations, typically a lot of vomiting and 1 to 2 day incubation period. And management is fluid replacement. Rotavirus is most commonly seen in young under-immunized children between 6 months and 2 years. So rotavirus in kids under-immunized. fecal oral route, and incubation is under 48 hours. You can diagnose it with PCR testing, and oral rehydration is the mainstay. Staph aureus gastroenteritis, also continuing with the non-invasive here. It has a short incubation period within 6 hours as well. And you need to be cautious of the source being food contamination. So dairy products, mayonnaise, meats, eggs, and salads especially. So when they're left out for a while and left out at room temperature for Staph aureus. They'll have prominent vomiting and nausea and abdominal cramps. And management is fluid replacement, of course, and IV if they're unable to tolerate oral. So for Staph aureus, it's just that short incubation period and the infection being from dairy products, mayonnaise, meats, eggs, and salads. Next will be Bacillus cereus gastroenteritis. This also has a short incubation period within 6 hours, so it's similar to Staph aureus. It's an enterotoxin that can survive reheating, and the most common pathognomonic thing is fried rice. So Chinese food leftovers are typical of Bacillus cereus gastroenteritis. Again, prominent nausea and vomiting, and fluid replacement is the treatment. Enterotoxigenic E. coli, still in non-invasive. Enterotoxigenic coli is the most common cause of traveler's diarrhea. So risks are contaminated food and water. Contaminated water includes unpeeled fruits washed in water and untreated drinking water or ice. It produces heat-stable toxins and heat-labile toxins. Incubation period is 2 to 3 days. Clinical manifestations: abrupt onset. You should do gram cultures and stain. And management is oral rehydration. It's usually self-limiting. And remember, you can use the antidiarrheals like loperamide or bismuth subsalicylate for this as well. Next we'll go to Vibrio cholera. Vibrio cholera, importantly, is a gram-negative, which will explain its treatment, comma-shaped rod transmitted via contaminated food and water. Outbreaks may occur during poor sanitation and overcrowded conditions, especially abroad. And the pathophys is exotoxins, causing a secretory diarrhea, inhibition of water, sodium, and chloride absorption, which may cause a profound diarrhea and dehydration, and hypovolemia. So massive hypovolemia, dehydration, and electrolyte depletion. Clinical manifestations of Vibrio cholera are vomiting, abdominal pain, borborygmi, cramping, and copious watery discharge, rice water stools, classically, gray with flecks of mucus, and may have a fishy odor, but no fecal odor, blood, or pus. So it's still a non-invasive for Vibrio cholera. And that's that classic rice water stool. It's a clinical diagnosis, and the management is oral rehydration is the mainstay, but you can also use tetracyclines, which are the first-line antibiotic if you needed. So fluoroquinolones or macrolides can also be used. Tetracyclines are the first line for this, and antibiotics may shorten the course of the disease in patients who are severely ill or have other comorbid conditions or with a high fever, although a high fever is more typical of an invasive diarrhea. For prevention of Vibrio cholera in areas where it is endemic, you want to use bottled water, wash hands with soap and safe water, or use chemical toilets, and cook food thoroughly. Okay, so Vibrio parahemolyticus and vulniferus. So these are gram-negative rods, so they're still in the Vibrio category, but they're Vibrio parahemolyticus and vulniferus. So gram-negative rods transmitted via raw or uncooked shellfish consumption and seawater. Interesting. So direct contact of water with the wounds or shucking oysters, especially during warm summer months. Vibrio parahemolyticus causes gastroenteritis, and Vibrio vulnificus causes gastroenteritis. Also importantly, necrotizing fasciitis and cellulitis. So this is the most common cause of death from seafood consumption in the US, Vibrio vulniferus. So I think Vibrio vulniferus as vulnerable. It's the most common cause of death from shellfish as well. And you can use a tetracycline for this too, as it's still part of the Vibrio family and it's gram-negative. So risk factors are underlying liver disease, cirrhosis, alcoholism, etc., and immunocompromised as well. So even those who have diabetes. Gastroenteritis, you'll have diarrhea, abdominal cramps, etc. Cellulitis due to the wound exposure to the seawater or estuarine water, and necrotizing fasciitis, hemorrhagic bulla may rapidly progress to shock. So this is very serious. Clinical stool studies, wound cultures, and blood cultures should be gotten. And if it's just a gastroenteritis, you can just rehydrate them. If you have the cellulitis, it's tetracyclines. And if you have the neck fash, it's emergent surgical debridement plus broad spectrum antibiotics as well. So very important for that. Next will be C. diff, Clostridioides difficile. So Clostridioides difficile, formerly Clostridium, is a spore-forming, importantly, toxin-producing, gram-positive anaerobic bacterium. So it's gram-positive, that's why it's responsive to vanc. So risk factors, recent antibiotic use, especially clindamycin, importantly, advanced age, gastric suppression with PPIs, etc., and also long hospital stays. The pathophys of C. diff is an organism overgrowth secondary to alterations of the normal GI flora, most commonly seen after a course of antibiotics, especially clindamycin in adults and amoxicillin in children as well, or chemotherapy, which wipes out everything. It can also be healthcare associated, like we said. Clinical manifestations are a watery, non-bloody diarrhea, it's non-invasive still, abdominal cramps, fever, and abdominal tenderness as well. Complications include pseudomembranous colitis, bowel perforation, and toxic megacolon. Importantly, toxic megacolon, and you'll remember over 6 centimeters dilated is toxic megacolon. For diagnosis, you can do the C. diff toxin from the stool, which is the initial test of choice, and you'll find also a leukocytosis with increased white blood cell count, which is classic. Sigmoidoscopy in select patients, you'll find pseudomembranes, importantly. So there's a few things to know for the management of C. diff, which again is a non-invasive diarrhea, is importantly discontinuing the offending antibiotic, which is most commonly Clinda in adults and amoxicillin in kids, which is the initial step of management. Also, importantly, contact precautions and hand hygiene. Hand hygiene with soap and water may be more effective than alcohol-based hand sanitizers in removing the C. diff spores, because spores are resistant to killing by alcohol, so you just want to wash them off basically. Oral vanc or oral fidaxomicin are the first line agents. Metronidazole is an alternative agent. And remember, this is oral, not IV. This is the really only indication for an oral vanc. Second recurrent episode, Clostridium difficile episode, you want to do a pulse tapered oral vanc or fidaxomicin. If it's recurrent, treat it with metronidazole, do oral vanc. And if it's frequently recurrent, at least 3 occurrences, you can do a fecal microbiota transplant. Okay, so now we'll move to invasive infectious diarrhea. So just to recap invasive infectious diarrhea, invasive is a high fever, positive blood and fecal leukocytes, and it's not as voluminous due to the large intestine involvement as opposed to small intestine in non-invasive, and invasive also has mucus as well. So do not give any anti-motility drugs with invasive diarrhea, as it may cause worse toxicity. Some of these invasive examples are Campylobacter, Shigella, Salmonella, Yersinia, enterohemorrhagic E. coli, not enterotoxigenic, and also Campylobacter, like we said. So first we'll go into Yersinia enterocolitica. It's a gram-negative, so it says enterocolitica, so I think E. coli is negative, gram-negative, so gram-negative coccobacillus with bipolar staining, and it looks like a safety pin appearance. So safety pin appearance. Sources are contaminated pork, as the most common in the US. And clinical manifestations are fever, abdominal pain, and importantly mimics acute appendicitis. So mimics acute appendicitis in Yersinia. It can also cause mesenteric lymphadenitis, producing abdominal tenderness or guarding. Diagnosis is cultures, as well as pharynx and mesenteric nodes. And management is electrolyte replacement and fluid replacement. You can also, if it is severe, use some gram-negative coverage like Bactrim or fluoroquinolones for Yersinia. Next will be Campylobacter enteritis. Campylobacter jejuni is the most common cause of bacterial enteritis in the US, so that's very important. Most common cause of bacterial enteritis in the US, and this is invasive. Campylobacter jejuni is the most common antecedent event in post-infectious Guillain-Barré syndrome, and most commonly affects children and young adults with a 3-day incubation period. Sources of Campylobacter jejuni are contaminated food, raw or undercooked poultry as the most common, also raw milk, contaminated water, and puppies are an important source in children. Clinical manifestations: fever, crampy periumbilical abdominal pain. So just like Yersinia, it can also mimic acute appendicitis. And the diarrhea is initially watery but progresses to bloody. So remember, Yersinia is that mimicking of appendicitis in abdominal lymphadenitis. But for Campylobacter, we also can have a mimicking of appendicitis, especially because it's more common in kids and young adults. So for diagnosis of Campylobacter, we want to do a stool culture. We'll see gram-negative S or comma-shaped seagull-shaped organisms. So comma or seagull-shaped organisms. Enzyme immunoassay or PCR. Management of Campylobacter, fluid and electrolyte replacement is the mainstay of treatment. It's usually mild and self-limited with a peak of illness lasting 1 to 2 days. If it is severe or in high-risk immunocompromised patients, you should use a macrolide actually as the first-line antibiotic when needed, such as azithromycin. Loperamide and other antimotility agents are avoided, and proper food handling and washing can prevent the spread. So this is interesting because it's a gram-negative. However, macrolides are the first antibiotic of choice, such as azithromycin. So I've gotten questions where it would give you azithromycin or other antibiotics that cover gram-negative, and the choice is azithromycin for Campylobacter. Next will be enterohemorrhagic E. coli, 0157H7. So enterohemorrhagic E. coli, 0157H7. Sources of this are especially ingestion of undercooked beef, unpasteurized milk or apple cider, daycare centers, and contaminated water, and the incubation period takes a long time comparatively, for 4 to 9 days. Pathophys is a Shiga-like toxin, a varotoxin that causes endothelial damage leading to hemorrhage. It's most commonly seen in children and elderly. So this is a leading cause of that hemolytic uremic syndrome. So no antibiotics, so they must pass it by themselves, as the antibiotics would release more of the toxin, so that would not be good. So watery diarrhea for clinical manifestations is seen early on before becoming bloody, and crampy abdominal pain and vomiting are also seen. For management of the enterohemorrhagic E. coli, you want to do fluid replacement as the mainstay, of course, avoid antimotility drugs, and avoid antibiotics, like we said, in children due to the increased incidence of hemolytic uremic syndrome, HUS, due to an increased release of the Shiga-like toxin when it does actually kill the bacteria. So you really would just want to flush the bacteria out in this one, as opposed to killing it, which releases more toxins. Next will be typhoid or enteric fever, typhoid fever. So typhoid fever is a diarrheal illness most commonly caused by a gram-negative rod, Salmonella typhi, and paratyphi. Most common in children and young adults, and it also has a long incubation period, from 5 to 21 days. The transmission is fecal-oral, could be from food or water, and importantly, a history of travel to areas where sanitation is poor, like South Central Asia, or contact with carrier. Pathophys is it crosses the intestinal epithelium barrier through M cells overlying the lymphoid follicles of Peyer's patches. It can also colonize the gallbladder in chronic carriers. Clinical manifestations: headache, intractable fever, chills, abdominal pain. Constipation initially followed by non-bloody diarrhea, and it may be a pea soup, green in color. So those are all bolded. So headache, intractable fever, chills, and abdominal pain in a pea soup green color for Salmonella typhi, which is typhoid fever. Also bolded for physical exam is a fever with a relative bradycardia, classic but rare, and rose spots occurring in the second week, and hepatosplenomegaly. Culture of the stool or blood, and for management is oral rehydration and electrolyte replacement as first-line management. Antibiotics are often given, and for antibiotics you want to use fluoroquinolones for first line. So Salmonella typhi is a gram-negative, so you can use fluoroquinolones for that. Okay, so non-typhoidal salmonella. So this is another salmonella species, which is one of the most common causes of foodborne disease in the US, and this is more from poultry, eggs, milk products, fresh produce, and importantly, contact with reptiles. So if you have like a pet turtle or something, you should always wash your hands before and after. So this is non-typhoidal salmonella, as opposed to typhoid fever. Clinical manifestations of this are nausea, vomiting, fever, abdominal cramps, diarrhea, but it still has the classic pea soup, green in color diarrhea, and it may be bloody, malaise, and headaches. Stool cultures for diagnosis and rehydration, electrolytes, etc., and also fluoroquinolones as well. For this non-typhoidal salmonella, our first line. Next will be shigellosis. Shigellosis is a diarrheal illness, most commonly caused by gram-negative rods again, and the name of the bacteria is Shigella sonii, which is most common in the US. There's also a couple other ones too. Children under 5 years old in daycare settings are at the highest risk for shigellosis, and the pathophysiology is Shigella dysentery produces Shiga toxins, enterotoxins that are neurotoxic, cytotoxic, and enterotoxic. For transmission, importantly bolded, is it's highly virulent with an incubation period of 1 to 7 days, and it's fecal oral in transmission. For shigellosis, the clinical manifestations are importantly lower abdominal pain, high fever, tenesmus, explosive, watery diarrhea that progresses to mucoid and bloody diarrhea. Neurologic manifestations, especially seen in young children, such as febrile seizures, and complications include Reiter syndrome, which is reactive arthritis, also hemolytic uremic syndrome, especially in children. So we said hemolytic uremic syndrome was also in the enterohemorrhagic E. coli, so it's also with Shiga as well, due to the Shiga-like toxin. So diagnosis of shigellosis is stool cultures, positive fecal white blood cells and red blood cells, as it is in invasive diarrhea. And for CBC, you will see a leukemoid reaction, which are white blood cells over 50,000. So that's important, bolded, CBC leukemoid reaction, white blood cells over 50,000 for shigellosis. On sigmoidoscopy, we could see punctate areas of ulceration as well. And for management, oral rehydration and electrolyte replacement are the mainstays of treatment. So how I remember this one is HFL, H, hemolytic uremic syndrome, F, febrile seizures and fluoroquinolone, and L, leukemoid reaction. So all the important bolded stuff are in HFL, hemolytic uremic, febrile seizures and fluoroquinolones, and L, leukemoid reaction. So again, for management, oral rehydration and electrolyte replacement, and antibiotics like fluoroquinolones or other gram-negative coverage. And also azithromycin can be used in shigellosis, just as it can be used in Campylobacter. Even though they are both gram-negative, it can also be used in that. Okay. Next will be protozoan infections. So first, Giardia lamblia. Giardia duodenalis, also known as Giardia lambula or Giardia intestinalis, is a protozoal parasite associated with sporadic or an epidemic diarrheal illness. So the sources of Giardia are ingestion of contaminated water, most commonly from a remote stream or well, or it's also called beaver's fever or backpacker's diarrhea, not to be confused with traveler's diarrhea. So this is Giardia backpacker's diarrhea or beaver fever. The pathophys is beavers are reservoirs for the protozoa, and outbreaks occur due to contaminated water, food, or fecal oral transmission. You'll have some frothy, greasy, foul-smelling diarrhea, steatorrhea, with no blood or pus, some abdominal cramps, etc. And diagnosis is by antigen assay, trophozoites, and cysts seen on stool examination. So you want to do that ova and parasites. Management, rehydration, and electrolytes, of course, and metronidazole for this one, importantly. So metronidazole is the first line for Giardia. You can also do tinidazole, albendazole as well. Next is amoebiasis, Enantamoeba histolytica. Amoebiasis and Enantamoeba histolytica are a protozoan, most commonly transmitted by ingestion of cysts from fecally contaminated water or food. It's not that common in the US and more occurs from migrants from travelers to endemic areas. It's also associated with amoebic liver abscess, importantly. So mostly are asymptomatic. For GI symptoms, they might have a few weeks of subacute mild diarrhea to severe dysentery, abdominal pain, etc., bloody stools, mucus, weight loss, fever. And the liver abscess could give you fever, right upper quadrant pain, or anorexia. For diagnosis, stool microscopy with ovarian parasites. You'll see the cysts ingested with red blood cells. So because the cysts are not constantly shed, at least 3 stool samples on different days should be examined. You can also do antigen testing, which is pretty sensitive, and stool PCR detects the parasitic DNA or RNA in the stool. And for liver abscess, if you're suspecting that, you could do a liver ultrasound, CT, or MRI. For management of amoebiasis, you can do, if it is colitis, metronidazole, paromomycin, importantly. So metronidazole or paromomycin, also tinidazole. And paromomycin is a intraluminal parasitic, so that's what you want to use. And for liver abscess, metronidazole or tinidazole plus the intraluminal antiparasitic, followed by chloroquine. So they may also need drainage if no response to meds after 3 days. So if they do have that amoebic liver abscess, you use metronidazole, the paromomycin, and chloroquine, so 3 drugs. Next, to go over secretory diarrhea. The etiologies are hormonal, serotonin, such as in carcinoid syndrome. Remember the serotonin, diarrhea, calcitonin, medullary cancer of the thyroid, also gastrin secreting tumors like Zollinger-Ellison. So also remember Zollinger-Ellison syndrome with the steatorrhea and the malabsorption. Laxative use and Vibrio cholera as well for secretory diarrhea. Workup findings, you'll see a normal osmotic gap, large volume, and no change in diarrhea with fasting. For osmotic diarrhea, on the other hand, the etiologies are medications as most common, lactulose, sorbitol, antacids, bacterial overgrowth, Whipple's disease, and tropical sprue. For malabsorption, celiac disease, pancreatic insufficiency, as we're not being able to digest fats and even some carbs from amylase, and lactose intolerance as well. So the workup findings in an osmotic diarrhea would be decreased diarrhea with fasting, increased osmotic gap, increased fecal fat, deficiency in fat-soluble vitamins A, D, E, and K as well. And finally, lastly, for the diarrheal illnesses, we have Whipple's disease, which is Trophaemia whipplei. This is a gram-positive, non-acid-fast, periodic acid Schiff positive rod. The contamination is, or the transmission is contaminated soil, most commonly seen in farmers. The manifestations are malabsorption as well as a non-deforming arthritis. Neurologic symptoms will be there as well, with rhythmic motions of the eyes while chewing. So, rhythmic motion of eye muscles while chewing is Whipple's disease, Trophaemia whipplei. And for diagnosis is actually a duodenal biopsy. And then you can do the periodic acid shift, the PAS, positive, for macrophages and non-acid fast bacilli and dilation of lacteals. So just a few things for Whipple's disease. You want to think about farmers, somebody who's a farmer, as well as malabsorption, arthritis, non-deforming arthritis, as well as those neurologic symptoms, which are the rhythmic motion of the eyes, of the eye muscles while chewing, and you do a duodenal biopsy, and the treatment is penicillin. Okay, so now we'll move to the metabolic disorders. So starting off with the metabolic disorders is G6PD deficiency. G6PD deficiency is an X-linked recessive enzymatic disorder of red blood cells that may cause episodic hemolytic anemia. So the risk factors for G6PD are primarily males, as it's X-linked recessive, so only males can get it, kind of like muscular dystrophy. And it's 10 to 15% of African American males, importantly, Mediterranean, African, etc. So the pathophysiology, G6PD normally catalyzes NADP to NADPH, which protects red blood cells from oxidative injury. So in G6PD deficiency, a decreased G6PD activity during oxidative stress results in an oxidative form of hemoglobin, which is methemoglobin. The denatured hemoglobin precipitates as Heinz bodies. So oxygenation results in the denaturing, and then you have the Heinz bodies. So it's really having to do with the glutathione antioxidant is lost, and so they're more susceptible to injury. So I had a question on the mechanism of action. So it's a decrease in glutathione antioxidation, which is lost and leads to the susceptibility to the injury to the red blood cells, in which again we get those Heinz bodies. And so the red blood cell, so going over it one more time, the red blood cell membrane damage and fragility causes an extravascular red blood cell destruction, hemolysis, by reticuloendothelial macrophages in the spleen, marrow, liver, as well as an intravascular hemolysis, so it's both. So some exacerbating factors are important to know for G6PD deficiency. Infection is the most common cause, such as the DKA and also fava beans, broad beans. Medications, how I remember them, is DNP, dapsone, nitrofurantoin, and pyrazinamide, or primaquine as well. So medications, dapsone, primaquine, methylene blue, nitrofurantoin, phenazopyridine as well. So DNP, dapsone, nitrofurantoin, and primaquine. Most patients are asymptomatic until times of the oxidative stress take place, and an episodic hemolytic anemia can occur for 2 to 4 days after the exposure. This will result in back or abdominal pain, symptoms of anemia or jaundice, indirect bilirubin, and dark urine. They may have a transient splenomegaly, and acute renal failure may occur in severe cases. Neonatal jaundice as well, if they have this when they're young. So the diagnosis of G6PD is on peripheral smear. You'll see a normocytic hemolytic anemia only during the crisis itself. Schistocytes, which are bite cells or fragmented cells, plus positive Heinz bodies. So bite cells and Heinz bodies. Smear is usually normal when not in the acute stage, however. So I remember G6PD, they have the two food-relating things, so bite and Heinz. Hemolytic anemia, they're increased reticulocytes, increased indirect bilirubin before the liver, and decreased haptoglobin as well. So you can do an enzyme assay for diagnosis of G6PD, which will show fluorescent spot test and DNA testing, but just for diagnosis overall, the peripheral smear is your go-to. For management, it's usually self-limited, and you want to avoid the offending food and drugs and treat the underlying infection as well, if there is one. For severe anemia, do some iron and folic acid supplementation and blood transfusions if severe. And for neonatal jaundice, phototherapy and Paget's disease of the bone, osteitis deformans, is next. So Paget's disease of the bone is an abnormal bone remodeling seen in aging bone to increased osteoclastic bone resorption and increased osteoblastic bone formation. This leads to larger, weaker bones. Risk factors are persons of Western European descent, and 40% are autosomal dominant. Clinical manifestations mostly asymptomatic, over 70%, and it's often found incidentally on radiographs or because an incidentally high alk phos is seen on routine lab testing. So importantly, a high alkaline phosphatase. Bone pain is a common symptom, and you may see some bowing deformities. Skull enlargement may also be seen, with deafness as well, due to bony compression of cranial nerve 8. For diagnosis, you want to get labs. Often an isolated, markedly elevated alkaline phosphatase is the first sign. You may also have a normal calcium, phosphate, and parathyroid hormones, and an increased urinary pyridine and N-telopeptide. For radiographs, there's a few different phases. First, the lytic phase, which is blades of grass or flame-shaped lucency. Sclerotic phase, which is increased trabecular markings. And for skull radiographs, classically, will show the important cotton wool appearance. Cotton wool appearance for Paget's disease of the bone. This is sclerotic patches that are poorly defined and fluffy as a result of thickened, disorganized trabeculae, which leads to sclerosis in previously lucent bone. Management of Paget's is asymptomatic, don't need treatment, but bisphosphonates are the first-line medical management. So remember, bisphosphonates for Paget's disease and also vitamin D and calcium supplementation are usually given to prevent hypocalcemia during bisphosphonate treatment. So bisphosphonate inhibits those osteoclasts that are breaking down the bone. Normalization of ALK-Phos levels indicate a response to treatment. You can also give NSAIDs for the pain and calcitonin as well. So to go more into bisphosphonates are newer nitrogen-containing bisphosphonates. They're used IV, like zoledronic acid, pamindronate, and zolendronate have greater efficacy than others in severe Paget's disease. So they can also be taken orally, but the ones that are taken orally are the common ones, alendronate and risendronate. They're indicated as first line for osteoporosis and Paget's disease of the bone, and the mechanism, like we said, is inhibiting osteoclast activity, decreasing bone resumption and turnover. Alendronate and risendronate inhibit both osteoclast and osteoblast activity as well. So some considerations which are important with bisphosphonates are taking 8 ounces of plain water as well as 1 to 2 hours before meals, a minimum of 30 minutes, and they have poor oral absorption. So we want to look out for that esophagitis as an adverse effect, especially alendronate. So we want them to stay upright for at least 30 minutes after they have this. So esophagitis as a side effect, and you want to also add calcium and vitamin D supplementation alongside the bisphosphonates. So also a rare but notable adverse effect are atypical femur fractures and osteonecrosis of the jaw with bisphosphonates. And contraindications for oral bisphosphonates are esophageal disorders, also certain bypass procedures. Chronic kidney disease is a contraindication for both oral and IV, and alendronate is contraindicated if esophageal stricture, dysphagia, or a hiatal hernia is present. Next will be PKU, or phenylketonuria. Phenylketonuria is an autosomal recessive disorder of amino acid metabolism associated with phenylketone neurotoxicity due to the accumulation of phenylalanine in the urine and blood. So we can't detox it, so we have an increase in phenylketones, which are neurotoxic. So neurotoxicity is irreversible if it's not detected by 3 years of age. Clinical manifestations are typically present after birth with vomiting, mental delays, irritability, convulsions, eczema, increased DTRs, intellectual disability, in children of blonde, blue-eyed with fair skin as well. Increased serum phenylalanine, and also a urine with a musty or mousy odor from phenylacetic acid. Newborns are always routinely screened for this in the US, and it can be monitored during pregnancy as well. Lifetime dietary restriction is the management of phenylalanine, so you want to restrict phenylalanine and increase the tyrosine supplementation. So phenylalanine levels are followed at regular intervals in neonates and less often in older children and adults. Some adults, however, show improvement in behavior, symptoms, and sequelae when treated with phenylalanine-restricted diets. And of course, avoid foods high in phenylalanine like milk, cheese, nuts, fish, chicken, meats, eggs, legumes, aspartame found in sodas. Aspartame. So vitamin C, ascorbic acid deficiency is next. Risk factors of vitamin C deficiency are a diet that lacks raw citrus fruits and veggies. Excess heat denatures the vitamin C. Also those who smoke, have illicit drug use, alcoholism, malnourished individuals and elderly, and symptoms can occur after 3 months of deficiency intake. So that's about the same time as folic acid as well, and B12 takes years as well. So the 3 H's of scurvy are important to know, which is vitamin C deficiency: hyperkeratosis, hemorrhage, and hematologic. So hyperkeratosis is hyperkeratotic follicular papules surrounded by hemorrhage. For hemorrhage, we have vascular fragility due to abnormal collagen production, with recurrent hemorrhages in the gums, importantly, skin, perifollicular, and joints, and impaired wound healing. And also the hematologic abnormalities, anemia, glossitis, increased bleeding time. So hyperkeratosis, hemorrhage, and hematologic for scurvy. For diagnosis, serum ascorbic acid levels and ascorbic acid repletion is the treatment. Generalized symptoms improve within days of treatment. Next will be vitamin D deficiency. This is a low bone turnover plus decreased osteoid mineralization, osteomalacia, or cartilage at the epiphyseal plates, which is rickets. So this is in contrast to osteoporosis, where the mineral and matrix loss is proportional. So osteomalacia, the etiologies are severe vitamin D deficiency most commonly. This leads to decreased serum calcium and phosphate, with subsequent demineralization of the bone, osteoid only. So it becomes soft bones, so osteomalacia is soft bones. Malabsorption can also occur due to chronic liver or kidney disease, gastric bypass, or celiac sprue. And disease in children is equal to rickets, and adults is osteomalacia. So severe vitamin D deficiency is rickets in children, and adults it's osteomalacia. Clinical manifestations are diffuse bone pain and tenderness, muscular weakness as well, proximally. Hip pain may cause an antalgic waddling gait, so that's pain with walking. Bowing of the long bones is important to note, and symptoms of hypocalcemia. Diagnosis: classically, you'll have a decreased calcium, decreased phosphate, and decreased 25-hydroxyvitamin D levels, increased alk-phos and PTH, and radiographs will show classic looser lines or zones, which are transverse pseudo-fracture lines. This is narrowing of the radiolucent lines from visible osteoid. Vitamin D supplementation is first line, ergocalciferol. For rickets, rickets is low bone turnover and decreased osteoid mineralization, osteomalacia, and or cartilage at the growth plates. So growth plates are only in kids, so rickets is in kids. Vitamin D deficiency is most commonly seen between 3 months and 3 years when growth or calcium needs are high and decreased sunlight exposure, such as prolonged breastfeeding without vitamin D supplementation. So the etiologies of rickets are calcipenic or phosphopenic. So calcipenic is calcium deficiency or vitamin D deficiency, including dietary deficiency, celiac, cystic fibrosis, or excessive bowel resection as well. It could also be phosphopenic, which is due to renal phosphate wasting, and an example of this is Fanconi syndrome. Clinical manifestations of rickets are delayed fontanelle closure, growth delays, delayed dentition, and genu varum, which is lateral bowing of the femur and tibia. For diagnosis, depends on the cause, but classic labs are a decreased calcium, phosphate, 25-hydroxyvitamin D levels, which are incalcipenic especially, and you will also have an increased alk-phos and PTH in response to that hypocalcemia. Radiographs show a widening of the epiphyseal plate, costochondral junction enlargement, which is the classic rachitic rosary, and also long bones appearing to have a less distinct fuzzy cortex. For management, vitamin D supplementation is first line, ergocalciferol again. For vitamin A function, vitamin A function is vision, immune function, embryo development, hematopoiesis, skin, cellular health as well, due to epithelial cell differentiation. So most common sources of vitamin A are kidneys, liver, egg yolk, butter, green leafy vegetables, carrots. Vitamin A excess leads to acute and chronic toxicity. So vitamin A excess, if we remember, is common for idiopathic intracranial hypertension or pseudotumor cerebri, and you never give it in pregnancy as well. So this can lead to teratogenicity. So two important things for vitamin A excess are increase in idiopathic intracranial hypertension, pseudotumor cerebri, and teratogenicity, as no vitamin A should be given in pregnancy. Vitamin A deficiency, on the other hand, some deficiency risk factors are liver disease, alcoholics, also fat-free diets, because it's a fat-soluble vitamin, A, D, E, and K, and fat malabsorption like in cystic fibrosis, Crohn's, ileitis, short bowel syndrome, or bariatric surgery. Clinical manifestations of the vitamin A deficiency are primarily visual changes, such as especially night blindness, importantly, and also sometimes retinopathy, impaired immunity due to poor wound healing and frequent infections, and also dry skin. You could also have squamous metaplasia, conjunctiva, respiratory epithelium in the urinary tract, and Biot's spots. So Biot's spots are white spots on the conjunctiva due to squamous metaplasia of the corneal epithelium, importantly. For diagnosis, it's clinical, and you can get a serum retinol level as well. Next, for a vitamin B deficiency, such as riboflavin, which is B2. So riboflavin is vitamin B2 deficiency. And you have OGO again. So that's oral, genital, and ocular syndromes. So Behçet's syndrome also has OGO. But for riboflavin B2 deficiency, there's oral, ocular, and genital. And for oral, you have lesions of the mouth and classically magenta colored tongue, glossitis, angular cheilitis, stomatitis, etc. For ocular, some photophobia and corneal lesions, and genital scrotal dermatitis. So the OGO is common in Behçet's as well as B2 riboflavin deficiency, and that's OGO is oral, genital, and ocular. Next will be thiamine or B1 deficiency. Thiamine B1 deficiency is caused by chronic alcoholism most commonly, and also weight loss surgery. So this is the different beriberi. So we have dry and wet beriberi in thiamine B1 deficiency. So dry beriberi is nervous system changes. This is symmetric peripheral neuropathy and paresthesias, sensory and motor neurons. And wet beriberi, on the other hand, is high output heart failure and also dilated cardiomyopathy. So wet beriberi, high output heart failure and dilated cardiomyopathy, and dry is CNS changes. Also, we know Wernicke's encephalopathy, triad of ataxia, difficulty walking and balance, as well as global confusion, and ophthalmoplegia, paralysis or abnormalities of the ocular muscles. And it's considered a neurologic emergency, and it's most common in chronic alcoholics, which is why we give an infusion of thiamine B1 in IV fluid when they're having alcohol withdrawal or just to alcoholics who present. So that's Wernicke's encephalopathy. And there's also Korsakoff dementia. Korsakoff dementia is memory loss, especially short-term, and confabulations. This is irreversible, and it's more of a chronic condition as a consequence of Wernicke's encephalopathy. And the treatment for all of these is IV thiamine followed by oral thiamine. So just to run through them one more time, most common for B1 deficiency is chronic alcoholism. They have dry beriberi, which is nervous system changes, peripheral neuropathies. Wet beriberi, which is the dilated cardio and the high output heart failure. There's Wernicke's, which is more common in chronic alcoholics and has the triad of ataxia, confusion, and ophthalmoplegia. And also the Korsakoff dementia, which is especially short-term and confabulations and irreversible. So next will be niacin or nicotinic acid, which is B3 deficiency. So some of the sources of B3 or niacin/nicotinic acid are especially meats, grains, and legumes. So the etiologies are often due to a diet high in untreated corn, which lacks niacin and tryptophan. So diets which lack tryptophan are also common in alcoholics, anorexia, and malabsorption. So for niacin deficiency, it's a lack of tryptophan, which is important. And carcinoid syndrome can lead to this as well due to increased tryptophan metabolism due to the production of serotonin. So if we think about it, when we take niacin, we're worried about that flush as well, which of course can be decreased with NSAIDs, but in carcinoid syndrome, we also have that flushing as well. So it kind of makes sense that in carcinoid syndrome, we're using up all that tryptophan, therefore leading to a niacin deficiency. And we can remember that because the niacin has the flushing and so does carcinoid syndrome. And also Hartnup disease. Hartnup disease is decreased tryptophan absorption in the kidneys and small intestines. And classically for niacin B3 deficiency, we have three things to remember. The 3 Ds, dermatitis, diarrhea, and dementia. This is pellagra. So vitamin B3 deficiency, niacin, pellagra, dermatitis, diarrhea, and dementia. Pyridoxine is next, which is a B6 deficiency. Pyridoxine B6 deficiency, most common causes, again, chronic alcoholism, but also isoniazid, penicillamine. If we remember for Wilson's disease, we gave penicillamine, but we also added B6 to it. So isoniazid, penicillamine, hydralazine, levodopa, carbidopa, oral contraceptives. So pyridoxine B6 deficiency, most commonly though, we can see here it's highlighted as chronic alcoholism, isoniazid, and penicillamine. Manifestations are neurologic with peripheral neuropathy, classic but rare, and also stomatitis, cheilitis, glossitis, and anemia as well. Next, for another B12, for another B deficiency, and this is B12, which is cobalamin deficiency. So B12 has a lot more that we need to know about it. Sources of B12 are naturally contained in many animal products, such as meat, eggs, and dairy. And absorption of B12 is released by the acidity of the stomach and combines with intrinsic factor secreted by the parietal cells, where it is absorbed mainly in the distal ileum. So it needs to travel all the way to the distal ileum. So that's why we're going to have a problem with patients with Crohn's, because Crohn's commonly affects the distal ileum. So etiologies of the B12 deficiency, also known as cobalamin, are decreased absorption, of course, and also decreased intake. So for decreased absorption of B12, pernicious anemia is the most common cause. And again, this is lack of intrinsic factor due to parietal cell antibodies, so it is autoimmune, leading to gastric atrophy. Crohn's disease, like we said, as well, affecting the terminal ileum. Also ileal resection, some gastric bypasses surgery, gastritis, achlorhydria, tropical sprue, Zollinger-Ellison, and especially chronic alcohol use as well. Some meds can also lead to it, H2 blockers and PPIs like we mentioned earlier with the treatment of peptic ulcer, also decreased nucleic acid synthesis, and metformin, importantly, anticonvulsants, and fish tapeworm. So decreased intake would be vegans due to lack of consumption of meat or dairy products in which these are found. Clinical manifestations of B12 deficiency are anemia, especially symptoms similar to folate deficiency but associated with neurologic abnormalities. So we tend to see that MCV, the macrocytic anemia, of over 100 femtoliters. Typical is like 80 to 90. So folic acid deficiency can also be concomitant, but it's not associated with neurologic abnormalities like a B12 deficiency is. So we can also see hematologic abnormalities, epithelial abnormalities, and importantly, neurologic symptoms. So B12 neurologic symptoms are symmetric paresthesias, most common initial symptom, especially involving the legs, lateral and posterior spinal cord demyelination and degeneration, ataxia, weakness, vibratory and sensory and proprioception deficits, decreased DTRs, hypotonia, a positive Babinski, seizures, and psychosis. So all neurosymptoms for B12. For diagnosis, you want to do a CBC with peripheral smear, which will show increased MCV, macrocytic anemia, plus megaloblastic anemia. Megaloblastic anemia is a hypersegmented neutrophil as well as macroovalocytes, plus a mild leukopenia and thrombocytopenia and low reticulocytes. So most importantly is the increased MCV in the hypersegmented neutrophils with macroovalocytes. We can also diagnose it with a decreased serum B12 level, an increased LDH, an increased homocysteine, and an increased MMA, methylmalonic acid, which distinguishes B12 from folate. So both B12 and folate will have an increased homocysteine, but only B12 has the increased methylmalonic acid. So how I remember that is it says B12, so B12, so it has both things, methylmalonic acid and homocysteine elevated, whereas folate just has one. So management of the B12, we want to do B12 replacement, of course, and the routes of administration are oral, sublingual, etc. In symptoms of anemia or neurofindings, we want to start with an IM B12 shot. So in the adults, IM cyanocobalamin injection weekly until the deficiency is corrected, and then once monthly. They can be switched to oral therapy after the resolution of neurosymptoms as well. In patients with pernicious anemia, they may need lifelong monthly intramuscular therapy. But if it is dietary, and you'll find this out through the Schilling's test, you can do an oral B12 supplementation. So next we'll move to acute pancreatitis. So acute pancreatitis. This is acinar cell injury, intracellular activation of pancreatic enzymes leading to an autodigestion of the pancreas itself. So etiologies of acute pancreatitis are gallstones most commonly, and second most common is alcohol abuse. Gallstones are the most common at 40% and alcohol is at 35%. Also some medications can cause it, like thiazides, protease inhibitors, estrogens, and exenatide, which is a GLP, also valproic acid. Others can be iatrogenically through ERCP, also malignancy, scorpion stings, idiopathic trauma, cystic fibrosis, hypertriglyceridemia, although it has to be over 600, for hypertriglyceridemia to cause it. Also hypercalcemia and infection, abdominal trauma or mumps as well. So that's a lot of different causes for acute pancreatitis. For clinical manifestations, we'll see epigastric pain. This is constant boring pain, like boring a hole in your epigastrum, that often radiates to the back or other quadrant. And remember, pain is exacerbated if they're supine, as well as with eating, as it tries to pump out the lipase and amylase, and also relieved by leaning forward, sitting, or the fetal position as well. They'll have nausea, vomiting, and fever, and shock in severe cases. On physical exam, they'll have some epigastric tenderness and tachycardia. Decreased bowel sounds may be secondary to an adynamic ileus, and dehydration or shock if severe. So it's important to know necrotizing or hemorrhagic pancreatitis will show Cullen's sign, which is the periumbilical ecchymosis, as well as Gray-Turner sign, which is flank ecchymosis, and perineal ecchymosis is called Fox sign. For the diagnostic criteria of acute pancreatitis, the diagnosis of acute pancreatitis requires the presence of two of the following three criteria. It can be an onset acutely of persistent epigastric pain, severe pain, often radiating to the back, or elevation in serum lipase or amylase 3 times the upper limit of normal, or characteristic findings of acute pancreatitis on imaging, CT, MRI, ultrasound. No imaging, however, is required if the patient meets the first 2 criteria, so they need 2 of those 3 to make a clinical diagnosis of it. For diagnostic labs, there's many things we can get. They'll have an increased amylase and lipase, which are the best initial tests. It's important to know lipase is more specific than amylase, and levels don't equal severity as well. It's not really specific for that. An ALT with a 3-fold increase is also highly suggestive of gallstone pancreatitis, as there's probably a blockage. And if the blockage is in the pancreas as it connects to the common bile duct, it's going to cause the acute pancreatitis, and the bile is going to back up to the liver, so that's why we see the increased ALT as well. So hypocalcemia we could see as well in acute pancreatitis, and this will be necrotic fat binding to calcium, lowering the serum calcium levels. It's also called saponification. Leukocytosis, elevated glucose, bilirubins, and triglycerides. For diagnostic imaging, we want to get an abdominal CT, which is the diagnostic imaging of choice. It's also recommended in patients who fail to improve or worsen after 48 hours of management to assess the extent of necrosis. You could also do an MRI. Transabdominal ultrasound is recommended to assess for gallstones if you suspect gallstone pancreatitis and bile duct dilation. Abdominal radiograph, we have some classic signs to note. For abdominal radiograph, we could see the sentinel loop, which is a localized ileus of a segment of small bowel in the left upper quadrant. We could also see, so the sentinel loop again, it's basically an obstruction near the pancreas, and it's radiating in inflammation. So the inflammation from the pancreas actually cuts off the area and leads to that localized ileus. So we could also have the colon cutoff sign, which is an abrupt collapse of the colon near the pancreas, and this is near the splenic flexure area. So it pushes that area, and we'll see on radiographs the colon cutoff sign. Pancreatic calcification is suggestive of chronic pancreatitis as well. That's pancreatic calcification is chronic pancreatitis. You could do an MRCP, which is useful to detect stones, a stricture, or a tumor. And for chest radiograph, left-sided exudative pleural effusion in moderate to severe cases. So for management of acute pancreatitis, 90% will actually recover without complications in 3 to 7 days and require supportive measures only. So, quote unquote, rest the pancreas. So you want to be supportive with NPO, high volume IV fluid resuscitation, use lactated ringers, which is preferred. It's associated with a decrease in systemic inflammatory response as compared to normal saline, and also analgesia, meperidine. So it used to be thought that meperidine decreases spasm of the sphincter of Oddi, so that's why I use meperidine. Antibiotics are not routinely used, but if it is severe infected pancreatic necrosis, which could be over 30% necrosis on CT or MRI, you want to do broad spectrum antibiotics like imipenem may be used. So that's imipenem in a very bad infected pancreatic necrosis of acute pancreatitis. So it's important to know the Ranson's criteria. This is used to determine the prognosis of these patients. So we can also do the Apache score too. But for the Ranson's criteria, I'll just mention some of the different admission criteria and what they should be in 48 hours. I won't go over the specific numbers though. So involved in the admission criteria for Ranson's is glucose, age, LDH, AST, and white blood cells. And within the first 48 hours, you also want to get calcium, hematocrit falling, greater than 10%, oxygen, BUN, a base deficit, and sequestration of fluid. So if the score is over 3, severe pancreatitis is likely. If it's under 3, severe pancreatitis is unlikely. And also a mnemonic that I came across for the causes of acute pancreatitis I'll mention is I get smashed. So I, iatrogenic, G, gallstones, E, ETOH, T, trauma, S, scorpion sting, M, mumps, A, autoimmune, S, steroids, H, hypercalcemia or hypertriglyceridemia, E, iatrogenic through ERCP, and D, drugs like GLPs, diuretics, and HIV drugs like the protease inhibitors. So now we'll move to chronic pancreatitis. So chronic pancreatitis is progressive inflammatory changes to the pancreas that lead to loss of pancreatic endocrine and exocrine function. The etiologies are similar, except alcohol is the most common for chronic pancreatitis, whereas gallstones were the most common for acute. So etiologies of chronic are alcohol most common, which is 70%, also idiopathic, hypocalcemia, hyperlipids, and the rest of the causes like we said. Clinical manifestations are a triad, a classic triad of calcifications due to the decrease, so we also know that the decreased hypocalcemia, and steatorrhea. So remember, the decreased calcium is due to that saponification process forming the calcifications. So triad of calcifications, steatorrhea, and diabetes is hallmark, but only seen in 1/3 of patients with chronic pancreatitis. We also see weight loss, continuous epigastric pain, may be atypical or completely absent. Diagnosis of chronic will be amylase and lipase, usually normal or some mild elevation. On CT, we'll see the classic calcification of the pancreas, and it's often done in patients with acute pain to rule out other causes of abdominal pain. Abdominal radiographs will see, again, the calcified pancreas, and on endoscopic ultrasound or MRCP, and for pancreatic function testing, we can see fecal elastase as the most sensitive and specific. So for chronic pancreatitis, fecal elastase, the most sensitive and specific. We can also do a pancreatic stimulation with secretin or CCK, which is not usually done, however. So management is alcohol abstinence, pain control, low-fat diet, also vitamin supplementation. Remember, we're lacking that lipase function, so we need to give the fat-soluble vitamins A, D, E, and K. So oral pancreatic enzyme replacement can be done, and pancreatectomy only if retractable pain despite medical therapy. Next will be a pancreatic carcinoma. So pancreatic carcinoma, 70% are found in the head of the pancreas, 20% in the body, and 10% in the tail of the pancreas. Types, adenocarcinoma or ductal carcinoma is the most common cause, 90% of them, or islet cell carcinoma, 5 to 10%. Ampullary and duodenal carcinomas, cystadenomas, and cystocarcinomas also, but that adenocarcinoma is most common in the head of the pancreas. Risk factors: smoking is the biggest risk factor, as well as age, over 55 years of age. Also patients with chronic pancreatitis, diabetes, males, and obesity. For clinical manifestations of pancreatic carcinoma, it usually presents later in the disease course, so it's tough to detect, but METs are often usually present when it does present. Regional lymph nodes as well as the liver are the most common metastases. Painless jaundice is classic, and weight loss. Painless jaundice due to that common bile duct obstruction, and weight loss, importantly, from that malabsorption, as well as it is a cancer. So that's important, painless jaundice. So I believe that's called the Courvoisier sign, painless, or no, rather, well, Courvoisier sign will be here, and that's a palpable, non-tender, painless gallbladder that is distended, but they will have a painless jaundice as well. So continuing with clinical manifestations, abdominal pain radiating to the back may be relieved with sitting up and leaning forward. Tumors in the body or tail produce symptoms later than in the head, so it's usually more advanced at the start of diagnosis. Also, they may have a new onset diabetes or depression. Pruritus due to the increased bile salt in the skin. Anorexia, acolic stools and dark urine due to the common bile duct obstruction. Physical exam, we have a couple classic signs, some we already mentioned. The Courvoisier's sign, which is a palpable, non-tender, not painful, distended gallbladder due to the common bile duct obstruction, especially if the head of the pancreas is involved. We also have Trousseau's sign. This is a different sign from the hypocalcemic Trousseau's sign. Trousseau's sign is a Trousseau's malignancy sign, which is a migratory phlebitis associated with the malignancy. However, it is nonspecific. For diagnosis of pancreatic carcinoma, we want to do CT as the initial test of choice. If the CT is negative, we can do an endoscopic ultrasound with biopsy of the pancreatic lesion. If the CT is positive, then we want to do, for next step, a simultaneous surgical removal and biopsy. Tumor markers, classically, CA19-9 is often used to monitor after treatment, and sometimes CEA, although CEA is more colon and gastric cancer. For management, surgical procedure is called the Whipple procedure, which is a pancreaticoduodenectomy if confined to the head or the duodenal area. Also, the tail will lead to distal resection, and you can do also post-op chemo with 5-fluorouracil as well. If it's advanced or inoperable, you can do an ERCP with stent as a palliative measure for intractable itching. And the prognosis is pretty poor for pancreatic carcinoma. Only 20% are resectable even at the time of diagnosis, and overall 5-year survival rate is only 5 to 15%. It's the 4th leading cause of cancer-related deaths in the US. Next will be Meckel's or ileal diverticulum. This is a persistent portion of the embryonic vitelline duct, the yolk sac, or ophthalmo-mesenteric duct, in the small intestine. It's the most common congenital anomaly of the GI tract, and it has the classic rule of twos, in which it's in 2% of the population within 2 feet of the ileocecal valve. 2% are symptomatic. It's 2 inches in length. There's 2 types of ectopic tissue, which gastric is the most common, can also be pancreatic. And it's 2 years, most common age at clinical presentation, and 2 times more common in males. The pathophys is ectopic gastric or pancreatic tissue that may secrete digestive hormones leading to bleeding. Clinical manifestations usually asymptomatic, often incidental finding, or painless rectal bleeding or ulceration. If present, the pain is usually periumbilical. It may cause intussusception, volvulus or obstruction, or may cause diverticulitis in adults. For diagnosis, you want to do a Meckel scan. This looks for ectopic gastric tissue in the ileal area, and mesenteric and arteriography or abdominal exploration can also be done. Management is surgical excision if it is symptomatic. So next will be duodenal atresia. Duodenal atresia is a complete block or closure of a portion of the duodenum leading to a gastric outlet obstruction. Risk factors are importantly polyhydramnios, which is an increased amniotic fluid, and Down syndrome. So it's like the body's protective mechanism against the increased amniotic fluid pressing inside of the esophagus. And also, don't forget Down syndrome for duodenal atresia. It's associated also with other congenital defects. The manifestations are neonatal intestinal obstruction shortly after birth, within the first 24 to 36 hours, with bilious vomiting. It also may be non-bilious, but bilious vomiting and abdominal distension. So it's the first day of life. Diagnosis, abdominal radiographs will show the classic double bubble sign. The double bubble sign is distended air-filled stomach and a smaller distended duodenum separated by the pyloric valve. So the bubble is once the duodenum and it's separated at the pylorus between the stomach. Management is decompression of the GI tract, electrolyte and fluid replacement, and duodenostomy is the definitive management. Next will be volvulus. A volvulus is a twisting of any part of the bowel at its mesenteric attachment site. A volvulus most commonly involves a sigmoid, but also the cecum in older adults, and the midgut and ileum are common in children. So complications are obstruction and impaired vascular supply to the affected area. And for manifestations, obstruction leads to crampy abdominal pain, distension, nausea, vomiting, constipation. Also tympanitic abdomen with a tenderness to palpation. Impaired vascular supply, fever, tachyperitonitis, etc. For neonates, they'll have bilious vomiting within the first week of life and colicky pain. On abdominal CT, which is the diagnostic test of choice, you'll see a dilated sigmoid colon and a bird beak appearance at the site of the volvulus. So bird beak appearance at the site of the volvulus, which we also see in achalasia, but this is much different here. So dilated sigmoid colon and bird beak appearance at the site of the volvulus with abdominal CT. Abdominal radiograph, you'll see a bent inner tube or a coffee bean sign on radiograph. This is a U-shaped appearance of the air-filled closed loop of distended colon with a loss of the haustral markings. On contrast enema, we can also see the bird's beak appearance, where the proximal and distal bowel rotate to form the volvulus. It's not indicated if the peritonitis is present, however. For management of the volvulus, we want to do endoscopic decompression with a proctosigmoidoscopy as the initial treatment of choice, and often a rectal tube is left in place to decrease the acute recurrence and decrease distension. So it can recur quite often. Oh, and decompression, often followed by elective surgery, is due to the high rate of recurrence. And immediate surgical correction in patients with peritonitis, gangrene, or endoscopic decompression that's unsuccessful. So it also includes sigmoid resection with primary anastomosis or Hartmann's procedure. So again, for the abdominal radiograph, we have the bent inner tube or coffee bean sign. And again, that's the U-shaped appearance of air-filled closed loop of the distended colon with a loss of the haustral markings. So next will be small bowel obstruction. This is partial or complete mechanical blockage of the small intestine. The etiology is most common and most importantly is post-surgical adhesions for small bowel obstruction, most common cause. Also incarcerated hernias as the second most common. Crohn's can also cause it, malignancy and intussusception. Malignancy is the most common cause of large bowel obstruction. So different there. So there's a few different types. It could be a closed loop versus an open loop. So in the closed loop SBO, the lumen is occluded at 2 points, which can reduce the blood supply, causing strangulation, necrosis, and peritonitis. It could also be complete versus partial. So with complete, the patient usually has severe obstipation, so the gas is blocked. They're unable to have a bowel movement or pass gas. Distal versus partial. Distal presents with more abdominal pain and less vomiting. And for clinical manifestations, we have the 4 hallmark symptoms called CAVO, C-A-V-O, in SBO, small bowel obstruction. So we have the crampy abdominal pain, we have abdominal distension, we have vomiting, and obstipation, which is no flatus, usually in the late stage. So SBO is CAVO, crampy abdominal pain, abdominal distension, vomiting, and obstipation. And obstipation is important as we differentiate it from other conditions similar. So on physical exam, abdominal distension and bowel sounds are high-pitched tinkles on auscultation and visible peristalsis, early obstruction. Hypoactive bowel sounds heard in late obstruction. So in early obstruction, it's kind of like the stomach is trying to contract past the obstruction, but it can't. So we hear increased bowel sounds and high-pitched tinkles on auscultation with the visible peristalsis, but later it's almost like the bowel tires out and it doesn't even try to continue to push past the obstruction, so we have hypoactive bowel sounds later in the obstruction. So for diagnosis, abdominal radiographs will have the classic multiple air fluid levels in a step ladder appearance, dilated bowel loops, also minimal gas in the colon if complete. For a CT scan, we have a transition zone from dilated loop of bowel with contrast to an area of bowel with no contrast. So one more time for the radiographs, for SBO, we have the multiple air fluid levels in a step ladder appearance and dilated bowel loops. For management, non-strangulated SBO want to be NPO, bowel rest, IV fluids, as well as bowel decompression with NG suction, if severe. Strangulated, we want to go to direct surgical intervention. So next will be a splenic rupture or laceration. The spleen is the most common organ injured during trauma. The liver is the most common cause of bleeding. It's associated with a left side rib fracture as well, blunt abdominal trauma, infectious mononucleosis due to EBV. Clinical manifestations of a splenic rupture or lac may have abdominal pain, may have signs of hypotension and shock. Also classic, the Kerr sign. The Kerr sign is referred left shoulder pain due to irritation of the diaphragm and the phrenic nerve. So you might get it confused with Bowes sign, but Bowes sign is the right shoulder pain around the scapula, and that's due to the gallbladder irritating the phrenic nerve. But here for the spleen, of course, on the left side is the Kerr sign. Diagnosis is the fast abdominal exam, the focused sonography and trauma. CT scan shows the extent of the injury and exploratory laparotomy. For management incomplete, we could do endovascular embolization, but if it is a complete or intractable bleeding, we could do splenectomy. Next will be, in comparison to SBO, a paralytic adynamic ileus. So a paralytic adynamic ileus is decreased peristalsis without, importantly, without structural obstruction. This is a non-mechanical factor affecting and altering the normal coordination of the motor activity of the GI tract. So most commonly a post-op state. Medications such as opiates, importantly, also could be metabolic, such as hypokalemia or hypercalcemia. Severe medical illness, metabolic, and hypothyroidism as well, or diabetes due to gastroparesis. Clinical manifestations are similar to an SBO with abdominal pain, nausea, vomiting, obstipation, abdominal distension, increased flatus, and inability to tolerate an oral diet. Decreased or absent bowel sounds, unlike an early SBO that classically has the high-pitched sounds, and there's also no peritoneal signs. Okay, so none of the bowel sounds, none of the bowel is contracting, so there's no sound, it's adynamic. And also in the SBO, which differentiates it, is the proximal area tries to override the obstruction, thus we have the high-pitched sounds for a while, then it stops. But here we have no sounds. For diagnosis of the adynamic ileus, for plain radiographs, we'll also see dilated loops of bowel with no transition zone, paucity of air in the colon and rectum. For labs, get a CBC, electrolytes, LFTs, amylase, lipase, and also a CT if you need further evaluation. So the management of a paralytic ileus is supportive, NPO or dietary restrictions, clear fluids with progression to a liquid diet, and of course electrolyte and fluid repletion. Also treat the underlying cause, whether it's medications like opioids or like metabolic, such as hypo-K, hypercalcemia, or hypothyroid or diabetes. And you can also do NG suction if moderate to persistent diarrhea, nausea and vomiting. Next will be intussusception. So intussusception is a telescoping or invagination of the intestinal segment into the adjoining distal intestinal lumen, leading to bowel obstruction. It's most commonly occurring at the ileocolic junction. It most commonly causes a bowel obstruction in children ages 6 months to 4 years of age. And risk factors, 2/3 are seen between 6 to 18 months of age, also males, and commonly seen after viral infections as well. Lead points are idiopathic is most common, Meckel's diverticulum, enlarged mesenteric lymph nodes, also the hyperplasia of Peyer's patches, which are basically the lymph or immune system cells in the wall of the small intestine. Also tumors and submucosal hematomas, foreign bodies. So some of the manifestations of intussusception are classically vomiting plus abdominal pain, plus the passage of blood per rectum, and this is the classic currant jelly stool. Currant jelly stool, so that's stool mixed with blood and mucus. And abdominal pain that is colicky in nature, so kind of off and on and severe. Physical exam, they'll have a sausage-shaped mass in the right upper quadrant, or hypochondrium plus emptiness in the right lower quadrant, and that's Dance's sign, due to the telescoping of the bowel. So one area will have more of an emptiness, and then you'll find a sausage-shaped mass in the other area, so that's that right upper quadrant. For ultrasound, for diagnosis, you want to do ultrasound, which is the best initial test. Then you'll have a donut or target sign. And on abdominal radiographs, there'll be lack of gas in the bowels. And it's both diagnostic and therapeutic, very importantly, to do an air or contrast enema. So air enema is more commonly used than barium enema, especially if peritonitis is present, and water-soluble contrast is preferred over barium as well. So for management, like we said, the intussusception reduction through pneumatic, air, or hydrostatic, saline or contrast, decompression, although air is usually preferred, and also we want to admit them for observation, importantly, for intussusception, as there's a 10% recurrence within 24 hours of treatment. And if it does recur, then you want to do surgical resection if refractory to that insulfation. And of course, fluid and electrolyte replacement is the most important initial step, followed by NG decompression. So fluid and electrolyte replacement, and then that pneumatic enema. Next will be Hirschsprung's disease. Hirschsprung's disease is a congenital megacolon due to the absence of ganglion cells, leading to a functional obstruction. The most common site is in the distal colon and rectum at 80%. Males, way more common than females at 4-to-1. Also Down syndrome and Chagas disease. Pathophys is a failure of complete neural crest migration, leading to an absence of enteric ganglion cells in Auerbach's and Mesner's plexuses. So it's a neural problem basically in the anus. This leads to a failure of relaxation of the aganglionic segment and subsequent functional obstruction. Neonatal intestinal obstruction for manifestations will see a meconium ileus, failure of meconium passage over 2 days in a full-term infant. They'll have some bilious vomiting as well as abdominal distension, and no stool in the rectal vault as well. This is a failure to thrive. Enterocolitis and chronic constipation in older children with milder disease. For diagnosis, contrast enema will show a transition zone, a caliber change between normal and affected bowel. It's also helpful for pre-surgical planning. An anorectal manometry can be used, and this can be used as a screening test. You'll have increased anal sphincter pressure and lack of relaxation of the internal sphincter with balloon rectal distension. Importantly, the definitive diagnosis for Hirschsprung's disease is a rectal biopsy. Rectal suction biopsy is usually performed with a full thickness biopsy, reserved if rectal suction biopsy is non-diagnostic. Abdominal radiographs can be gotten as well, decreased or absence of air in the rectum, and dilated bowel loops. And management is resection of the affected bowel area. So the last topic for the GI system is appendicitis. Appendicitis is an obstruction of the lumen of the appendix, resulting in inflammation and bacterial overgrowth. It's most common in 10 to 30-year-old patients, and appendicitis is the most common cause of acute abdomen in children from 12 to 18 years old. The etiologies most commonly are a fecalith and lymphoid hyperplasia as the two most common causes. Also inflammation, malignancy from a foreign body. Lymphoid hyperplasia is due to infection, most commonly caused in children. So the fecalith is more common for the older adults, and if it occurs in children, it's most likely lymphoid hyperplasia. The clinical manifestations are the classic presentation of anorexia, importantly, and periumbilical or epigastric pain, followed by right lower quadrant abdominal pain in 12 to 18 hours. Also nausea and vomiting. Vomiting usually occurs after the start of the pain. In patients with a rectocecal appendix, they may have an atypical pattern like diarrhea and a positive rectal or gynecologic exam. Appendix may also be pelvic, so there's different areas where the appendix could actually be. Appendiceal inflammation stimulates nerve fibers around T10 to T8, causing vague periumbilical pain. Once the parietal peritoneum becomes irritated, it radiates to the right lower quadrant. On physical exam, there'll be rebound tenderness, rigidity, and guarding. Also, rectocecal appendix may have atypical findings. Tests for appendicitis, importantly, highly tested, are the Rosving sign, which is right lower quadrant pain with left lower quadrant pain palpation. Also the obturator sign, right lower quadrant pain with internal and external hip rotation with the flexed knee. The patient's often supine when you do this. Psoas sign, the right lower quadrant pain with right hip flexion and extension, raising the leg against resistance. So you just want to activate the psoas muscle, which flexes the hip. McBurney's point tenderness, also classically, points 1/3 the distance from the anterior superior iliac spine to the navel. For imaging, in adults, CT scan is preferred imaging of choice, with ultrasound and MRI reserved for radiosensitive populations like pregnant or children. And in children, a surgical consult is often obtained prior to imaging to determine if imaging is even needed, depending on the risk. And management, of course, is appendectomy. Laparoscopic is preferred when it's possible. And that concludes the GI system of Pance Prep Pearls.